What we usually do is go around the horseshoe and introduce ourselves, even though we're virtual. Just a reminder to turn off your cell phone so you don't cost yourself $5. And we'll go from there. The format this time will be a presentation during which I hope everybody will collect their 2 most important questions. After the presentation's over, we'll go around and ask the questions around the horseshoe, and we'll defer to the presenter for answering whichever one seems most pertinent or important at the time, and saving the rest for any subsequent visits from folks as we have some more orientation sessions. So usually we would have occasions to ask the department questions every 6 to 9 months at best, and we're now looking at 10 months. So I understand there's probably likely to be a lot of questions. I just don't want to miss any of them. If we don't get to the questions, then please submit them by email to Anna or Aaron. They're used to collecting them and getting us answers, but they'll also frame subsequent sessions with folks. So let's quickly go around the horseshoe and introduce ourselves, starting with Representative Griffin. Good morning. Can we
Yeah.
Good morning.
Sorry. Good morning. My name is Abigail Griffin, and I represent House District 102, which is Glenburn, Levant, and Condescade.
Representative Connor.
Good morning. My name is Representative John Connor. I represent District 58 in part of Lewiston. Thank you.
I don't see Representative Craven yet, but Representative Madigan.
Good morning. I'm Representative Colleen Madigan. I represent House District 110, which is about half of Waterville and some of Oakland.
Representative Zager.
Morning, everyone. Thank you, Senator Claxton. Sam Zager, represent District 41, parts of Portland.
Representative Lemlin.
Hi there. I'm Michael Lemlin. I represent District 88, which is Chelsea, Whitefield, Jefferson, and half of Noblesboro.
Representative Perry.
Good morning. I'm Representative Van Perry. I represent House District 140, which includes Indian Township, Baileyville, Barron, Callis, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Representative Stover, are you ready to introduce yourself? Or I can come back to you. So why don't we go to Representative Javner?
I unmuted. I was able to do it.
Go ahead,
apologize.
Representative Stover.
Good morning. My name is Holly Stover. I represent House District 89, including the towns of Boothbay, Boothbay Harbor, Southport Edgecombe, Westport Island, and part of South Bristol.
Now, Representative Javner, thank you.
Good morning. I am Representative Kathy Javner, and I represent District 141, which is in the counties of Penobscot County and Washington County. That's it.
Representative Meyer.
Good morning, and thank you, Mr. Chair. I am Representative Michelle Meyer, serving Southern Maine's House District 2, which is Elliott, and parts of South Berwick and Kittery, and I am the House co-chair.
And I'm Ned Claxton, Senate District 20, which represents Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. We also have been recently joined by Representative Craven. Would you care to introduce yourself, please?
Thank you, Mr. Chair. Sorry for being a bit late. I'm Margaret Craven, and I represent District 59, which is part of Lewiston.
We are also joined by our analysts. So if you want to introduce yourself, Anna.
I'm going to defer to Senator Moore first.
Oh, I'm sorry. I'm not used to the horseshoe yet. Thank you. Senator Moore.
Thank you, Anna. Good morning. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, Sullivan, and Hancock County.
Thank you. As I said in our first session, I'll be making mistakes as fast as I can so I can correct them. Sorry about that, Senator. Now, thank you, Ms. Broom, for correcting me.
I'm Anna Broom. I'm one of the non-partisan staff at the Office of Policy and Legal Analysis. And just for a reminder, I'm not going to say this every time, but I just want to remind you that we do not advocate or take positions. We're non-partisan staff.
And Erin?
Good morning. My name is Erin Dooling. I am the other co-staff for the Health and Human Services Committee.
And we're also joined by Carrie Withy, although I don't see her image.
Good morning. Good morning. My name is Carrie Withy, and I am the clerk for the Health and Human Services Committee.
Analyst Lazur, you want to say hi?
Good morning. I am Luke Lazor. I am also one of the nonpartisan staff from the Office of Fiscal and Program Review.
And we have our distinguished guests today, the Commissioner, Department of Health and Human Services, Jean Lambrew, and we have Ms. Molly Bogart, who will be introducing the folks that we'll be hearing from. So unless there's something else pressing, I'd turn it over to Molly.
Great. Good morning. My name is Molly Bogart. I'm the Director of Government Relations for the department. It's good to see many returning faces, but I also look forward to getting to know those of you who are new to the committee. I will be your contact for DHHS across our offices and programs, and so don't hesitate ever to reach out to me if you have a question or a constituent issue or a bill you'd like to discuss. I'm more than happy to do that and get you the information that you need from our folks. So I look forward to working with you. And with that, I'll hand it over to Commissioner Lambrew.
Morning. Senator Claxton, Representative Meyer, members of the committee. My name is Jean Lambrew. I am the Commissioner of the Department of Health and Human Services, and I am here to introduce our Commissioner's office to you, as well as to provide a high-level overview of the presentations that you'll be hearing from all of our senior leaders in the coming days. I want to start by saying we look forward to the partnership that we're about to engage with during this session. It's going to be a lot of work, a lot of good work, and a lot of hard work. But I want to, as we look through this organization chart, introduce you to our team, because while I am always going to be at your service, I have really smart and committed people who work with me who will be able to be present, answer questions, etc. And that starts with my three deputies. Sarah Gagne-Holmes, Benjamin Mann, and Bethany Ham are the three deputies who can act in my place. We have a teamwork system so that there's always somebody else in the room with me. So they are true substitutes for me as needed. So if you have questions that Molly is going to bring one of them to you to answer, just know that they speak on my behalf. We also have 7 offices and 2 hospitals. You'll be hearing from all of these directors in the coming days: Aging and Disability Services, Maine CDC, Child and Family Services, Behavioral Health, Family Independence, Maine Care and Licensing and Certification, as well as Riverview and Dorothea Dix Psychiatric Centers. We also include here our advisors. Molly will be, again, your point person. If I don't have enough right arms to say she's my right arm, because I have so many right arms these days, but Molly will be able to be your conduit, your person to go get information from us. She'll be the most efficient and effective person for your committee. But we also have a communications director in Jackie Farwell, director of diversity, equity, inclusion, Liana Ameyes, 2 clinical advisors, Lisa Letourneau, who mostly deals with health system change, Amy Blisle, who is our chief child health officer, as well as a senior advisor for coverage and affordability. We have a significant portfolio on this topic, so we have a dedicated person for that topic, as well as Kate Frischke, who's our director of research and evaluation. This team leads our biggest department in state government. We have about 3,400 headcount here at the Department of Health and Human Services. It's a relatively older workforce, a little bit diverse in terms of how we look. We look like the state of Maine, but not as much like our clients, which is one of our goals in the coming year, is to diversify our department. Like the state of Maine, we are on average older. We're proud of that. We embrace aging here in Maine. And we do have our district offices listed on the right, the most recent, which was opened, feels like years ago, but I think it was just about a year ago in Calais. So we are excited to have our regional offices serving people in Maine. And we need these regional offices because of who we serve. We serve roughly 1 in 3 Maine residents through primarily Maine Care, where we have about 339,000 people enrolled, with 71,000 people in the expansion population. Our food supplement program, also known as SNAP, where we have 152,000 people. And you can see going on down, we have a range of programs that serve tens of thousands, if not thousands of people in Maine, each of whom is valuable to our state and our programs. And because of the scope of the department, we also have one of the largest budgets in state government. The biennial budget proposal that the governor just put forth would have includes $2.8 billion in general fund savings. That does not count the much higher federal funds that come in to support these programs, with, as you can see, the lion's share going towards Maine Care services, but again, that's accompanied by a federal share, but also, again, family independence, child and family services, behavioral health. So this gives you sort of the pie chart of the general fund, but just note that it doesn't necessarily reflect the work because, again, Maine Care is mostly payments to healthcare providers, whereas we have a fairly large number of employees in child and family services for child protective services and family independence, for example, for eligibility specialists, because that's work that we do in-house. So our mission, which we worked hard on in 2019 and have continued to support, is to promote health, safety, resilience, and opportunity for people in Maine. That work is organized around these 3 statements that we try to achieve: that Maine children grow up in a safe, healthy, and supportive environment, allowing them to thrive throughout their lives; that all adults have the opportunity to work, live with independence, and have good health; and that older Mainers live with dignity in the place that balances their needs and preferences. We strive every day to achieve these goals across all of our programs. But turning to the next slide, we also have identified cross-departmental goals. And again, in the coming sessions, you will learn about each of our offices' unique missions, because they all do have their missions and their programs. But we also recognize as a team, we have larger goals that we try to achieve together. They're listed on this slide. I won't read them all off, but these were, again, identified in 2019, advanced in 2020, and continue even during the pandemic and post-pandemic to be how we organize our cross-departmental activity. Again, you'll hear about within departmental office goals and programs in the coming days, but just know that these are the ones that in the Commissioner's office we lift up, and we work to support teams both across this department, but also across different departments. For example, as we work on behavioral health, we work closely with Department of Corrections and Department of Public Safety as we try to ensure that people with mental health challenges are appropriately served in community-based settings or institutions as needed, and not necessarily in jails and prisons. But turning to the next slide, I can't go much further in this presentation without talking about COVID-19. Since almost a year ago, this department has reoriented towards COVID response. The Maine CDC is within our department, and so it has turned intense effort to tackle one of the biggest public health challenges we've had in 100 years. But we also have all of our other offices that have had to go over and above what they do on a daily basis to help. So clearly, the Maine healthcare system has had to respond to COVID-19. You know, we have nearly 200 people in hospitals today with COVID-19, as well as people in nursing facilities, group homes, and other settings who are disproportionately affected by COVID-19. And the Office of Aging and Disability Services, Division of Licensing and Certification, Office of Maine Care Services, all support the health and long-term care systems as we support people with COVID-19. We also coordinate the public and private sector COVID-19 response. We could talk about this at length, but we have regular meetings with all of our different stakeholders to coordinate the response inside and outside state government. We work on the indirect COVID-19 impacts. We know that COVID-19 does have serious and often deadly consequences for people who catch the disease, but we also know their indirect effects. People who skip their chronic illness care because of stay-at-home orders, people who have had mental health or behavioral health challenges because of the pandemic. We have our Office of Behavioral Health, our different offices throughout the department that work on this indirect impact of COVID-19 because the health impact goes beyond those just affected by COVID-19. The economic impact of COVID-19 has also affected our work at the department. Our programs, food supplement program, TANF, all of our economic supports have been affected by COVID-19 too. So we worked hard to support low-income families in Maine during the pandemic. And we also serve as the center of a hub of different cabinets who do work on COVID-19 as well. Supporting, you name it, the Department of Education we work with on a daily, if not weekly basis to support their efforts to keep in-person learning. We work with the Maine Emergency Management Agency to coordinate emergency response. We continue to work on government-wide initiatives supporting the COVID-19 prevention checklist work of the Department of Economic and Community Development, as well as putting the full, support of different cabinet agencies behind our efforts. And I think it's been amazing. People don't think agencies like Department of Transportation have a role in COVID response, but in addition to their public health messages that many of you see driving around Maine, they also have helped us transport PPE to schools, for example, this fall. It has been an all-out effort, and a lot of our work and a lot of my time has been spent on this in the past year, as it will continue into the new year. Going to the narrow, I'm sorry, one back, Molly. We have in the department, though, striven to keep our services open during the pandemic. At our peak last year, we had 70% of staff working and dispatching from home, 86% when excluding Maine CDC and the psychiatric hospitals. While that 86% has gone down somewhat, we think we can do our work effectively in many aspects remotely, so have maintained that posture as we try to keep people spread out, to keep people in Maine safe, especially as we've seen the surge in COVID-19 in the past 6 weeks. We did have our offices resume our full public hours on June 8th. We do maintain that presence. We have had very great success in keeping those offices open safely. We've had to close those offices on occasion when a staff person has tested positive for COVID-19, but we have developed a really efficient system to ensure that those workers, first and foremost, are safe, that their workplace close contacts are notified, that we've closed offices as needed for the appropriate cleaning and notification of those workplace close contacts, but also been able to resume services in a timely way to keep the people of Maine served by our programs. And notably, Maine CDC, as well as our psychiatric hospitals, have been fully operational under our continuity of operations plan throughout the pandemic. We are proud of this work. It has caused strain for our state employees, as it has for all other Mainers. We have striven to offer them programs. The Strengthen Me program, which Jessica Pollard will talk about more today, I believe, is something that you should ask her questions about. It's a fabulous program that serves Maine residents as well as department employees as a way to keep our team going safely during this pandemic because the needs of the Maine people are so high. So I will give a very high-level overview of both our initiatives and then how they have been affected by COVID-19, and then we will open it up for questions. But going back to one of the governor's major goals, on her first day in office over 2 years ago, she signed the executive order to direct the department to expand Maine Care or Medicaid. We recently hit 71,000 people covered through this expansion. That was the goal set years ago, and that coverage has been even more important during the pandemic. For example, Maine Care has poised itself pre-pandemic to really provide access to services through telehealth, and the statistics, which Michelle Probert will talk about more during her presentation, skyrocketed during the pandemic, enabling us to safely provide services to people for whom in-person contact would have been risky. We also worry about access in rural Maine. Many of you know from your districts that oftentimes it's a challenge to get to a primary care doctor, a clinic, or a hospital. So we launched a rural health transformation initiative 2 years ago that work veered into telehealth last year and other supports for our rural nursing facilities and hospitals during the pandemic. We are now reassessing that work to see how in this new year we can continue to forge forward and provide access for people in rural Maine, but that work is critical to our overall goal. We also, in the last 2 years, launched Cover Me, which is an initiative that tries to not just encourage people to sign up for Maine Care, but also for individual private insurance. We know that through the health insurance marketplace, people do have choice of affordable coverage, and we have been trying to promote that. And last year, the governor signed into law the bipartisan Made for Maine Healthcare Act that allows us to begin to move towards a state-based marketplace here in the state of Maine. So we run that private insurance marketplace rather than the federal government. We're working very closely with the Bureau of Insurance on other insurance reforms to make healthcare more affordable, including those COVID-related coverage provisions. But again, going back to the top, Governor Mills has made making healthcare accessible and affordable for all Maine residents a priority, and we have made progress on that in the last 2 years and hope to continue to do so this year. Turning to mental health and substance use disorders, another early action by the governor was an executive order on opioid use disorder and how do we tackle the unacceptable level of addiction and death in the state of Maine. Gordon Smith continues to lead that effort. We had our second opioid summit virtually last summer. We continue to forge ahead in all these programs, including, and Jessica Pollard will highlight some of these. We launched this last year, this overdose prevention through intensive outreach, naloxone and safety program, options program, to really increase our statewide reach of public and targeted campaigns, to focus proactively on these non-fatal overdose cases, trying to really put information in the hands of the people when they need it the most, as well as to increase our collaboration with law enforcement on response. We've begun a ride-along program this last year that we're expanding to all counties, and we are cautiously optimistic that we can begin to make inroads into this pre-existing challenge that was made worse by the pandemic. We continue to identify gaps in our behavioral health and mental health continuum, trying to fill those gaps. We are working to open the Cumberland County Crisis Center, for example. That will be a place where people can go to get services rather than a hospital or being involved with law enforcement. So we continue that work, as well as implementing a service locator so people, both individuals and their providers and their family, can quickly identify services that are the most appropriate level for their loved one themselves in a timely fashion. We have upped our work this past year on the frontline warm line, given the need for additional mental health and emotional support. Some of our lines have seen a 25% increase in the last year due to the pandemic. We've recruited more volunteers and feel good about the support that we're providing, but always could do more. And with federal money that we received in this past year, we launched Strengthen Me, which is a strength management and resiliency management program for anybody in Maine. It has its own website, its dedicated number, and it has begun to provide critically needed services during this challenging time. Turning to our children, we again are quite worried and concerned about what the impact of the pandemic has meant for our Maine children. We know, and again, working closely with the Department of Education at the governor's directive, trying to ensure that children can have in-person learning safely is one of our top goals. To that end, while we've continued our work with the Children's Cabinet on trying to advance our goals of quality in childcare, early learning, as well as helping at-risk youth get the behavioral health and preventive services they need, we did provide extra initiatives in 2020. For example, implementing a per member per month payment through Maine Care so that as children were going back to school, they could get a well child visit, get their vaccinations, get dental care. We similarly held our public health nurses held some vaccination clinics to ensure that kids who missed their vaccinations in the spring got them going into the fall. And we continue to work hard, not just on childcare, but on child welfare during the pandemic. Indeed, the number of children in the care of the department did increase during the pandemic. That happened to be primarily, as Todd Landry will talk about when he comes to visit you today, partly due to increased children coming in, but mostly due to challenges placing those children, given that the courts were not operating at full capacity. So we are proud of really hard work that Todd and his team did to try to reduce the number of kids in care. We are now back to pre-pandemic levels. And as Todd will talk about, those children have been kept safer than the average rate of COVID-19 transmission in Maine. We're proud of that work, but there's more work to be done. That work began pre-pandemic, is continued during the pandemic, and we hope with your support, we can advance it this year. At the other end of the age spectrum, we also know that older Mainers have been disproportionately affected by the stay-at-home orders. Isolation, challenges getting services have been an issue. We have continued during the pandemic to advance our agenda, so we will shortly release our age-friendly state plan that we began almost 2 years ago in partnership with the AARP and other senior groups in Maine. And I think we continue to try to figure out how do we advance our services along the spectrum for older Mainers as well as adults with developmental disabilities and intellectual disabilities. But we also have had to add on to that work close collaboration with our long-term care facilities during the pandemic, providing them financial and regulatory support, providing them routine connections with our teams, Maine CDC, our experts, our infection control experts, as well as we use coronavirus relief funds to provide technical assistance to our group homes so they can get on-site assistance with how do they protect their own staff and their residents through this pandemic. We have also provided significant financial and actual testing supports for our long-term care sites. We have a person who is a dedicated staffing contact when they're running out of when they run into staff challenges due to the pandemic. And we have launched early the long-term care retail pharmacy program to vaccinate residents of skilled nursing facilities and assisted living facilities and other long-term care facilities in Maine. That program is progressing, not as fast as we would like, but we did have some conversations with our partners in the pharmacy world in recent days. We're hoping to accelerate that, as well as working with our independent pharmacies to really make sure that our most vulnerable residents in Maine, older Mainers, and people in long-term care get vaccinated as soon as possible. But we also are grateful for our partnership with our area agencies on aging, as well as their volunteers and our community action programs, because during this pandemic, they've worked extra hard to provide increased numbers of home delivery as well as nutrition services to try to keep our residents with food insecurity supported during this pandemic. And our last of our initiatives is about improving economic stability and reducing poverty. We run some of these critical programs that do support people who are trying to get back to work. Our TANF programs, Aspire. We launched our HOPE program this last year, recently gave 30 of our first graduates some notes and some commendations, most of whom are going into the healthcare field, which is very exciting. HOPE is our program that supports wraparound support for parents who are trying to get an advanced degree to get back to jobs. So we continue that whole family or 2-gen work. We also are trying to expand that work this year. We've done this work in partnership with the Department of Labor and the Department of Economic and Community Development with a sharp eye for the governor's 10-year economic development plan. We continue to coordinate our access to higher education and training programs across these departments. And we also more narrowly during the pandemic have focused on both healthcare workers. This past year, we hired a director of healthcare workforce who does nothing but try to figure out how we increase the supply of healthcare providers in the state of Maine and connect people looking for jobs with those healthcare jobs. We also, as we're entering into this new year, are in very close contact with the governor's office, the Office of Innovation in the Future, as well as Economic and Community Development on what is that pathway to get our unemployment rate here in Maine down. So we are aggressively trying to figure out how do we mobilize all of our programs across state government to get Maine people back to work. Entering to the next slide, we will talk more about our budget initiatives in the coming weeks, but just to give you a preview, our budget initiative, as the governor said, is not really very exciting. A lot of our work is focused on how do we recover. And here at the department, we do have initiatives focusing on reinvesting in public health. The department, the Maine CDC, when I arrived 2 years ago, had 25% fewer people than it had 8 years before. And we spent some of our time last year building the leadership. You'll hear from Dr. Shaw and Nancy Beardsley on that later on today, as well as the infrastructure for Maine CDC, but it wasn't enough. And we had to do a lot of scrambling during the pandemic to really build that team. So we are going to be asking for support in the budget process for initiatives to support testing, vaccination, and social services for COVID-19, as well as those structural gaps that were pre-existing in Maine CDC that we really feel the imperative to fill now. We will also continue the reforms that we began pre-pandemic for adults with intellectual and developmental disabilities, on mental health, as well as child welfare. You'll hear more from our leaders on that today. We also continue to support Maine Care. The program has been, again, essential during the pandemic. It was essential before the pandemic. In our budget, we have $45 million for rate increases, as well as a $25 million stabilization fund for those contingencies. And I will say this, it's very hard to figure out what the system will look like 6 months or a year from now, given the fact that we still don't know. Have we hit the peak of the pandemic? Are we on a downswing, or could it resurge? Will we vaccinate people fast enough that 2021 could begin to be a normal year, or will the supply chain really choke us up and slow down our efforts? So we have a stabilization fund for potential ongoing economic challenges and need for Maine Care during this period of time, for potential disallowances. We got a letter almost on Christmas Eve from the Centers for Medicare and Medicaid Services with a deferral saying they're taking away money from us because of the tax that they view as impermissible. So we have to plan for that potential challenge, as well as for should things go well, should we actually rebound in our economy, should we not have these disallowances. You'll hear from Michelle Probert about our rate system reforms. We have a multi-year plan to try to improve the way we pay healthcare providers in Maine through Medicaid. This reserve fund, stabilization fund, could be used for that should the other needs not materialize. So I'll close by saying, when we think through our work this year, you'll hear a lot about this in the budget process, but our work is our team. It is a very person-centered department that we have here. It is our caseworkers who work with individuals and families to try to support them. It's our eligibility specialists who try to connect people in need with different services that might be available to them. It's our experts who work with our private sector partners who give them the guidance and accountability and support to do what they do. We will continue to talk about rebuilding the department, trying to, as I mentioned earlier, make it more diverse and equitable and inclusive. We have efforts underway to do that as well. We have implemented a work from home policy in response to the COVID-19 pandemic. We are thinking hard about how much that could continue post-pandemic. What do we learn from this experience that is good for the state and good for our workers that we could continue? And we did strive for, and I am proud of Governor Mills achieving this, despite a dramatic turn in the state budget. We did protect critical infrastructure through our curtailments and our biennial budget, and we hope to keep it that way. So our ongoing work is always challenging, always fulfilling, and always striving to improve our services to the people of Maine. That has been complicated by the COVID-19 pandemic. It has, I think, shown both our challenges in our system with racial disparities, for example, but also what's best in our system. We are so proud of the state of Maine and how we have responded to COVID-19. And while it doesn't feel good right now, we all mourn the deaths that have happened. We all, suffer with the families whose family members are hospitalized right now. We still continue to work with our nursing facilities to keep our residents safe. We still strive to get our schools open. Maine still ranks in the top 5 on all of our COVID statistics to date, including cumulative numbers of cases, deaths, and hospitalizations. Our testing remains very high in the nation. Even our last 2-week positivity rate is in the top 5 of all states. And our COVID vaccination process has been going well. That work will continue, but we recognize that that's on top of the really good and hard work that we do every day for the people of Maine. So we appreciate having the chance to introduce Commissioner's office and our other offices to you, and I'm happy to take questions.
Thank you for that introduction, Commissioner Lambrew, and a high level view of what's been a very busy 2 years for you, I'm sure. Let's go around the horseshoe, ask everybody to basically submit their 2 priority questions, and then we can collect those and give Commissioner Lambrew a chance to answer the ones that she feels best ready to or most important to address now. So let's start with Representative Griffin. Do you have a couple of questions?
Actually, just have one. So do I go ahead and just ask it now?
Please.
Okay. I'm concerned about the family members that cannot visit family members that are in medical facilities such as nursing homes and hospitals. The best advocate for a patient is a family member. When do you see this changing?
Thank you. Representative Connor, do you have a couple concerns?
Thank you, Mr. Chairman. Yes, I do. My first question is, Commissioner, I was wondering if you could explain your role in recommending and proposing the governor's executive orders relating to COVID. And then my second question is what is the agency's plan of attack to reduce the error rate in the I believe it's the SNAP benefits that have, I believe our error rate is in the 19% range. So I was just curious to know what the plan of attack is to correct that. Thank you, sir.
Thank you. Representative Craven, do you have a couple questions?
Thank you, Mr. Chair. Yes, thank you, Commissioner. And I am just so grateful for all of the work that you and your department has been doing and the response. My question is, though, for guidance for private docs that are not associated with hospitals. I've had some inquiries about that, and Molly was very gracious in sending me information, but I'm still getting questions from even the Maine medical lobbyist, and especially for Lewiston. We have pediatrics associates here in Lewiston that serves the vast majority of children, and only 4 of their providers have been able to get vaccinated, and wonder if there was some kind of movement or guidance for an organization like that is so widespread around the city, if they could get some kind of plan or preference for vaccinations. Thank you.
Thank you, Representative Craven. Representative Madigan.
Thank you. I also was wondering about the independent physician, so thank you, Representative Craven, for asking that. I have another question in regards to, is there any way, are we tracking in the department behavioral health services and outcomes now that many of those visits are virtual? I'm concerned about people being more isolated, understanding that we're also trying to keep them safe, but if we could have some information about that, that would be great. Thank you.
Representative Zager, did you have some questions?
Thank you, Senator Claxton, and thank you very much, Commissioner Lambert. I fully appreciate the tremendous challenges, not only responding to COVID, but also expanding healthcare coverage, responding to the opioid epidemic, and all the reforms that you outlined. I echo what has been asked about the distribution of not only vaccinations, but also historically the personal protective equipment to community health centers at QHCs, or hospital affiliated practices and non-hospital affiliated practice and primary care practices, and especially in the parts of Maine that are less accessible to hospitals. My second question is, what do you think the role is of primary care and behavioral health in terms of health outcomes and lower costs in the state of Maine?
Thank you. Representative Lemlin?
Thank you, Senator. I actually have a multitude of questions, but I'm going to ask one, and I'd like to make just one quick comment, if I may. My question is, what are we doing to fix our reputation of being the state to go to for Medicaid because our limitations are less? That's my question. And if I may, I just want to make one comment. The commissioner said that she's unsure of what's going to happen with COVID-19. And I'm willing to bet I have the answer to that. I believe that COVID-19 is going to continue to spike October through May. And then June to October, with or without a vaccine, the numbers are going to drastically go down. And then again, with or without a vaccine, come October, we're going to have a huge spike again, October to May. So thank you.
Thank you, Representative Lemlin. Representative Stover.
Good morning, and thank you, Commissioner and Molly, for the presentation. I think it was quite thorough. Some of my concerns that I'd like to hear more about is long-term care, both assisted living and nursing, and how we continue to sustain those programs both through the workforce and also the programs that exist. In my small town, we just saw an six-bed assisted living program close the week of Christmas, and the building is now up for sale, which is, it's 6 beds, but it was 6 important beds. So I'd like to hear more at some point, whether that's through the office when Dr. Saucier comes or at another time. The other thing I'd like to raise for consideration, rarely do we talk about dentistry. And I, as a person who works for Lincoln County Dental and just opened a dental practice, the only dental practice in the entire county that serves Medicaid recipients. I would love to talk more about dentistry at some point and Medicaid rates. We get $30 for a cleaning and exam, and I know personally I don't pay $30 for a cleaning exam where I go. So it gives me a job because I'm the director of development and I write lots of grants, but I just think in the real systemic picture, because a lot of other diseases and medical issues stem from dental caries. So thank you.
So if we could keep this questions primarily, that'd be great. Representative Perry.
Thank you. Well, actually, as I look at us moving forward, in the last session, we were really trying to address many of the needs that we had, not only in public health and prevention, but in mental health and also substance abuse issues. Knowing that we're going to have a rather, limited budget, how do you see us progressing on the many needs that are still there and setting priorities that we can work with?
Thank you. Senator Moore.
Thank you very much, Commissioner Lembrou. Boy, amazing how much we do in DHHS, how much it affects our people across the state of Maine. Some great questions have been asked. The one I'm just thinking about too is that when we adjourned, we still had that rate review study that was being made to take a look at all of the rates. And I'm just curious on how that status is going. Our minimum wage has gone back up, or it's gone to $12.15, and now we've got nursing homes, assisted living that are, and as Representative Stoverman, there's not enough monies out there. So I'm just curious on how that is going and where we stand on that.
Thank you. Representative Javner.
Thank you, Senator Claxton. Thank you, Commissioner Lembrou and Molly. We appreciate the hard work. I also just want to say I appreciate all the communication that we have been receiving from the department throughout this whole year. I really appreciate that. My first question has to do with our population of disability, those with disabilities. I have so many constituents that have contacted me about not being able to have doctor's appointments because of, not being able to wear a mask. And I really want to know what it is what the department is doing as we move forward. What I can tell, my constituents that we're working on this to make it accessible for them. And number two, public health, I know, is a huge push and a real high priority. The one piece of public health that I have really searched for throughout the last year as we've gone through this whole pandemic is what the department is doing to encourage all of us in healthy behaviors, what it is that we can do to really, really keep ourselves healthy on a very practical level beyond, staying 6 feet apart and keeping ourselves, what it is that we can do to really encourage one another to be healthy, but as a department, what it is that we're doing to encourage that.
Thank you. And Representative Meyer.
Thank you, Mr. Chair. I want to thank the Commissioner for her leadership and for of a department that has certainly answered the call during extraordinary and still evolving crises, and we need only to look at the numbers in other states to see that your work and your leadership has kept many Mainers alive. Senator Moore asked about the rate study, so I won't reference that again. I am interested. But now that it appears we are on the brink of a unified national approach to COVID-19, and hopefully our supply of vaccine here in Maine will meet the demand. I wonder if you could comment on the vaccine rollout. And of course, this question will be posed to Dr. Shah as well when he's before us. And if we are maximizing all of the expertise that's within our districts, our counties, where we've got some unique situations that arise in my own district here in very far southern Maine. We have issues regarding cross-border employees, folks that treat in New Hampshire and are receiving some very mixed messages about where they will receive their vaccines. And I wonder if there is communication with the departments in other states about their approach, and then this unique cross-border issue that I'm dealing with down here.
There are questions that I'll share with Molly and our analysts when we get done. My two were about the plan. Well, I'll ask later on from the CDC presentation about the plans for getting homebound patients vaccinated and what's in place around that. And also I'm concerned about the immunization gap that has been certainly aggravated by COVID and what the impact will be for the next school year, especially given the other requirements that we added last session. So I'm concerned if we're going to need to do something to address that for next year or not. So those are my two questions. So Commissioner Lambrou, understanding that we have about 20 minutes for answers and about 3 days worth of discussion, do you want to pick and choose out of that group and answer the ones you're most ready to ask,
Sure.
with the understanding that we'll get the rest of them to the people who should see them?
Sure. Although Senator Claxon, I think I only have 10 minutes. So
well, we'll give you a little bit. We got started late, but if you have to leave, I understand that too.
I do. We have our
Very good.
critical COVID meeting that I have to get to. So I'm going to do this quickly, but Molly's going to be my note taker because I think you're going to hear from people today who can answer these questions better. So starting out with a question on visitation for people in hospitals and nursing homes, we are absolutely concerned about that as well. And I think if you talk to Director Monteo about that, we issue guidance for our facilities about what circumstances they can allow visitors in. So we are working on that as well. To the question about our role in executive orders on COVID-19, we do have a role, as do all the cabinet officials, and giving guidance to the governor about executive orders. She has as her North Star public health. So we give her the public health guidance, as well as how the potential topics interact with different parts of this. She strives to balance out her public health with her commitment to the Maine economy, as you know, as a balancing act. And I think we can be more than happy to talk more about that in the future. And when we talk about the error rate, Representative O'Connor, we will be, Tony Pilot will be coming from Office for Family Independence, and I think he can address that. The reality is that the error rate happened before we arrived, and we have a plan to improve it, but I think he'll give you that answer. On the questions about the private doctors getting access to vaccines, we have been working with the Maine Medical Association, the Maine Osteopathic Association, the different allied health professionals as well, to try to marry their members who are independent, who are struggling to find vaccine, with sites that are providing it. In the governor's phase 1A, they're our priority. We want patient-facing healthcare providers to get vaccinated as soon as possible. So that work continues. We also have been trying to work with the Maine Medical Association on this issue of PPE and trying to ensure that they can help connect providers with PPE. The good news is that the supply chain for PPE has expanded, so we're not hearing the same kind of struggles that we heard last year. All that said, we have emergency management agencies that are poised to help in emergency basis. That continues to this date and will continue throughout the pandemic. And to the point of, you know, are we going to really invest in primary care and behavioral health to try to reduce costs and improve quality? Absolutely. That's something that Dr. Letourneau, who's our lead here in my office, spends a lot of time thinking about. We've done some major reforms you can ask Michelle Probert about. I think that is a priority for the department. To the question about are people coming to Maine as a go-to place for Medicaid, given our our expansion policy, it's actually, Maine is the last state in New England that expanded Medicaid. So sort of the opposite is that some of our residents were struggling to get access before Maine expanded Medicaid. And what we found is the residents who've gotten coverage through the expansion have had lower emergency department use and better health outcomes. I think that Michelle Probert could speak to that. On the questions about our long-term care programs, indeed, Director Saucier at Odes will be able to talk about what we've been doing to support those facilities, as can Director Monteo, given the fact that we have been all out trying to support our long-term care facilities during the pandemic. Going to the question about continuing our support for behavioral health, given the limited budget. I think you'll see when we go over our budget proposals that the department found efficiencies, found federal funding, found savings to dig deeper so we could continue the work that we did. So we have spending initiatives in our budget, including in the area of behavioral health, $5.5 million for community mental health and substance use disorder services, including crisis services, $2 million to promote the options program that I previously discussed. We continue to try to make those investments, trying to find efficiencies, federal funding, and savings to support the important work that needs to continue here at the department. On the questions about our rate system evaluation, in 5 minutes, I expect that we'll post on the department's website a blog that describes the interim report from Myers and Stouffer on the rate system evaluation. There is going to be a final report that is not yet done, but that is coming shortly. And I think Michelle Probert, Director of the Office of Maine Care Services, is prepared to give you a little bit of a high-level preview of that when she comes later on today. On the challenges that people with disabilities have had accessing healthcare during the pandemic, we've worked hard to make sure our non-emergency transportation has continued during the pandemic, to do telehealth and other types of accommodations to ensure that any individual with disabilities continues to get quality healthcare during the pandemic. And when it comes to public health and how do we continue to encourage healthy behaviors beyond the public health protocols, again, Jessica Pollard, Director of the Office of Behavioral Health, will talk about some of her campaigns because she absolutely has been working tirelessly to try to create those messages to support mental health and behavioral health during the pandemic. But one of the exciting parts about our work during the pandemic is not just our department, but the Department of Agriculture and Forestry Services has made national parks in Maine a priority. So we've done aggressive campaigns to get people out in Maine during the summer months and the winter months to exercise, to get physically healthy. The Department of Inland Fisheries and Wildlife has also waived fees for fishing permits and other different types of activities. We've worked across state government to promote safe, healthy activity. And I think if you ask, I think the latest thing I saw about the statistics was that use of Maine state parks last summer was 50% higher than the previous year, which is a sign of success. And then to our chair's questions about vaccines, Dr. Shaw will be here later on and will be able to answer these questions in great depth. Just know that our challenge has been, as was mentioned in the question, lack of transparency from our federal partners. We literally don't know until Tuesday how much vaccine we're going to get the next week, and it's always a surprise to us. We don't get the kind of support. We might be getting the $12 million that Congress passed and the president signed into law on December 28th, may get it this week for vaccine distribution. We previously got nothing. We have been operating in a vacuum that we expect will change. We're doing our best. I think we, again, compared to other states, are doing relatively well. We want to do more. We will develop those strategies to get to rural Maine, talk to Dr. Saucier about homebound seniors. It's on his list of activities to engage with our AAAs, AARP, other organizations to get people out. Michelle Probert's working on transportation options for people on Maine care who are low income. We are working as aggressively, as hard as we can to vaccinate as many people as Maine quickly, equitably, and safely as possible. Those plans will evolve. We will be as transparent as we can every week about who can get vaccinated where. We have a website at maine.gov COVID-19/vaccines, which is our go-to site, but it's a work in progress. It's hard work, but it's good work. And I hope that when it comes down to our predictions, when this will end, that we exceed expectations. So I'll take a deep breath and turn this back over to Molly, who will help get much more thorough answers to all of your excellent questions, either through our orientation briefings or in writing. And I will say, as I turn it back to Molly for the subsequent office directors' presentations, just note that one thing I worked on very hard in 2019 was bringing on substantive experts, committed people, responsive people as the people you're going to be meeting in the course of your orientations. I'm really proud of their work. You will find that they will be able to answer your questions in great depth with, I think, responsiveness. And if they can't, we'll get back to you. But I'm really proud of the team you're about to meet and the work that they've done.
Thank you for joining us this morning, Commissioner. I understand it's the first of subsequent visits, and we appreciate the information. Have a good day.
Thank you all.
Ms. Bogart, do you want to introduce Mr. Viejo?
Yes, yeah. I'm very optimistic that we can keep to our schedule as tightly for the rest of the day as we just did. But yeah, I'm excited to introduce Director Monteo from the Division of Licensing and Certification. He is a registered nurse who's worked in the division for several years now, previously as the Director of the Medical Facilities Unit. Has a lot of expertise here and has also worked in the fields that his office oversees. So I am excited to introduce him, and I will turn it over to Bill and start sharing slides in just a moment.
Thank you, Molly. Senator Claxton, Representative Meyer, members of the committee, my name is Bill Monteo. I am the Director of the Division of Licensing and Certification here at the Department of Health and Human Services. And I do want to thank you for the opportunity to introduce our office to you. We can go to the next slide, Molly. So the mission of licensing is up on our website as well, but essentially we try to support access to quality and effective healthcare and social services by developing, applying, and enforcing some minimum regulatory standards that help people have a safe and appropriate outcome. And what you'll see is our position count and our expenditures. I will focus the discussion today on within the Division of Licensing, the breakdown of our programs. Children's licensing is within our operation budgetarily, but operationally is under the Office of Child and Family Services. And you'll hear more about children's licensing when Director Landry orients you to his program. So if we could go to the next slide, Molly. So within the Division of Licensing, I obviously am the director. We're broken down into essentially 3 functional units, with children's licensing operationally falling under Child and Family Services. So we have 2 assistant directors, the Assistant Director of Medical Facilities, who oversees the acute care team, and I'll give you more detail on that team, the long-term care team, laboratories, which is laboratory licensing and CLIA certifications, their Certificate of Need and Healthcare Oversight Division, and our training and enforcement and compliance unit that looks at our state agency compliance with the CMS contract that we hold. We have the Assistant Director of our Community Healthcare Programs, who oversees our assisted housing, the Behavioral Health Licensing Unit, the Sentinel Event Unit, the Main Background Check Center, and the Direct Care Worker Registry, which is the CNA Registry. We can go to the next slide, please, Molly. This just gives you a high-level overview of our expenditures and appropriations for the programs within our unit. One thing I do want to point out to you on the civil money penalty, these are when there are federal sanctions issued primarily to long-term care facilities or nursing homes within the state, CMS imposes fines based on the regulatory violations. A percentage of that fine money comes back to the state in this civil money penalty and gets put into a dedicated account. The state uses that money under CMS's direct guidance and approval to fund projects in nursing homes that benefit nursing home residents. Any utilization of this money must be approved by CMS, and it has to be shown as a direct benefit to nursing home residents. And a good example of that is early on in the pandemic, we utilized this to provide funding in cooperation with the Maine Long-Term Care, the Long-Term Care Ombudsman Program and the Maine Healthcare Association to provide funding to all nursing facilities to obtain electronic devices, digital devices to assist with a virtual visitation for residents in nursing homes that couldn't do other visitation means. So that's the type of utilization of that money and that funding. If we go to the next slide, Molly. The Medical Facilities Unit oversees and is responsible for federal certification, state licensing, complaint investigations, and our focus on our complaint investigations is regulatory areas that we have a responsibility and jurisdiction over. And I'll provide you a little more detail on that. But we also register personal care agencies, temporary nurse agencies, placement agencies, and individuals who receive care through the family provider services options within Maine Care. And this is just a simple registration process for those entities. And the Healthcare Oversight Unit, which is otherwise known as the Certificate of Need Unit, falls within the medical facilities. Next slide, please, Molly. The division is also the state agency contracted with the Centers for Medicare and Medicaid Services. And the Medical Facilities Unit provides federal certification as well as state licensing for nursing homes, and our acute care team really is all other. It's hospitals, home health agencies, ambulatory surgical centers, hospice, dialysis, outpatient, portable x-ray providers, rural health clinics, intermediate care facilities for individuals with intellectual disabilities, a transplant center program, which we have one of in Maine, and the CLIA laboratories. Next slide, please. The Healthcare Oversight Unit, otherwise known as their Certificate of Need, their primary role is the Certificate of Need process. They review mergers and acquisitions, new facility services, any substantial capital investment and new equipment requests in facilities. I do believe, I'd have to go back to the statute, but I do believe the current ceiling is 5 million on that. If a facility is expending less than 5 million, the certificate of need is not necessarily required, but they do review and provide a determination of whether or not it is required. Changing access to services, so the decrease of a service. Increasing bed complement or nursing facility beds primarily. Looking at continuing care retirement communities and certifying to the State Bureau of Insurance that these individuals have appropriate required licenses. They track nursing home and residential care beds, and the residential care beds that they track are essentially the level 4 PNMI, the larger facility beds, not the smaller facility bed counts. And they oversee compliance with the state statute on free care in hospitals, and any appeal of free care requirements are processed by the certificate or the healthcare oversight team to a hearings officer for review. If you want to go to the next slide, please. So we certify 1,305 clinical laboratories. I can tell you that number has gone up, and I'll touch on that a little bit at the end. One transplant center program, which is currently in Portland. 5 outpatient physical and speech therapy providers, 38 rural health centers. We have 2 portable x-ray providers, and these are agencies. These are companies that travel to primarily nursing facilities and conduct portable x-rays in the nursing facility rather than have the nursing home resident be sent to a hospital to get an x-ray. We also certify and license 38 hospitals. That includes the critical access hospitals. And 93 nursing homes currently in Maine. And when you look at the total number of providers, it's 1,727. If you want to go to the next slide, please. We also register, and this is under the state statute, 179 personal care agencies. And the personal care agencies are the ones that provide home-based services and PSS, personal support services. These are individuals that go into the homes and assist people in their homes. These are non-medical, they're non-healthcare services. So it's primarily some housekeeping, assisting people with meal preparation. So things that they need assistance with to kind of keep them in the home, but are not healthcare services. 120 temporary nurse agencies, and these are throughout the United States. Any agency that provides temporary staffing in Maine has to register with the department. 6 placement agencies. Placement agencies are similar to temporary nurse agencies. They are agencies that work to connect somebody looking for example, a private duty nurse with that individual, and then the individual nurse and the person looking to employ them work out their own contractual arrangement. The staff are not staff of the placement agency, so it's slightly different than a temporary nurse agency. And there are currently 399 individuals that we register for the family provider service option within Maine Care. Next slide, please. The medical facility unit within DLC conducted 148 federal recertification investigation surveys to determine compliance with CMS, applicable CMS standards and conditions of participation. In addition, we conducted 83 federal investigation surveys with a focus on infection control related to COVID-19. And we've conducted 24 state licensing investigations to determine compliance with state regulations, particularly on state-only home health agencies. Next slide, please. This is just giving you a high-level breakdown of the providers that we license and certify within the medical facilities and how many there are. For example, we have 7 volunteer hospice agencies. These are non-federally certified. They provide hospice services strictly on a volunteer, not on a paid basis, and there are very few of them now left in Maine. And 93 nursing homes. Next slide, please. The community healthcare programs side of licensing oversees the assisted housing and behavioral health facilities. And assisted housing is kind of the broad term that includes assisted living, residential care, and what's referred to as PNMI facilities, private non-medical institutions. The Maine Background Center also falls under this program. They conduct background checks that are required by statute. And these are comprehensive background checks. They link to the SBI system as well as the Sex Offender Registry, the Maine Certified Nursing Assistant Registry, and the Maine Sentinel Event Program. And the Sentinel Event Program, facilities are required to report sentinel events or serious events and provide a root cause analysis to this program. And they essentially extract data and use that data to develop newsletters and also try to do outreach and educational programs to improve the quality in facilities and reduce the probability of reoccurrences. And these are significant events such as wrong site surgeries. Next slide, please, Molly. The assisted housing or and behavioral health licensing, as I mentioned, assisted living facilities are facilities that have private apartments. Residential care facilities and PNMI facilities are facilities that provide care and services in more of a dormitory style or very similar to a nursing home type of a setting where there could be 1 or 2 residents in a room. But they're not private apartments. The rooms usually have 1 or 2 residents within a room, and they're in a bath that's shared. And then the residents go out and get meals and would go out to a central area or living room area or recreational room area. The residential care facilities range in size from 1 to 2 residents up to, we have some that are well over 125. And the behavioral health licensing, currently we license the agencies and there are over 1,200 sites. Agencies can have several sites, including providing services in schools. I already mentioned the Sentinel events. There are very few providers that are required to report into them: hospitals, ambulatory surgical, dialysis, and ICF. Sentinel events program does not include nursing homes. Those are any issue in a nursing home comes under the federal CMS condition of participation. The Workforce Development Unit operates the CNA registry and the Direct Access Worker Registry. The Workforce Development Unit also works very closely with ODES on things related to curriculum for particularly PSSs. They also work with the Board of Nursing. The Board of Nursing establishes the curriculum and the criteria to become a CNA. Our Workforce Development Unit then approves the CNA education courses based on the criteria established by the Board of Nurses and conducts and oversees the testing process for CNAs.
Mr. Monteo?
Yes.
Sorry to interrupt, but when you hit one of those abbreviations, could you define it for us? SBI was one, ODES was another. We're all relearning the language. Thank you.
I apologize, sir. So SBI is the State Bureau of Investigations within the Maine State Police, and ODES is the Office of Aging and Disability Services within DHS. The term that you see on here, ICF, IID under Sentinel events, are intermediate care facilities for individuals with intellectual disabilities. We have many facilities that are within the Office of Aging and Disability Services that are group homes for individuals with intellectual disabilities. This term, the ICF IID, refers to the 16 federally certified facilities that we have in Maine. The group homes, of which there are many, and I'm sure Director Saucier will talk about, are not federally certified and don't have to comply with the same standards as these do. Next slide, please, Molly. This just gives you a breakdown on the community healthcare programs, particularly as it relates to assisted housing and behavioral health. There are 30 adult daycare programs, 64 assisted living, and these are the apartment style independent and apartments within Maine. 652, and that number continues to grow for assisted housing providers, everything from 2-bed facilities up over 125 bed facilities. EAP is the Employee Assistance Program through behavioral health licensing. MH are mental health agencies, and SA is an old term, I apologize, but those are substance use disorder agencies that we license. Next slide. So this is DLC supports workforce development through the maintenance of the CNA and direct care worker registry. This provides oversight of the personal service specialist training, also the certified residential medication aid. These are CRMAs is the term that you'll hear. These are individuals that go through a simple 40-hour training program that allows them to pass medications in the assisted living facilities due to the shortage of nurses and the unavailability of nurses. But they have a very limited scope because of the training is not significant, a very limited scope on the types of medications that they can administer within facilities. And Maine is one of only 28 states that has a mandatory reporting of sentinel events program. The sentinel events unit reviews the root cause analysis and provides feedback to providers if they have done a credible and thorough root cause analysis. And we are currently, and they do provide an annual report to the legislature about sentinel events in Maine. They are currently doing a review to look at the past 5 years of sentinel events to determine if they're seeing any change both in numbers and types of sentinel events. For example, within the top 5 sentinel events, pressure ulcers within facilities still continues to be one of the top 5 events that we see. Next slide, please. Our CNA, our workforce development, CNA and direct care worker registry, we maintain a list. Currently, there are 72,000 CNAs on that list. Of that, only 16,245 are active. The registry is publicly accessible and to anybody that wants to check. And it does list the result of criminal convictions or annotations for abuse or neglect on the registry. And it is a requirement federally for nursing homes to check and verify on new employees that they do not have anything listed on the registry for annotation of abuse or neglect. And we have 729 that we have denied registry based on criminal convictions, and there is an appeal process for those individuals to appeal. Next, please. This just gives you the breakdown of the number of facilities covered under sentinel events and how many there are. ASC is ambulatory surgical centers. ESRD are end-stage renal disease facilities. These are dialysis centers. And ICF IID are the 16 federally certified homes for individuals with intellectual disabilities. Next slide, please. This is giving you a little bit of a background now that the Maine Background Check Center has been up and running since 2017. And you'll see in 2018, we had a significant spike in the number of background checks that we were conducting. And that was primarily because at the end of 2018, there was a window of opportunity that providers could get everything done without facing fines or penalties. In 2019, we saw a slight decrease. We saw a significant decrease in 2020. And I think Personally, I think that is attributed to a lot of facilities not bringing on initially in the pandemic new staff and kind of trying to freeze things. We've seen that come up. We're now seeing more of a spike upward as facilities are bringing on staff. Next slide, please. A little bit on complaints. We investigate complaints against facilities and agencies that we license or regulate. These can allege violations that impact health and safety. And when we are reviewing an intake, and as you'll see here in 2020, we received 6,308 intakes. An intake is both a facility reported incident that they are mandated to report, such as any allegation of abuse or neglect is mandated to be reported, as well as complaints from family, residents, the ombudsman, others. Every complaint that we receive has to be reviewed and analyzed and determined, is it within our jurisdiction? Can the allegation within that complaint be directly correlated to a rule or a regulation that we have jurisdiction over? If it can, we will investigate if it's within CMS's parameters. If it can't, we send the complainant back a notice telling them that it's not within our jurisdiction, and we will provide a referral. In hospitals and deemed facilities, we need CMS's approval before we conduct investigations. And when they deny that approval, it then goes to the accrediting organization that deems them for investigation and review.
And before we move on, Director, I wonder if you could talk a little bit about our partnership with the Long-Term Care Ombudsman when these complaints are in nursing facilities and not ones that we follow up on. Yes.
So we work, as I mentioned earlier, we work very closely with the Long-Term Care Ombudsman program. There are a lot of complaints that we receive, particularly in nursing homes, but even some in some hospitals, that the Long-Term Care Ombudsman program assists with, primarily because the jurisdiction of licensing is looking at is there a rule or regulatory violation? And it's really a yes or no. If there is a rule or regulatory violation, does it warrant a citation that requires them to give us a plan of correction on how to fix it? The Ombudsman program assists because they help with both the facility, the family, and the resident. And I hate to use the term negotiate, but they kind of help mitigate and identify what are the issues. And they look at how they can come to a successful resolution to address the core problem at hand. Probably one of the best examples would be somebody has a concern about visitation. And on a regulatory standpoint, we will, and I'll mention this earlier further, we look at the visitation issues under the nursing homes under CMS guidance. What the Ombudsman's office will do will be to work with the family and the provider to say, okay, because of your status currently with an outbreak in your facility, in-person visitation is not the best, but can we come up with an alternative? Is there some type of way that we can allow for this visitation to meet the needs of the resident of the family that still ensures the safety of individuals? So they are very, very helpful in resolving that. And oftentimes there are also communication issues. It's really just a misunderstanding that the Ombudsman can provide a lot of communication on. All nursing homes are required to post the Ombudsman's contact information. And we also, in our acknowledgement letter to complainants, provide that information as well. I just wanted to touch briefly on some of the COVID-19 issues. Early on, and it continues, we work both on implementing and enforcing, as well as providing guidance on CMS waivers. We have provided guidance documents to facilities, for example, on staffing and crisis staffing that kind of gives them suggestions on a progression of, as they're experiencing staffing problems, things that they should consider, things that they should do. Early on in the crisis, we were, and actually going back to 2018 in programs that I have done with the Maine Healthcare Association under the CMS Appendix Z rule, which is the emergency planning rule, we were advocating to providers that they get involved with the various healthcare coalitions that are under the Public Health Emergency Preparedness Unit within the CDC, and get involved with their county emergency management agencies to start planning and looking at things such as, if they have a significant event, it might be better to have the hospital provide a physician to the facility to help provide on site versus sending a lot of ambulances and patients to the hospital. What type of incident would that be appropriate? And to pre-plan that and to look at staffing and staffing resources and what are they going to do if various situations arise. And we've also put out both in state infection control rules early on to address areas that were deficient. One thing that we were seeing as a result of surveys that we were doing was that a lot of things, and my experience working both in a hospital as well proves this, that a lot of things happen during the day. And one of our emergency infection control rules really looked at requiring the facility's infection preventionist to go in off hours and evenings and evaluate how staff were providing care and provide education to address deficient practices that they were seeing in that setting. Assistance with emergency staffing is both the staffing guidance that I referenced, and also with looking at within the rules and the context to help providers of when they're really in a critical crisis, how can they bring on non-certified staff, provide them with immediate training, and ensure that they're competent to do very specific tasks to help keep residents safe and get them through the crisis. We work closely with the CDC on outbreak calls anytime there's an outbreak in a facility, with identifying staffing issues and trying to work with the CDC and with the Office of Aging and Disability Services to try and identify resources. We don't provide staffing directly to facilities, but we try and help them with identifying resources, as does the long-term care ombudsman. We bring them in early on these conversations as well. Consultations with facilities and providers, we have provided infection control. Early on, we were doing this through the phone outreach to providers, providing us additional documents or guidance documents to providers to clarify what the regulations were. We would, with acute outbreak needs, I already discussed that we work with the CDC. We've also worked with Maine CDC and the Office of Aging and Disabilities Services to look at a self-swab testing process to try and help facilities with the testing requirements early on, particularly in facilities that didn't have nurses readily available. The CMS regulatory clarifications, CMS changed our scope of work and required on-site infection control surveys, and they now send us every Thursday. I get a list from CMS in Baltimore of all states, and it identifies the state of Maine, which facilities have had recent outbreaks that CMS has been made aware of, and then directs us within 3 to 5 days of that notice to have surveyors on site doing observations and evaluations of the infection control procedures consistent with CMS's guidance that they have put out. So we've provided the guidance to all providers. So in the issue of transparency, we've made sure that providers know where they can go and get that. The survey process is readily available to providers. The intent is really to try and mitigate outbreaks and control things before they spread. CLIA laboratory, many facilities receive from the federal government, virtually all nursing homes received point of care testing devices or antigen testing devices. There were several large PNMI residential care facilities that receive these as well, but not all. And there's been increased utilization of these devices, which requires a CLIA, which is the Clinical Laboratory Improvement Amendment, either a license or certification or a waiver. And what you're seeing here are the numbers. In September of 2020, we had essentially 51 applications during that month for either a CLIA certification or a CLIA waiver. In November, shortly after these devices started going out, we received 296, so a six-fold increase in CLIA waiver applications. It went down slightly in December to 228, but it still continues to be pretty high. So anything from a school to the local fire department that uses any type of a testing device that tests human samples requires a CLIA waiver or a CLIA certification that we have to review under the federal process and enter into the federal database. The other thing that I apologize I didn't put on this was we provided some emergency CON approvals to facilities to allow for alternate care sites and surge capacity as part of their planning process early on in the pandemic as well. I want to thank you for your time, and I do know there was one question that came up earlier about visitation. I don't know if Senator Claxton, if you'd like me to address that now, or if you have other questions that.
Sure, that'd be great. And when after we're done with that, just before we do that, I want to have Senator Baldacci, who's just joined us, introduce himself.
Hi, good morning. Nice to see you. I'm Joe Baldacci.
Thank you, Senator. I'm Bill Monteo from the Division of Licensing.
Thank you, Bill.
So why don't you go ahead and give us an answer to that question that you flagged?
Certainly. We have provided several guidance documents to facilities about visitation. Early on, there was really in the need to try and protect residents. Visitation was really restricted. CMS put out guidance regarding this, and they essentially clarified in that the initial guidance was the restriction of visitation to compassionate care, which was defined by CMS as end-of-life situations. And that wasn't being interpreted very literally by many of the providers because of a lack of guidance on that was the only situation in which compassionate care visitation could occur. CMS has since provided additional guidance that we have also sent out clarification on to all the providers. And it's their CMS memorandum is QSO 20-39-NH. That guidance provides criteria and outlines for facilities and actually tells them that they should be allowing visitation, and compassionate care means more than end-of-life visitation. But there are certain things that they have to consider and ensure that they can address that visitation can happen safely. So when a facility is in an area or a county of high community spread, visitation is limited to compassionate care because of the transmission and the risk to the residents. And a compassionate care visit is really identified by the physician of that resident, the nursing staff, the ombudsman, the family can do outreach, but the visitation has to be based on the need of the resident in the facility. And this is difficult for many people because it doesn't account for family. So if the family really has a strong need and a desire to see their mother or their father or their loved one in the facility, that compassionate care visit will only happen if the physician feels that it's in the patient's best interest or the resident's best interest. And many of the cases that are given are residents that are withdrawn, depressed, not eating as much. The visitation, it could be allowed under compassionate care to address that feeling of social isolation or missing of the family to try and help provide some level of improvement. There has to be adherence to precautions for disease transmission. And the CMS requirement, once a facility enters a county of community where there's no high level community transmission, so moderate or low, then there's much more open visitation. We saw a lot of really inventive things that were being done in many facilities in Maine. I can tell you I saw one facility that really had a good thought. They created early on a Lexan visitation booth right within the entrance of their facility to allow for people to come in and visit without having direct contact and transmission. Great thought. had to be immediately relocated because it obstructed a life safety exit, but was moved outside the facility and accommodated the mission and was very well regarded by both family and residents. So, and you know, we're seeing more, we're providing more clarification, but facilities are trying to address that. The general theme that we see is many of the facilities are really concerned about you know, having an outbreak in their facility, and they're really they're being more overly cautious, and we are providing much more outreach to address this, as is the long-term care ombudsman, by going on site and clarifying for them, you know, what is and isn't a compassionate care, and the ombudsman has been very instrumental in helping with that.
Thank you for that answer. Let's go around again and see if there's a question or two from everybody. Let's start with Representative Zager this time.
Thank you, Mr. Chair. I have a quick question regarding background checks. Thank you so much, Montejo. You mentioned criminal convictions, and my question is, how are drug possession crimes, such as marijuana convictions that happened years ago, and when the law has changed such that those would no longer be crimes, how is that accounted for when doing background checks in the initial or the appeals process?
So we'll go around and get all the questions asked, and then give Mr. Montejo a chance to answer some key ones. Representative Lemelin?
Thank you, Senator, and thank you, Director, for your report. I have no questions at this time.
Thank you. Representative Stover?
Thank you, Mr. Chair. I have no questions.
Good. Okay. Senator Baldacci? That may be unfair since you just joined us.
No. I thank you, Senator Claxton. Mr. Montejo, thank you very much for your service. I know I apologize coming in a little bit late. I did want to ask you a couple questions about nursing homes. In Bangor, we've had Winterberry Heights has had 2 major outbreaks. And I wanted to know where we were with that situation and if there are other outbreaks in the Bangor area we should be aware of. And then I also had a longer term question, which is because I noted in your slideshow, you mentioned that there are 6,308 complaints that your department gets, and about 1,500, it sounded like 1,500 or so were surveyed. So I wanted to get some background. One is, do we have enough staff to look into the complaints? And I'm sure that you guys have a directory, or I don't know if you compile a yearly report on nursing homes that you can put out. I know that would be helpful to many people who have loved ones in nursing homes. So those have been my 2 general areas of questions. Thank you.
Thank you. Representative Perry?
First of all, wow, that was a very thorough report. Thank you. I guess the question I do have is, because I did some work last session with the background check organization agency, and the thing that we have been trying to work toward is the ability for agencies who need to do background checks to be able to do it as a one-stop shop. And I know we haven't been there yet, but some idea of how close they're getting and what changes they are looking at.
Thank you. Representative Griffin, do you have any questions?
I do not, but I wanted to thank you for answering the question about visitation. That was my question. And I also like to thank you for your presentation. It was very well done.
Representative Connor.
Thank you, Mr. Chairman, and thank you, Director Montejo. The question that I have is pertaining to the certificate of need. I was just curious to know if there was a drastic change in the number of certificate of need applications during COVID, and if it was tracked, and what that looked like in comparison to the previous years prior to COVID. So again, I echo my colleagues. Great briefing. Thank you very much.
Representative Craven?
Thank you, Mr. Chair. No, I don't have any questions, but again, want to thank you for the great report. Very, very clear.
Representative Madigan?
Thank you. I have no questions at this time.
Representative Javner?
Thank you, Senator Claxton. I just have one quick question. With the complaints issue, where, if you don't handle them in your department, where else are they referred to? I know the ombudsman helps with a lot of that, but where else are they referred to?
Senator Moore? There's a problem with the audio.
Can you hear me now?
Yeah.
But then, the Representative Perry asked a question that I was curious about as far as the one-stop shop of that session. The only other question I had is I was trying to recall what the cost of a background check for an in-person business or an
I'm sorry, you broke up and I didn't hear the question.
My question was about what is the cost of the criminal background check?
Thank you. Thank you. Representative Meyer?
Thank you, Mr. Chair, and thank you, Mr. Monteo. I do have a question. So as you're likely aware, this committee began a conversation in the 129th on workforce development and the professionalization of the direct support working group. And I wonder, I heard that conversation then brought up again in the Caucus on Aging replay that I listened to recently. And I wonder, there was talk about the collapsed credential for DSP, PSS, CNN, home health aides. And I wonder how close you are to the collapse credential becoming effective, and how and who you are including as far as stakeholders in that conversation.
Thank you. And my questions were about how much do we know about the huge number of inactive CNAs at a time when the long-term care facilities are telling us they can't hire staff? So how much research, how well do we know what's going on for that group? And are there areas that we could address some of that? And the other was really an expansion of the question that Senator Baldacci asked about a specific nursing home or two. My question is about what's the best way for us to be aware of the nursing homes in our communities and their status with respect to outbreaks. Okay, so do you want to pick and choose out of that, Mr. Monteo, in the next 10, 15 minutes?
I will try and go in somewhat order, but and I will, things that I don't know off the top of my head, I'll ask Molly to follow up and I'll provide the information to Molly. To the question on the background check related to marijuana crimes, if the crime is still listed in a database as a criminal conviction, it would still show. So this really is an online type of a computer. We utilize a system provided by Yale New Haven, and that computer system is networked through OIT and various other computer systems, so that somebody puts in the information and our system reaches out and touches essentially other various databases and provides a report. So I would have to, Representative, get back to you regarding the specifics on marijuana crimes. I don't know that off the top of my head, but I will follow up with Alex Netton, who is our program manager for that and provide that information to Molly, who can get it back to you. The question on Winterberry Heights specifically, a little bit of clarification. Winterberry Heights is not a nursing home. It is a assisted housing provider, so it's a residential care facility, and therefore not subject to the same infection control standards and regulations as nursing homes. And we have put an emergency rule through for our assisted housing providers to address, because one of the things that was identified early on in this situation was that there is no requirement for assisted housing facilities. I apologize, I'm getting a notice that's saying my computer's about to restart and I'm trying to make it snooze. So there is, assisted housing facilities don't have the same requirements related to infection control. That having been said, there are regular calls with Maine CDC and our staff on that, with that facility, that identify PPE needs, testing needs, and we work with staffing and as well as with the long-term care ombudsman. So I am not knowledgeable on the specific details of that provider. That's one that Heather Hyatt, who's our Assistant Director of Community Programs, is working with on a regular basis. Outbreak information is provided through the CDC. We don't list outbreak information in facilities that we license or regulate because that's all done through the CDC and through the CDC's reporting process. We do list and on our website, which is readily available to the public and any of you. Any facility that we license is listed on our website, that you could go in and look at the details of inspections. So you could go to a facility and find out who is the administrator, what's the contact information of that facility, what's the phone number, and you can pull the reports, both investigation and recertification or relicensure survey reports. For nursing homes, CMS provides a nursing home compare site that utilizes this data and allows you to compare nursing homes within your community. For example, if you have 2 or more nursing homes in your community, you could compare one against the other on looking at the health reports and the life safety reports, and it will give you the details of what was the violation. So many of the terms are very broad, but you can actually get into the detail of what is the evidence that supports the violation. The question regarding our complaints, the 6,308 is, yes, it is significant. We have used to have a dedicated staff that did just complaints. Years ago when I started, there was a special complaint unit that's been absorbed within other units. We don't provide a yearly report on our nursing homes and on our complaint process because the information is readily available on the website for people. There's not any report that we pull that shows how many complaints per year this facility has had over that facility. All of the complaints are reviewed. We call it a triage process, consistent with Chapter 5 of the CMS State Operations Manual. And if a complaint alleges something that's outside of our jurisdiction, and the referrals are made based on the type of provider that it is. And then, for example, if we get an allegation of abuse from a personal care agency, we register, and the only current requirement is that they conduct a background check through the Maine background check program. So they register with the department, they conduct a background check, but there's currently no operational rules for their practice. So when we get an allegation of abuse or neglect, we work closely with the Adult Protective Services within Office of Aging and Disability Services, and we would refer the complaint to them because they have jurisdiction. And if they don't have capacity, we could go out, and we have in the past gone out and investigated that matter and provided the evidence to the Adult Protective Services as well as to the Healthcare Crimes Unit at the Maine Attorney General's office for follow-up and action. For other providers, for example, hospitals that are accredited, the predominant accrediting agency is the Joint Commission that many of you have heard of. If a complaint, when it's reviewed, doesn't meet a high criteria level under the CMS standards, CMS will not approve or authorize the state to investigate it. Those complaints are referred to the Joint Commission for follow-up and investigation. And so what we will do is send the complainant notice that it doesn't meet the criteria under CMS for an on-site investigation and provide them with the contact information for the Joint Commission. In some cases, we have made the referral to the Joint Commission ourselves. And others, the referral would go to the Healthcare Crimes Unit at the Attorney General's office, for example. So it really depends on the nature of the complaint. We look at all the complaints because the only thing that we can investigate is things that fall within our licensing jurisdiction. And so there are times where things that are really egregious that we don't have rules or regulations that fall under. If it's a federally certified provider, we will reach out to CMS. But a lot of allegations, for example, billing complaints that we do get a lot of, go either to the Bureau of Insurance or to the Healthcare Crimes Unit or the Office of the Inspector General in Boston federally, because there's no regulatory rules that we have in regards to billing. There is a rule that requires providers to deal with a grievance. So if the billing complaint was filed with the hospital or the provider, if they didn't address the complaint with the complainant, we would look at it from a grievance, the failure to follow the grievance requirement, but we can't address the billing issue at its core. Staffing, I mean, anybody would say we could always use more staff, but I think we do well with what we have. We spend more time, I call it on the front end, screening the complaints. And we also do a lot with the complaints with the Ombudsman's office, notifying the complaint of, what our limitations are and suggesting that they reach out to the long-term care ombudsman to see if they could resolve it, because they will get oftentimes much more satisfaction from the ombudsman mitigating or resolving the issue than it will getting a standard yes or no, it's a violation or not. So in regards to the background check, Representative Perry, we are still working on the one-stop. It's been difficult getting the various computer systems and networks through firewalls and to talk with them, each other. I'd like to hope that we could someday get there. The other issue that I know has been brought up in the past is the portability, the ability to get a background check done and be able to utilize that result at other employers. And that's still an ongoing issue that we're looking at as well. I don't have a status for you, but I will follow up with Molly to get you a better answer for that. Our CON unit, we did issue and we are tracking several emergency CONs, as I mentioned earlier, for surge capacity in facilities. For example, there's a hospital that owns a nursing facility that has a closed unit or wing that was being renovated that we gave an emergency CON to allow that to be a 45-bed surge capacity in the event that they needed it for COVID. We are tracking those, but we haven't really seen any other significant change or increase in other CON reviews and approvals. Many of these projects are things that take several years in regard to the CON approval and the construction process. And some of them are changes of ownership. We did see a surge a few years back in nursing facility closures and purchase and sales. We've not seen a significant increase in that work either, but we are still seeing requests for review and projects related to nursing home beds and changes of ownership. Not a significant deviation from the past. But I can get you numbers, which I'll get to Molly, on the emergency CONs related to COVID. I don't have for you the cost of the background check off the top of my head, but I will get that to Molly to get back to you as well. And we are still working with the Office of Aging and Disability Services, as well as Main Care, on the issue of the workforce development. I'm going to, Representative Meyer, need to follow up with Molly and get you a little bit more detail as to where that stands. But yeah, the work continues. It did stop during the COVID crisis to focus a lot of effort on the crises that we were seeing in the various nursing homes and infection control issues. But it picked up again, and we have been meeting to kind of bring that forward. It is recognized as a need. And the biggest issue that we heard was the portability of the training as well, and to be able to build. And as far as the question on the inactive CNAs, we maintain, the CNA registry maintains the database with contact information. And what we do, we work with the commissioner's office, with the workforce development unit within the commissioner's office on these outbreak calls, and provide essentially batch emails to even the inactive CNAs whenever there's a crisis to try and get people on board. We don't track or identify why people have chosen to not renew or activate their CNA. But anytime there's a crisis, and we do still reach out to the inactive to try and entice them to come back, there has been work done looking at through CMS waivers that CMS has approved, and through the staffing guidance that we have done to expedite a renewal process. And we have changed, with the Board of Nurses, looked at the criteria for out-of-state approvals. We did have a really serious issue because the CNA course in Maine is so much more in depth than in other areas. For years, our CNA course in Maine was 180 hours, and the national standard was 100, which made it very difficult for reciprocity for outside CNAs coming into Maine. And we've been able to come up with the Board of Nurses a workaround for that, to allow for CNAs coming in from out of state to have some portability. So I apologize if I didn't get to everything. I tried to hit on all of them.
Well, Mr. Monteo, did you present this 2 years ago?
I was with Sarah Taylor, was the director, and I was with her 2 years ago. Yes.
Well, I don't want to throw Sarah Taylor under the bus, but I really learned a whole lot this presentation. It was news to me, so I appreciate the care with which the presentation was put together and your willingness to answer questions. So thank you very much.
You're welcome, sir. Thank you.
So I think what I'll do is we've had two people join us, Nancy Beardsley and Dr. Shaw. Nancy, do you want to introduce yourself? Oh, never mind. I'm going to go through Molly to do the introductions. But I would encourage, again, everybody, feel free to go to the blank screen and stand up and turn around before you sit down again. We want to make sure people are moving around every once in a while. So I will go to Molly.
Great. Thank you very much. When I introduce them, I get to brag a little bit more than they'd brag about themselves. So I am happy to introduce you to our Director and Deputy Director of CDC. Dr. Shah, I think, probably needs little introduction after you've heard from him so many times over the last year. But we're so glad for his leadership at CDC, and Nancy Beardsley is now his Deputy Director at Maine CDC. I think many of you met her last session. She was the interim director as we were searching, and previously served as the director of the Division of Environmental and Community Health at CDC. And the two of them are really leading the charge here on COVID-19, but also I'm going to look to provide you today with some background around the rest of the work that CDC does that has not stopped in most respects. So I am happy to turn it over to the two of them, and we'll get going.
What we've been doing, folks, thanks you for joining us, is having the presentation be done and then collecting questions, understanding that we will likely not have time to get to all of the answers. So I just wanted to let you know a little bit more about the format. So thank you for being here, Dr. Shaw.
Well, thank you. And Chairman Claxton, Chairwoman Meyer, we very much thank you for the invitation to be able to join today. As Molly said, we'd like to talk with you about all of the work that's happening at Maine CDC right now. Certainly, COVID and the pandemic have put our response and mitigation efforts under the spotlight, the thing that we all talk about and hear about. But one of the things that I'm eager to chat with everyone about and discuss in greater detail is the other series of work that's happening at the Maine CDC, which, as you hear me talk about, I'm delighted to report has not stopped. Much of our efforts to keep Maine people safe and healthy from a number of diseases, be they infectious or otherwise, those efforts have not gone abated during our response to the pandemic. Indeed, in some areas, we've continued to make strides, even in light of the significant challenges. I'll get into some of those things in just a moment, and I'll flip open our slides in just a second as well. But I'd also like to take a moment to remark about how it was almost exactly 1 year ago today, in an appearance before this very committee, where many of you will remember Representative Dr. Hymanson asked me at the end of my remarks, where we talked about everything from childhood lead poisoning, the opioid crisis, maternal mortality. At the end of my remarks, Dr. Hymanson asked me what was keeping me up at night. And perhaps she expected, or the members of the committee expected me to talk a bit more about lead poisoning and maternal mortality and the opioid crisis. But what at the time, about a year ago, was starting to keep me up at night was what I referred to at the time, something happening in China with a virus. At that time, nearly a year ago, I had just started receiving briefings from the US CDC, and about a year and 3 weeks ago, had just, because of work I had done previously in Asia, started hearing my counterparts, many of whom were still back in Asia, talk about a virus that was rapidly spreading in a central Chinese city. And as I reported to the committee about a year ago, that was in fact what was keeping me up at night. I think after I said that, Molly started scratching her head very furiously, wondering what I was talking about. And as we've now seen, those things that have started halfway around the globe 365 plus days ago have now affected almost every facet of all of our lives across the state of Maine, across the country. Indeed, I speak to you all on a day where just yesterday, the United States surpassed now 400,000 deaths associated with COVID. And we in Maine have not been spared, having logged over 500 deaths. We will certainly talk more in detail about that, but I just wanted to set the table to, again, open to discussions around everything COVID related, but also all the other good work that's happening and continuing to happen across Maine CDC. So with that, and Nancy and I are delighted to be able to share with you where we are and where we hope to go over the next year. As Maine's public health agency, our goal is to provide essential services that preserve, promote, and protect public health. We do so with a team that is nearly 350 people strong, as well as a team that we are hoping to build out, as you can see here, with vacancies that we are continuing to try to hire. Even though the pandemic is what focuses much of our time, we are still working to hire folks across the agency, be they involved with the COVID response or in other vital public health parts of the agency. Our current budget, at about $229 million, is largely 2/3 comprised of federal funds, the remaining third being a mixture of special funds, general revenue, and just under 10% emanating from the Fund for Healthy Maine. Organizationally, what I'd like to do to organize my comments today is to, again, first talk a little bit about COVID-19 to set the table on where we are, but then recognize that there is other great work happening. And I'll focus on some of the divisions that you see here. For example, to spotlight the work that our public health nurses are continuing to do, our team of environmental and community health specialists, as well as, for example, our team of district liaisons and the folks who operate our vital records, all of which, again, have continued unabated throughout the crisis. Well, let's start with what is certainly and surely top of mind for everybody. Where are we with respect to the COVID-19 response? Well, our response began over a year ago at this point. Our first meeting to gather and discuss COVID-19 internally within Maine CDC happened the first day back of after the New Year holiday over 1 year ago. At that time, our focus was around trying to understand what was known and not known about the virus, and given what we did and did not know at the time, prepare, for example, to ensure that hospitals and healthcare systems had early cases of PPE, that we were working to bring on our testing capacity at our laboratory here in Augusta, and that we in turn were sharing every piece of guidance that we were receiving from the US CDC and the World Health Organization with healthcare providers and healthcare systems across the state, as well as with the public. Indeed, we started sharing that information over 2 months before we had our first case of COVID-19. Since then, since our first case on March 12th of 2020, we have unfortunately logged 35,637 cases as of this morning, and even more sad, over 500, to be precise, 536 deaths associated with COVID-19. As we'll talk about at the end of my remarks, the focus now remains on keeping that core response of PPE, outbreak investigation, laboratory testing, keeping those core pieces of our response intact, and now building on a new element of our response, that focusing on vaccines and vaccination, which we'll talk about in just a bit. The unit within Maine CDC that is the core of our response is our Division of Disease Surveillance. That division responds to reports of infectious diseases of all types. And after receiving those reports, be they of COVID-19, tuberculosis, hepatitis, HIV, launch epidemiological investigations to determine whether there's an outbreak or just a discrete case, and then notify those who have been potentially affected. That division also oversees the operations of our state public health laboratory, the Health and Environmental Testing Laboratory based here in Augusta. That's not all this division does. They also, for example, house the Maine Immunization Program, which, as I referenced, is now central to the activities across the state with respect to vaccine and vaccination planning. They do so much more as well, though. On top of everything COVID related, around outbreaks, testing, vaccination, they're also constantly scanning data for a host of other diseases to see if there are other trends that might be emerging for diseases that are non-COVID related. For even though COVID is front and center, we have to bear in mind that diseases like hepatitis, tuberculosis, and HIV have not gone away. In
Dr.
particular, yes, go ahead.
Would you just mind putting this in presentation mode? The slides are a little small for those of us on this.
By all means.
There we go. Thank you.
Thanks for reminding me, Molly. The Division of Disease Surveillance, again, is that core of our core response and is involved with really discrete parts of the COVID response. For example, the epidemiology team. These are the gumshoe disease detectives who are out there investigating outbreaks, trying to piece together what may have happened to cause the outbreak so that we can provide recommendations to try to bring it to an end. This team has been significantly expanded. Indeed, we've created 5 new teams within this team of outbreak investigators and supporting epidemiologists to do this work across the state. The other essential part of this division's work as it relates to COVID is contact tracing. We established a brand new program with a brand new IT platform to educate those who are contacts of confirmed cases so that they could be enrolled in a program to make sure that if they develop symptoms of COVID, they could be offered testing in a quick, efficient manner. All of that being brand new based on the response. The other part of this division that I mentioned that is essential and core to the response is our state public health laboratory. Thus far in the pandemic, they have tested more than 250,000 samples for COVID-19. That represents about 1 of every 4 COVID-19 tests done in the entire state of Maine. In other states like Connecticut, their state public health laboratory has maybe done 5 or 7% of all of the state's testing. We feel that the state laboratory is a core component of our testing landscape, and that's why early on, we set a goal of making sure that all Maine people could get access to testing as quickly as possible at no cost, done at our state public health laboratory. And that's why we're pleased to report that, again, almost 1 in 4 of every COVID-19 results processed in the state of Maine has occurred at the Maine CDC laboratory. We've been able to expand that capacity because of a partnership with Maine-based IDEX, which helped us establish a mobile laboratory adjacent to the bricks and mortar laboratory. We also more than tripled our staffing within that section and have also, since early in the pandemic, partnered with our colleagues at the Jackson Laboratory here in Maine to help sequence or look at the genome, the genetic structure of the viruses that we find circulating in Maine to make sure we are constantly on the lookout for example, these new variants that have popped up in the UK, South Africa, and other states across the country. But here's the important point. We have done all this while maintaining all of the other essential public health laboratory functions, whether it's our ongoing testing for rabies, tuberculosis, foodborne outbreaks, and pediatric and childhood blood lead. Those activities, again, have continued unabated, notwithstanding the expansions elsewhere. Front and center right now is the Maine immunization program. We're going to talk about immunizations right at the end because I gather and suspect that there's a lot of questions around that. The core of that work within Maine CDC is done within the Maine immunization program, which is responsible for allocating vaccine, distributing that vaccine, and undertaking wider scale public health education activities to inspire confidence in the COVID vaccines. That division, the Division of Disease Surveillance, is probably the core of our COVID response, but by no means the only element of Maine CDC overall. The next division I'd like to take a moment to touch upon is our Division of Environmental and Community Health. Indeed, Nancy Beardsley, our Deputy Director, used to be the Associate Director overseeing this division. This division has a couple of units underneath it. One, first and foremost, is the drinking water program. And as its name implies, it is essential to ensuring safe and reliable supplies of drinking water for everyone in Maine. It does so by providing oversight and technical support to the nearly 500 units across the state of Maine that are enforcing various elements of the drinking water program itself. This division of environmental and community health also is engaged in other areas. They, for example, house our radiation control program, which looks to register and ensure the competency of anyone involved with activities involving radiation in Maine, whether it's those who are testing for radon in the homes or laboratories that are looking at radiation levels. We also inspect various machinery and medical establishments across the state to make sure that, say, your X-ray machine, your mammography machine are all operating properly with respect to safety. The Division of Environmental and Community Health also houses our health inspection program. This is where the health and safety inspectors that are deployed to ensure health and safety and compliance with regulations at nearly 8,000 licensed establishments across the state are, be they restaurants, hotels, motels, campgrounds, camps, etc. As we've moved through our COVID work, this section too has seen increased activity owing to the number of concerns that have been raised by folks across the state around compliance with various public health guidelines. We've also recently moved the section of environmental and occupational health underneath this division. This section, environmental and occupational health, among other things, is responsible for monitoring increases in concerns around childhood lead poisoning, which remains one of our top strategic priorities across the division, across the agency. As with all of Maine CDC, this division has been engaged with the COVID response in particular. And the thing I'll draw your attention to is the second bullet, which is the health inspection program. These health inspectors have followed up on thousands of complaints related to COVID-19 prevention and adherence with guidelines across restaurants and hotels and motels across the state. To date, Maine CDC has issued 82 so-called imminent health hazard findings and have temporarily suspended the licenses of 20 establishments because of their violation of the COVID-19 prevention requirements. Going to turn really quickly to another division, which is the Division of Disease Prevention. Much of what I've talked about right now has focused on infectious diseases, be they in the community or in water and other venues. But of course, the mantra of public health is not to wait until a disease is affecting us, but rather to try to prevent it in the first instance. This is what the Division of Disease Prevention does, to attempt to reduce Maine's chronic disease burden through the provision of multiple evidence-based prevention programs. We do this by focusing on a number of areas. For example, maternal, fetal, and infant child populations to try to keep moms and their babies healthy. We also focus, for example, on prevention of substance use, be it tobacco, other illicit substances, as well as to try to improve mental health among children by improving their abilities to engage in what is called social and emotional learning, to cope with the challenges that come their way so that they can be more resilient young people, as well as being more resilient adults. And the other element of this division that is particularly important in this time right now, when so many are struggling, in part because of the challenges from COVID, is our WIC program. Our program that provides nutritional services for women, infants, and children across the state. What I want to do really quickly is, in the time that we've got, zero in on the WIC program in particular. Of course, make no mistake, the work that we are doing around tobacco and substance use and maternal and child health is critical, and this information is contained in the briefing book as well as in these slides themselves. But I want to take a second to spotlight the WIC program, because in a time of COVID, when again, there are so many challenges, economic and otherwise, we have been concerned about the increase in food insecurity across Maine. Indeed, food insecurity was a concern even before the pandemic, but it has only been exacerbated now as a result of the economic and other hardships imposed by the pandemic. Our WIC program has met that challenge, and I think has done so in spades. Even despite the pandemic, we have made significant improvements to the WIC program over the past year. For example, we moved away from the paper-based checks that people would receive as WIC beneficiaries and moved the entire WIC program to be effectively a debit card that gets automatically recharged every month. This has significant benefits. First of all, it's administratively much more straightforward to electronically load a debit card rather than having to mail out checks and then have those checks be used at the point of sale. So just from an administrative ease of use perspective for the consumer, the beneficiary, it's a big step forward. But the other reason it's a big step forward and why I urge the team to push on it so hard is that there is a certain and definite stigma associated with being a WIC beneficiary. You're at the grocery store and everyone else has a credit card, but you've got these paper checks. It's like sending up a flag that says, I need assistance. And for folks who are already struggling, broadcasting that is the last thing they need. By moving to what amounts to a debit card, this removes the stigma that some have reported to us they felt as being part of the WIC program. Stigma is something that's really important to me, all the more reason why I was delighted that Maine CDC was able to move the entire program electronically, even despite the challenges posed by the pandemic. The next area I want to zero in on within Maine CDC is our Division of Public Health Nursing. The public health nursing mandate, their ambit, is extremely broad. As you can see on this slide, they are involved with everything from providing treatment and support for babies and parents affected by substance use disorder. They are front and center in public health emergencies, whether infectious disease outbreaks, disasters, and bioterrorism. They are engaged in their communities, providing training and education. They are conducting home visits to new mothers across the state. They are helping ensure that kids have a safe place to sleep through the Cribs for Kids program. More recently, they have been central in standing up vaccine clinics across the state before COVID, and now with COVID, are part of our overall vaccination architecture. And then, as I've talked about, another one of my priorities being childhood lead, working with families that are at risk for lead poisoning to make sure that their homes are safe to mitigate or reduce the likelihood of lead poisoning occurring. Public health nursing's ambit is as broad as public health itself. And as a result of that, they have been front and center in our COVID response. Early on, when PPE was our top priority, it still is, but when it was one of our top priorities, we recognized that there were numerous healthcare providers across the state of Maine that needed an N95 mask. But you can't wear an N95 mask unless you have been fit tested. And you can't be fit tested unless your organization has a broader respiratory protection program. We deployed public health nurses to sites across the state of Maine to help them create that entire substructure so that their providers could receive and utilize N95 masks. More recently, we have been deploying public health nurses to vaccinate residents and staff of long-term care facilities across the state of Maine. We've also earlier throughout the pandemic had PHN guide and provide input to our colleagues at 211 so that when folks call with questions, when your constituents call with questions, they're getting accurate clinical answers. We also know that using PPE requires knowing how to take it on and take it off properly, and that requires training. So similarly, we deployed other groups of public health nurses across the state to teach folks the safe ways to put on PPE and to take it off to reduce the likelihood of infection. Public health nurses are essential to our work. We know that we need to keep hiring as many public health nurses as possible. This has been a challenge for a number of reasons. We look forward to working with you and getting your advice on how we can continue strengthening our team of public health nurses. And finally, before I turn it over and wrap up with vaccines and vaccinations, I want to touch on our Division of Public Health Systems. This too is a broad division within Maine CDC. It houses, for example, our Public Health Emergency Preparedness Program. That is the division within Maine CDC that has been delivering that PPE, coordinating those vaccine deliveries, so on and so forth. But the Division of Public Health Systems also, for example, runs our vital records system so that folks can get their birth certificates and death certificates and marriage certificates. They haven't stopped. They haven't missed a beat throughout the pandemic. The division also works very closely with critical access hospitals in rural areas to ensure that they too have the services and the support they need to keep rural populations safe. I want to close my remarks today by focusing in a bit more on vaccines and vaccinations. I say those words deliberately because a vaccine is only the first step. A vaccine on its own doesn't prevent anybody from anything. It is the vaccination that prevents folks from getting sick, whether it's with COVID, measles, polio, or any other infectious disease. Right now, with respect to COVID-19 vaccination, the state of Maine is generally following recommendations from the US CDC's Advisory Committee on Immunization Practices. This is the group of experts that started meeting in the summer, throughout the fall and winter. Indeed, we have a meeting next week to discuss who should be vaccinated, roughly speaking, in what order, and with which vaccines. We have largely followed those recommendations, making certain modifications as appropriate to Maine. For example, to account for our higher than average age population. Our two principles with respect to vaccination are to vaccinate with velocity and equity. At this time, however, the availability of vaccine across the country remains limited and is thus our principal constraint around expanding vaccination rates. In effect, the supply of vaccine is what governs the speed of vaccination. Right now, and for the foreseeable few weeks, Maine's incoming supply of vaccines from Operation Warp Speed and the federal government is unfortunately going to be holding steady at roughly 18,000 doses coming in every single week. I've been briefed by Operation Warp Speed that they hope after that next few weeks to begin increasing the allocations that are made to states. The $64,000 question is, by how much? Will it go up a couple of percentage points, or will we start seeing double-digit increases every week? As of when I was briefed on this, which was about 48 hours ago, at this time there wasn't an answer. We all wish that there were more vaccine coming into the state right now, because the supply of vaccine is what drives how we move through the phases that you see noted on this slide. Right now, we are in a position between phase 1, where we are working to close out vaccinations of healthcare workers, residents of nursing homes, and public safety personnel, while simultaneously starting to vaccinate those 65 and older, as well as those with other conditions. These are not discrete buckets. We will not finish every single healthcare worker in Maine before a single person age 70 and older gets vaccinated. Rather, I see these things as a dial. We will turn down the dial on phase 1 as we complete that process, and simultaneously turn up the dial on phase 1B as we start working our way through 1A. That is how we've treated most everything in the COVID response thus far, not as discrete on-off switches, but a series of dials that we turn as circumstances change. All that being said, I'm proud of the work that we've done thus far with respect to vaccinations. As of this morning, 74,000 people had received at least their first shot, and 17,000 people in Maine had received both of their doses of vaccine, over 90,000 shots administered. The more vaccine we get, the faster that we can move. We have an exciting year ahead, not just with respect to the COVID response, whether that be with vaccines, testing, contact tracing, PPE, but we've got other priorities. We must continue to rebuild our workforce and thus the vital programs that I've taken a minute to spotlight today. And we have to do so in a manner that allows us to engage with the public, to continue informing them with the best available scientific information and data, all in an effort to mobilize the entire state to move together and solve not just the COVID problems, but the myriad other public health challenges we know that have not stopped, even though the pandemic has been with us. So with that, Chairman Claxton, Chairwoman Meyer, thank you for your time and allowing me to set the table. Nancy and I look forward to any and all the questions that you may have. Sorry, my watch wanted to weigh in. It's not its time, however. So thank you all for your time, and I look forward to your questions.
Thank you, Dr. Shaw. Appreciate it. Thank you, Nancy Beardsley. Good to see you again, and glad you're on the team. So, understanding that there are likely to be a lot more questions than our time for answers, could people succinctly offer a couple of questions? And then I'd ask Dr. Shaw and Nancy to sort of pick and choose from their answers as we've done before. But let's get a couple of questions out there in the remaining half hour. So let's start this time with Representative Griffin. Have you got some questions for CDC?
Oh, sorry.
Oop. You just turned yourself off again, Representative Griffin. You're on mute.
Oh,
There we go.
Okay. Thank you. Someday I'll get this right, but thank you for your presentation. I have a question. How can people be informed about the ingredients of the vaccine so they can make an informed decision about whether or not to take the vaccine? I know in my family, many of us have allergies that may cause a reaction. And on the main CDC site, I saw that there were reported 2 allergic reactions to the vaccine. And also, what is the recovery rate for the virus in Maine? Thank you.
Representative Connor, do you have some questions?
Yes, thank you, Mr. Chairman, and thank you again, Dr. Shah, for your presentation. My question is the vaccine as high a priority for those that may have tested positive and displayed the antibodies to the virus? Are they as high on the priority list as all of the others? And that's really my question for now, sir.
Thank you. Representative Craven. And then we'll go to Representative Madigan when she's done.
Thank you, Mr. Chair. Thank you, Dr. Shah, for all that you do. I have 2 questions, actually. One is whether WIC beneficiaries are able to use their benefit at the farmer's market. And the other one is, and I've asked Commissioner Lambrou about this because I've had several inquiries that private docs are really not giving guidance to folks 70 and older, and I've had several questions about this, including, my own PC yesterday. He had no idea how I should register to get the vaccine. So thank you.
Thank you, Representative Madigan.
Thank you, Senator Claxton, and thank you, Dr. Shah, for being here. I want to echo Representative Craven's questions regarding direction that private physicians are receiving. How is that being disseminated to them so they can let patients know? The other question I have is, what's the process for determining where the vaccines are being distributed? I've seen the information the department has put out as far as where the vaccination sites are. And I've gotten calls from constituents that there didn't seem to be one in my area. So if we could just have some more information on that, and maybe more is rolling out soon. Thank you.
Representative Zager.
Thank you, Dr. Shah. First of all, I want to thank you for saving countless lives in Maine. I'm very proud and grateful that Maine consistently ranks as one of the very best states in a per capita in response to this historic pandemic. So thank you. Also, just to be brief, what would you do? What do you need from the legislature to be able to do even more? I recognize more money is always useful. That's probably part of it, but what would you do with that money if you could get some more? And what non-fiscal things would you need?
Thank you, Representative Lemelin.
Thank you, Mr. Chairman, and thank you, Dr. Shah. I don't know where to begin. I would like to spend about an hour with Dr. Shah on the COVID issue because I've done extensive research and I've followed the science, and I come up with totally different results. But 2 common denominators keep popping up, and that is that there is a lot of misinformation out there about COVID, and there is extreme fear. And that's something I'd like to see turned around. So I wouldn't know where to begin asking questions because, like I said, I have 100 of them. So hopefully one day, Dr. Shah and I will get a chance to talk about this. But for now, I'll just pass on my questions. Thank you.
Okay, Representative Stover.
Thank you, Dr. Shah and Nancy. Dr. Shah, thank you for your leadership over the past year. I do remember those comments in our committee last year, and I commend you for all you've done. The question I had was about WIC, and I'm just curious, since you were able to transition to the EBT form, have you seen an increase in participants? Thank you.
Okay, Senator Baldacci.
Good morning, Nancy, and good morning, Dr. Shaw. Nancy, are you the Hancock County Beardsleys related to the Beardsleys in Hancock County?
Yes, thank you, Senator Baldacci. I believe that I am from the 1600s or so.
Oh, okay, going way back. I wanted to thank both of you for your passion, public health. Dr. Shaw, you've made a huge difference, and I wanted to echo the comments of Representative Zager, because we really, you're the general, and we need you to let us know, and you're on the front lines, you need to let us know what we need to do to support what you're doing, not only for the COVID issues. The PPP is extremely an important issue. It's one that we dealt with. We had issues with at Eastern Maine Medical or Northern Light, as well as St. Joe's back in March here in Bangor that had shortages. So on PPE, public health nursing, which I consider absolutely critical, I appreciate the presentation on that. And then on the vaccine issue, obviously we need to know what we can do to support all of your efforts. And I want to thank you both very much for your work and your passion. You've made a huge difference, and I look forward to more discussions on this, but the three major areas that I hope to help out with would be public health nursing, PPEs, and vaccine distribution. Thank you, sir. Thank you, Nancy.
Representative Perry, do you have a couple of questions?
I do have questions about a question about distribution, and that's really to when this does come out, and it is for 70-year-olds. Right now, Washington County does not have a distribution site for the vaccine. They are being told to go either to Mount Desert Island or Bangor, which are all at least 2 hours away. So my concern is I've been talking with federally qualified health centers who are ready to do something, not at the 1,000 doses rate because we're such a rural area, but they've been looking at the federally qualified health centers working as one to get the distribution out across the county and to be able to do that. Also, both of the hospitals are looking to do that. Again, I understand distribution is difficult. We are one of the oldest counties in the state, and I've been getting a lot of constituent calls about where can I get it? I can't travel that far. How are we going to get this? So that's my question.
Thank you. Representative Javner.
Thank you, Senator Claxton. Thank you, Dr. Shaw and Nancy today for being with us. I also do echo Rep. Perry's concern about the distribution in Washington County about the vaccine. But I do have two questions. Number one, concerning the N95 mask fittings, who in particular, specifically, who was utilizing the program of fittings for those N95 masks, and how would somebody be in contact in order to make that available to them? And number two, is there an antibody test available to the public for the COVID-19? Thank you.
Thank you. Senator Moore.
I was going to say that Representative Perry stole my question. When it was published on the website the other day, you would believe the phone calls that we all received. I think all the Washington County delegation concerned with no Washington County site. So Representative Perry has brought up the issues that are questions that I actually had as well.
Thank you.
Thank you, Dr. Shaw, for all you do to keep us informed. We look forward to your reports every day, actually.
Representative Meyer.
Thank you, Mr. Chair. And thank you, Dr. Shaw and Deputy Director Beardsley for being here today and for all you're doing for the people of Maine. So I'm going to piggyback on Senator Moore and Representative Javner and Perry regarding the rollout and distribution at the other end of the state, my end, the very southern, far southern Maine. I've had lots of questions from constituents who wonder about their treating across the border in primary care settings in New Hampshire. And they wonder about, I wonder about any dialogue you've had with your counterpart in New Hampshire about those patients. And there are many, many of them. So that's my first vaccine question. My second is, there have been some reports of healthcare providers and vaccine hesitancy or refusal. And I wonder, have there been any discussions about mandating certain clinicians to receive the vaccine? Some other questions that I will certainly shoot over to Molly that regarding public health nursing. I didn't see anything on your slide about the support being given to older Mainers by public health nursing. So a little bit more interest, a little bit more on that subject. And then one final is there any consideration for home care workers being placed in the first group of in 1A? These folks are going into homes, multiple homes daily. And I wonder if there's any discussion around that group of workers. Thank you.
My question piggybacks a little bit on that in terms of what are our plans for the homebound individuals that we're able to keep out of long-term care because of all the support they get in the community, but then don't have access necessarily to visiting nurses. And as far as I know, the local VNA has no specific plans, but some early conversations. And the other one was, I'm concerned about the immunization status for kids because of delayed immunizations and because of the increased requirement for next school year for vaccination. And are we going to need to push that out or do something differently than we're currently doing before we end up excluding a lot of kids through no fault of their own? So those are my two questions. And I want to speak to the format and understand that this, as Representative Lemelin has suggested, is part of a longer conversation. But I appreciate your taking the time now to answer questions and try and give us some of these answers, understanding that you and people from your department will be back in the future to give us a chance to ask more questions.
Well, thank you so much. I am taking a look at all the questions, and I'm going to organize my responses such that I hope I can answer the bulk of these. This will be a communications challenge, but I think we are all collectively up to it. So let's start at the high level, which is how we thinking about COVID. And we are first and foremost grounded, above all else, by using science and data as our guide. My view is that in a pandemic, fear and misinformation can spread much, much more quickly than the virus itself. Indeed, I'm fond of a quote, I think attributed to Mark Twain, which is that misinformation can run its way halfway across the globe before the truth has even had time to put its shoes on. And so that is one reason why early on in the pandemic, even before we had our first case, I was committed to making sure that everyone in Maine had all the same operative nucleus of facts that we had from the US CDC and from the World Health Organization. Those facts are critical to driving our response because they inform the science that goes into the decisions that we've made. That has been one of our bedrock principles from day one. We do not intend to stray from that principle going forward in any fashion whatsoever. The surest way to rebut the concepts of fear and misinformation is to do so straight on with the facts. It's what I've always done from day one. I believe that people in Maine can handle the difficult truths associated with COVID. I won't stop doing that. Now, there were quite a few questions around vaccines and vaccinations, and I will get to those, but there were two in particular that I really was, that I'd like to talk about again, to note that there is so much other work happening across the Maine CDC. And those two were around the WIC program. First of all, there was the question, I'm just making sure I could recall who asked it. A question from Representative Craven around the farmers market. And Representative Craven, I neglected to mention this, I should have during my presentation. But among the reasons I'm proud of the transition to the EBT-based program is that it now means that WIC can be utilized at every farmer's market in Maine that utilizes or accepts EBT in any form. More importantly, and if I may be somewhat immodest and give my team a big high five here, Maine was the first state to make farmers markets part of our WIC network. And so this is an effort, of course, that has manifold benefits. It means that individuals who are recipients of the WIC program have access to fresh, healthy food. It's also a means by which we can support Maine farmers and agriculture all at the same time. Maine was the first state, right, Nancy, to go online with farmers markets as part of our transition to EBT. If we weren't the first state, we were one of the first 1 or 2 states. So I just wanted to spotlight that at the very top, because again, notwithstanding the challenges of the pandemic, we've been running forward and fast in a number of other areas. Representative Stover asked whether as a result of this transition, we've seen an increase in the uptake of WIC, and I do not know the answer to that, but that's a very interesting question that we will find out, because I myself would like to know the answer as well. Now, turning to COVID generally, there were a number of questions around, for example, PPE distribution. Representative Javner, among others, and Senator Baldacci asked about use of PPE, particularly the training programs. The training programs that we have offered, for example, fit testing for N95, have been open to any healthcare provider. That being said, our focus has been around long-term care. Many hospital-based providers who work in the intensive care unit may have already been trained on how to use N95s, but those that work in less acute settings, for example, nursing homes, may not have undergone that fit testing. Indeed, they may not even have the opportunity to be fit tested because for the most part, pre-COVID, wearing an N95 mask was not part of the standard protocol and procedure at long-term care facilities. It most definitely is now. But the programs for that fit testing are open and available to any healthcare provider. We have done those trainings in partnership with not just public health nursing, but the men and women of the National Guard. I do not have the exact number, but the last time I checked, I don't want to get the number wrong, so I won't speculate on it, but it was several thousands of healthcare providers across the state of Maine, and we'll get the exact number, but thousands upon thousands of healthcare providers had gone through that program, making them eligible to utilize an N95 mask. There were also questions around vaccines and vaccination. So that's where I'll focus most of my responses. Let me answer a few discrete questions that came right up. The first of which was from Representative Meyer around home care workers. Representative, they were most definitely part of our first wave, phase 1A. The very first allocations that went out, our first week of operations back in December, we had, I can get you the exact number, I believe it was 900 doses that very first week, when we only received 12,000 doses that went to home care agencies across the state of Maine. We recognize the value that those men and women play in delivering services to people in their homes and the public health benefit to keep those folks safe and healthy in home, as opposed to needing to go to a healthcare institution for more acute care. We have continued those distributions. I don't have the exact number, but I do know that in recent weeks, we've actually pulled back on distributions to home care workers because we have given so many of them at least their first dose. That was a deliberate choice we made in recognition of their importance. Now, more generally, around vaccines and vaccination, be it eligibility or availability. At this time, and to this day, we still remain constrained by supply. We also are in a situation where one of the things that we can do to keep everyone in Maine safe is to get as many shots in arms as quickly as possible. And so as a result of that, in the early weeks, we have focused on providers that can deliver as many shots into arms as quickly as possible so that we don't have doses sitting on a shelf. For me, one of the cardinal sins would be to allocate X number of doses to a location and them not being able to use it, whereas being able to allocate those doses to a high throughput facility that can utilize them without having anything sit on the shelves, that's a way that we can start offering protection across the state. And so for that reason, up until now, given the extremely limited supply, we have focused on the highest throughput providers. That being said, we have made deliberate efforts to ensure that equity remains part of our equation. Again, there are two components, velocity and equity. And for that reason, you will see on our weekly allocations that we have allocated vaccine to sites across Maine that we know are not able to do 1,000 shots a day. We understand that. But we know they have healthcare providers in their facilities and in their communities that need to be vaccinated so they can stay safe and keep providing healthcare. And that's why you will see on our allocation that almost every single week, this week included, vaccine has gone to Northern Maine Medical Center, A.R. Gould, Cary Medical Center, Holton Regional Hospital, Machias, Calais Regional Hospital, Down East Community Hospital. Each and every one of those sites has received allocations most every week since our process. Has it been enough? Not even close. There's not enough vaccine anywhere in the state. Writ large, we've only received about 115,000 doses, not even enough for 10% of the population. But we have been forced to put that in. We are forcing those institutions to get those into arms as much as we can. We know that there is disparate need across the state. We are hoping to start balancing those scales as we start getting more vaccine. Let me now turn to questions around, I'm going to just start at the top and go back to some issues that I think I can address somewhat more quickly. There were questions around the composition of the vaccine. The ingredients for the vaccine are listed on the manufacturer's pages. Those pages, those so-called information sheets, are given to, or we ask providers to give them to every single person before they receive the vaccine so that they know exactly what is going into their arms. And if they have allergies to any of the components, they can alert the provider and be monitored for the appropriate time so that if they do have a reaction, there are services available to it. Finally, before I take a break, I will answer just two last questions. The first is a question again from Representative Meyer around cross-border vaccine and vaccinations. That's an issue that remains under discussion. There are two components to that question. Well, the first is, what about folks who live on the border? Representative Meyer, I know you're from Elliott, from down south, so this is certainly top of mind for you. What about folks who live in New Hampshire and get their health care in Maine, and vice versa, Mainers who get their health care in New Hampshire? Right now, as of this moment, our recommendation is that folks be vaccinated in their state, notwithstanding where they may receive their health care. Why? Well, that's because allocations to the states are driven by the state's population. And thus, the allocation that comes to Maine is calibrated to our population. And that's why we recommend, even though it may be inconvenient, that folks get vaccinated in the state in which they live, be it New Hampshire or Maine. That may change if the allocations change, and certainly if the supply increases. So there's much more to come on that, but that's our view as of right now. And then finally, let me zoom out one click to talk more generally about immunizations. To Senator Claxton's questions, we too are concerned about delayed immunizations that may have occurred across the state. The last time I took a look at the data, what I saw was that thankfully, the youngest of the Mainers, those 5 and under, their vaccine rates had actually not suffered a diminution. But we did see a drop as recently as October in adolescents who had received their latest vaccines. I have not seen those data for the last quarter of last year. Those are being prepared right now. But Senator, I share your concern that because of COVID, other forms of healthcare generally may have been delayed or deferred, be they vaccinations or other preventative health care, mammograms, colonoscopies, other types of prevention. In your case, we are concerned with that as it relates to the introduction of vaccine and vaccination efforts for the upcoming school year. We still think that there's ample time in which folks can meet the requirements of last year's legislation. But if we find that that's not the case, then certainly we will keep tabs on those data. I'm going to pause. I know there were more questions than I answered, but I believe I've captured many of the themes. But Senator and Representative, Chairman and Chairwoman, happy to go back to any of those as you see fit.
Oh, Senator, you're muted. You're still muted, unfortunately.
Like I said, making mistakes as fast as I can so we can fix them. Thank you again for being here, Senator Dr. Shaw. I want to acknowledge that this is sort of a frustrating format since there's a whole lot more questions than there are time to answer them from right now. But I know Molly is working on carving out some other time down the road for other people from CDC or yourself to come back and try and answer some of these questions in greater specificity and with more flexibility. But I did want to make sure everybody had a chance to ask some questions, and that's why we formatted it this way. I have another 8 or so that I'll be sending to Molly and our analysts to make sure that those get in front of you too. But having this time with you is greatly appreciated. And as with most things, some of the answers generate more questions. So I anticipate that the rest of the committee will be submitting some more questions, which will be part of the conversations to come. Was there, in the time remaining, did you want to speak to things on your list? We have about 3 minutes, wanting to respect your time.
Well, you know what, Representative Zager, amongst others, and Senator Baldacci, that's what I should have ended with, made the very gracious and thoughtful offer of what do we need in order to get where we want to go. And Representative Zager, as you noted, funding is a perennial challenge. And I mean, so I'll answer your question, and I hope what is a helpful and constructive way, which is if funding were available, and I recognize that funding is tight given the fiscal constraints that all states and Maine are under, all states as well as Maine are under. But I will give you, I'll hopefully be able to provide a bit of a snapshot on, as it relates to COVID, but generally where we see the need for funding. As it relates to COVID, there are a certain category of things that I'll zero in on, specifically on vaccines and vaccination, for which additional fiscal support would be of use. Let me first start with one of the core elements of vaccination, which is vaccinators. We need folks to get shots into arms. Now, we can do so in partnership with healthcare institutions, which we are working on, but having additional individuals who can serve as vaccinators, who can say, go out into the community to, for example, Senator Claxton's point of serving those who are homebound, serving those for whom are in rural areas, for whom even for a drive to a larger center is out of bounds. Having that team, that force of vaccinators whom we can deploy to large employers, to the homebound, to rural areas, to schools when the vaccine is authorized, that will be essential to getting uniform coverage across the state. Another thing that funding could be essential for is not something that folks like to talk about, but is instrumental to our success or failure, and that's the IT system. It's all well and good to do stuff, but we've got to be able to track what we do, look at the data around what we do to determine whether we're doing the right thing. I've told my team that every morning I want to know not just how many people we vaccinated, but the answer to a harder question, which is, did we vaccinate the right people? And having answers to those questions relies on a robust data and IT architecture. It's not the most glamorous thing, but it is just as vital to our success as is anything else in state government. I could go on and on about other areas for which funding is needed and what we could do with it, but in our limited time, those are two that I know are top of mind for my team right now. But I appreciate that question, and I will, if I may, take it as an invitation to talk more about it in the future.
Thank you again. I appreciate that. So I think at this point, understanding that people have obligations and plans, we'll take a 1 hour break, reconvene at 1 if that works for you, Molly, still, and continue with our opportunity to get to know at least at preliminary level some of the departments in DHHS. So thank you to Molly for coordinating this morning. Thank you for Nancy and Dr. Shaw for being here. Good to see you again. And at some other time, I'll ask you what keeps you up at night again, Dr. Shaw, but not today.
Not today.
We have enough other things. We'll take a break now. Please leave your microphones off. I don't know how Carrie's going to work it in terms of turning off the Zoom or whether we leave it active or not. But if your microphone is off, that's a good thing. And that way the other people aren't privy to conversations that aren't part of our committee work. So thank you all for being here this morning, and we'll look forward to sitting down. Carrie, did you have something you wanted to contribute to that?
Yes, the Zoom will stay active, so muting and turning your video off is recommended.
Thank you very much. Have a good
Thank
lunch,
you, everyone.
everybody.
Thank you.
Hi, Holly.
Good afternoon, Representative Perry. How are things at the other end of the coast?
Oh, busy. Been doing a lot of volunteering at the COVID test site, so getting a sense of how much there is around us.
I saw you had a big drug bust. Congratulations.
Oh, yes. Yeah. Yeah. You know.
I would remind everybody that this is being recorded. Just saying.
You're okay, I think. The hard part is we can't have any of these little conversations that have nothing to do with what we're here for.
How many testing sites do you have?
Well, we actually have now, because we have the 2 Walgreens sites, and then in Calais is the hospital and the University of Maine in Machias. So those are the sites, but the hospital site, it seems to be the busiest site.
Same here.
Yeah, we're here every day from 8 to 10. And there was one period of time we actually in 2 hours, or a little more than 2 hours, did 174 tests. So it's a lot, sort of like a drive-through or walk-through site. So you just come in.
You did 174 tests in 120 minutes?
Yeah.
Wow, good for you.
Yeah, we figured we were at least doing a test a minute, the way it was going.
Less than, according to my math.
Well, I would say we went over the 2 hours that day.
Okay.
You can only go so fast.
Oh, I'd like to welcome Ms. Probert from the Maine Office of Maine Care Services. It looks like we have a caucus of 7. Welcome. And there's Molly. She's joined us too. So now she can do introductions. What we've been doing, Ms. Probert, is having somebody do their presentation and then giving the committee an opportunity to ask the questions, understanding that there probably won't be time to get all of the questions answered. But we found that we can put Molly in charge of that, and that's working great for us. So we'll start there. Okay, let me check the chat and see what I'm supposed to know. All right, I do know that you're here, Ms. Probert, so I'm going to defer to Molly at this point for the afternoon session starting at 1 o'clock.
Great. Thanks, everyone. We'll briefly introduce Michelle Probert. She's our director of the Office of Maine Care Services and served with the department in the past, and then did some work with a number of organizations, including Bath Iron Works and with the Healthcare Purchaser Alliance around value-based purchasing. And we are glad to have her at the helm at the Office of Maine Care Services. So I will hand it over to Michelle.
Before you start, Michelle, would you like to know any of the people, other people on the committee who are new here? So just so we can play faces, we'll start on my upper left. Senator Baldacci, you want to introduce yourself?
Sure. Michelle, I'm Joe Baldacci from Bangor. I previously served on the city council, and I've been an attorney in Bangor for 29 years. Nice to talk with you today.
Thanks, nice to meet you.
Hi there. I'm Michael Lemlin. I'm from Chelsea.
And Representative Zager.
Hello, Sam Zager from Portland, District 41. Thank you.
And the rest of the people over here should look at least vaguely familiar from about 2 years ago. So I welcome you, starting when you're ready.
Great. Thank you very much. Good afternoon, everybody. As Molly said, my name is Michelle Probert. I'm the Maine Care Director, and I've been in this role for getting close to 2 years. Senator Claxton, Representative Meyer, and members of the committee, thank you for having me today. And I look forward to introducing our office to you. So First, I'll just give a little warning that my daughter has band practice at 2 p.m. I have told her, which I tell her every week, to remember to close her door, and my door is closed. But if you start wondering like what that, saxophone noise in the background is, it's my daughter, but hopefully we'll be in good shape. So I'll start off by saying that Medicaid is very complex. Even though I have worked in Medicaid for many years now, I learn something new on almost a daily basis. So I ask you to bear with me through this presentation. I'm glad that you are all in Health and Human Services Committee, because I think that increases the likelihood that you will find this interesting, but there's a lot of details. So I will try to not get bogged down in them, and my goal will be that no one falls asleep. So I will start sharing my screen. I wonder if you all play Zoom bingo in terms of the things that, the bloopers that happen over and over again and what you hear people say. All right, bear with me. All right, Molly, is that the proper screen and not the weird black one?
Yes, yeah, you're all set.
Okay, excellent, thank you. Sorry, I'm gonna switch the screen because otherwise I'm gonna get confused. All right, there we go. So the first question to start with is, what is Medicaid? And at the very basic level, Medicaid is coverage for low-income Mainers so that they can work, they can be a part of their communities, and that they can otherwise live healthy lives. So Medicaid is health insurance, and MaineCare is Maine's version of Medicaid. It is really easy to confuse Medicare and Medicaid and MaineCare as the name for Maine's Medicaid. Maine public confuses it on the radio, the papers confuse it, and our new president has actually confused Medicare and Medicaid in the debates that we had a number of months ago. And so this might be really old news for a lot of you, but just as a reminder, Medicare is a national program. It is centralized out of the federal government, and it is for individuals who are over age 65 and or disabled. And so it is really a single program. Medicaid, on the other hand, is really a partnership between states and the federal government. Every Medicaid program is different for every state. Every state has to contribute its own funding to the Medicaid program, and that the amount that states contribute varies every year, and it is specifically based on how the average income for a state compares to the national average income. And so right now in Maine, for example, if we were not in a pandemic, our state percentage that we have to pay would be at just under 64%. The range across the country is from as low as 50% to as high as almost 78%. And another helpful thing to know, especially I think from a legislator's perspective, is that for the vast majority of changes that we make to the MaineCare program, we need to get permission to do so. And we need to get permission from the federal government. And we also need to go through rulemaking in the state of Maine. And so, especially because we have the federal component there, it is not often fast for us to be able to make changes within the MaineCare program as much as we would like it to be. So that's a little bit about difference between main care versus Medicare. I also just wanted to give an example that when we say low-income Mainers, what are we talking about in terms of an income level? And just to kind of ground folks, an example is that a family of 4 in the state of Maine would need to make about $36,570 or less annually in order for everybody in the family to be eligible for main care. And it gets a lot more complicated than that. Your income needs to just be the taxable income. It depends on whether you have a disability, and there's lots of other complications, but that's just an example so that you can kind of get a sense of income level that we're talking about. Okay, so this is a slide that's from the Kaiser Family Foundation. They put out these nice 2-pagers on actually every state Medicaid program, so it's helpful to look at. I will call your attention to the fact that this is from October 2019, and so it is already outdated, and it is even more outdated than it would normally be because since October 2019, we have continued to expand Medicaid. And also there has, again, been a pandemic, and so that has certainly changed the context that we're dealing with. But it's good for folks to know that about a quarter of Maine's population can be considered low income using the definition of looking at 200% of the federal poverty level. As of October 2019, about 18% of Maine's population was covered by either Medicaid or CHIP. However, since then, we are now actually at about a little over a quarter of Maine's population being covered by Medicaid or CHIP. And again, that is due to expansion, as well as some other factors that I will get into later in the presentation. When you think about your constituents, I just love these statistics because it's just really illustrates how widespread Medicaid is and how widespread main care specifically is in the state. So these numbers for adults are, again, a bit outdated now, and I haven't done the math. It might be up to 1.5 people per 7 adults, ages 19 to 64. But we're talking about 1 in 3 children, 2 in 3 nursing home residents. Interesting to note that over 2/3 of adults on Medicaid are working, are employed, and a little bit less than half of children who have special healthcare needs are on the Medicaid program as well. So in short, Medicaid members represent a substantial portion of your constituents and their families. Okay, so this is the main care organizational chart. It probably looks pretty small for you, but certainly I'm able to send it along if you'd like to see people's names as well as a better view of their faces. Right now, we have about 166 employees within the Office of Main Care Services. The vast majority of those are state employees. We do have a number of contracted positions that are instrumental and very important to the main care program, but were kind of left over from the last administration when they had filled some necessary spots with contract slots. So that is something that we continue to try to deal with and work our way away from. So what does the Office of Main Care Services do? Again, main care is health insurance. And so a lot of what we do is we really administer a health plan. Just when you think about health plans in the state of Maine, like Anthem and Harvard Pilgrim, we are a health plan and we are a large health plan. Albeit we do have a much broader scope of services than a typical health plan, so that makes our jobs a little bit more complicated. Starting on the left side of this screen, a lot of what we do is therefore related to operations of a health plan. So we enroll providers, we pay and adjust claims, we have audits to make sure that our payment and billing are accurate. We have customer service call centers for providers as well as for members. We have ways to manage utilization through prior authorization as well as through care management activities with members as well as with providers. We have efforts as required by the federal government to protect against fraud and abuse. We make sure that our providers are in compliance with our regulations. We also act as stewards of taxpayer dollars, and per federal regulation, Medicaid is supposed to be the payer of last resort. And so if somebody else has other health insurance, we need to make sure that that other health insurance is paying for things before Medicaid, before main care kicks in. We do a lot of communicating to our providers. We also, as required by the federal government, have a Medicaid Advisory Committee that is the Main Care Advisory Committee, or the MAC in Maine. And we meet monthly with that group of stakeholders and have a lot of helpful and actively engaged conversations. So that is most of the left side of this org chart that you see. We also have an analytics team. That analytics team does everything from actually setting rates to analyzing our claims and enrollment data to inform our finances, our budget, as well as the effectiveness of our programs, which is a direction that we are trying to move in more and more. We have a whole policy unit. Again, that policy unit is constantly working to get the federal authority we need to make changes to our programs, as well as go through rulemaking. And almost every single time there is an LD that passes into law that that impacts the main care program, we have to go through that federal and state process. I will call out the term spa, because when we talk about spas, it may sound like we're talking about facials and steam baths, but we're actually talking about state plan amendments with the Centers for Medicare and Medicaid Services, or CMS. So the SPA, or state plan amendment, is the most common way that we need to get authority for changes to the main care program. And lastly, I will mention our value-based purchasing unit. I'll be talking about that one a little bit more in this presentation, but that is really where we have efforts to try to move away from just paying for volume of services towards paying for value of services. So the previous slide, I talked to you through a little bit of what we do every day. These priorities on this slide reflect how we are moving main care forward under numerous initiatives. So these are our priorities, and all of our initiatives align with these priorities. And we developed these at the beginning of 2020 and have checked in with the main care team as a whole, and are in agreement that even though our world has changed a lot, even with COVID, these still remain our priorities, and we still are making progress on all of these fronts. So improving the health of Mainers by expanding access to needed service. I'll give a couple examples for each of these. Clearly through main care expansion, as well as under COVID, we have been achieving number one. Number two, ensuring that main care benefits, rates, and payment methods incent high value care. I just mentioned our value-based purchasing unit. That is what they do on a daily basis. And I'll also talk to you a bit later in this presentation about our comprehensive rate system evaluation that we are rolling out the results of as of last month, and that continues. Strengthening our technology, systems, and skills to maximize our efficiency and effectiveness. So we are rolling out a regular semi-annual trends report for main care. I think it has been quite some time since main care has done that, and that is an effort that we will be communicating and sharing with you as legislators as well. We also are finishing up conducting a strategic assessment of our Medicaid management information system, which is a large effort, and we have to deal with a lot of systems IT as main care, so that's critical as well. Culture of compliance and maximizing our federal dollars. A lot of our work around budget savings initiatives this year was saying, are we taking advantage of every opportunity we have to get the most federal match that we can get? And that's a discussion that we've been having, not just for main care, but also for our sister offices, many of whom do a lot of work that directly relates to main care as well. And then lastly, we care about our team and want to make sure that they are engaged and well trained and feeling supportive. So I just mentioned our sister DHHS offices, the Office of Main Care Services does not operate within a bubble. A lot of our staff, as I said, is operating a health plan. And so we really rely on the deep expertise of our sister offices who work with our member populations and their providers. And we have a team approach to pretty much every policy change or rate change or initiative that we are working on. I also wanted to call out specifically the Office for Family Independence. Many people in the state of Maine do not realize that when you apply to Maine Care, the Office for Family Independence, or OFI, is actually the office that is responsible for your Maine Care application. They have a single application process that also looks at food stamps and TANF, and so it's integrated from that perspective. And in addition to owning the application process, OFI is also in charge of maintaining authority for eligibility changes. And so eligibility, as I mentioned earlier, gets super complex for Medicaid in general and Maine Care specifically. And so they are really the subject matter experts on all of those nitty-gritty details. I wanted to give a shout out to the Maine Care Benefits Manual. This is where every little detail of every service that we cover is laid out. I don't know why I don't just bookmark it, but I Google Maine Care Benefits Manual all the time, because whenever I have a specific question about one of our services, that's where I go. And I would encourage you to do the same. They're very comprehensive documents that tell you everything about eligibility for the service and provider requirements and what the services are. So it's a really handy tool, and our rulemaking is what results in the Maine Care Benefits Manual. And just really briefly, so it's split into 3 chapters, but there are many, many sections, and you'll hear people speak in sections of policy for Maine Care. And those sections are the sections of the Maine Care Benefits Manual, and they align with the services we cover. They fall into 3 different chapters. Chapter 1 is a general chapter that really applies to all services within Maine Care. Chapter 2 is where we have the services and criteria for each specific service that we cover. And then Chapter 3 is where you look to see how services are paid and what dollar amount they're paid for each of those sections of policy. All right, so speaking from a federal perspective, what does Medicaid have to do? And therefore, what does Maine Care have to do? So the feds, CMS has mandatory services that we have to cover and mandatory populations. But there are a lot of services and populations that are optional, and it's at state discretion whether or not we choose to cover those. Services have to be statewide. So, everybody loves the idea of a pilot for a new approach. With our Medicaid program in Maine, we really can't do pilots unless we get a specific waiver from the federal government. And I'll talk about that a little bit more later. But we have to have any service we offer generally has to be available to the population statewide as a whole. We also need to make sure that members are able to choose their providers. So unlike the private purchaser side of things, we can't restrict members to only seeing a narrow network. They need to be able to go where they want to go. Services also need to be shown to be medically necessary. So what is mandatory? A lot of this is what you would expect for most health plans. I'm not going to read through all of these, but I do want to call out a couple exceptions. So nursing facility care, I'm sure you're all aware that Maine Care and Medicaid covers nursing facility care. That is not typical with commercial health plans. I also want to call out that we are required to cover the cost and provide rides to non-emergent medical services. So if a service is covered by Maine Care, we have to be able to get members who do not otherwise have transportation to that service. And that is also not typical for our commercial health plans in the state. that is what is mandatory, what is optional. So these are technically optional services, but I'm going to wager a guess that we probably would agree that we don't really, as people and as government, regard most of these services as optional. For example, prescription drugs, pharmacy is optional. If the state of Maine wanted to say, we don't want to cover pharmacy, that is allowable under federal law. We know, I would further point out that a lot of the services that are listed on this slide are really critical to member health, and also we know are helpful to prevent downstream member health issues and costs. And so when you think about preventive services, podiatry, which is really important for our older Mainers, dental care, physical therapy and occupational therapy, which we know can be really important to keep people away from opioids when they're having issues, home and community-based services to keep people out of institutions. These are all good services that we believe it makes sense to invest in so that, again, people stay healthy and also don't rack up even more costs further down the road. All right. So like health plans, MaineCare has different, what I will call benefit packages. And those different benefit packages have different eligibility requirements. So we usually just talk about MaineCare as a whole, but there are a lot of different groups. Generally speaking, and the eligibility, as I said, differs depending on what benefit package somebody is receiving. So generally speaking, our eligibility, you're going to see higher percentages of the federal poverty limit for children, for pregnant women, for people with disabilities. The groups that are on this slide are all full benefit groups. And so this is really sort of, these are our full benefit packages where there aren't restrictions to the kinds of benefits that you can receive. So just as I was talking about that there are certain services that the federal government considers optional, there are also groups of people who the federal government considers optional. And I've indicated with a couple asterisks the groups that we cover in Maine, but that from the federal perspective, we don't have to. And so that includes CHIP, which stands for the Children's Health Insurance Program. CHIP basically extends Medicaid coverage to additional low-income families. And also under CHIP, you can charge premiums. So you can charge for the cost of healthcare, which you can't for kids under regular Medicaid. So that is optional. Katie Beckett is an optional program. Katie Beckett is for children who have very serious health conditions. And then also we cover individuals up to age 26 in the state of Maine who were a part of the Maine foster care system. And that is also optional. That's an optional population for us to cover. This is another slide of groups where we offer full MaineCare benefits. So our expansion adults, as I'm sure you all are aware, Medicaid expansion was optional. So this is a group that at the top that we do not have to cover. I also wanted to call out that, as you're probably also aware, but for that expansion population, we get a 90% federal match. And so that is an exception to our regular federal match. I also want to call out on this slide where it says Medicare Savings Program. So I'll show you a few other categories for this program on the next slide, but the SLIMBY and QUIMBY is how you say those acronyms, and please don't ask me what they stand for because I forgot to write that down. But basically, you will hear this group often referred to as duals or dual eligible, meaning that those individuals have Medicaid as well as Medicare. And so MaineCare covers the cost of their cost sharing for Medicare, but then in addition, for these full benefits, MaineCare also provides additional services and benefits. And then moving on, so those were all of our full benefit groups. And then we also offer more limited benefits under Medicaid. That includes our HIV/AIDS waivers. So individuals who otherwise are not eligible for MaineCare because of their income levels, but that have HIV or AIDS, we provide coverage for those individuals. We offer a package of limited family planning benefits, again, for individuals who otherwise wouldn't be eligible for main care. Both of those benefits and populations we do not have to cover from the federal perspective. Emergency main care. So this is a limited benefit. It's as it states, it's only for emergencies. That includes labor and delivery, but this is a benefit that we're able to offer for non-citizens who do not have documentation from Homeland Security. But we cannot cover services to be able to sustain their health after an emergency. It's only in the emergency where we can cover those individuals. So we do have to provide that emergency Medicaid. And then justice involved individuals, so individuals who are incarcerated or detention facilities, we can only cover the cost of inpatient care for those individuals. So especially with main care expansion, our colleagues at OFI have really worked hard to make sure that individuals who are in our prisons and elsewhere get on main care, because then as they transition back into the community and have ongoing healthcare needs, that just helps us make sure that there's not a gap in coverage and that those services are able to continue. All right, other limited benefits. We're getting close to the end of these benefit slides, I promise you. So these are where the other duals show up, where we're only covering the cost share for Medicare and not additional benefits. And then we also have a program called the Private Health Insurance Premium, or FIP program. A lot of people aren't aware of this, but it's a great benefit. And basically, for individuals who may, for example, have healthcare coverage through their employment, but they're still eligible for main care, this gives them an incentive to get on private coverage as well as main care. We will pay for their cost sharing, so we'll pay for their premiums and deductibles, et cetera. And so it saves the member money to get their own private healthcare. It also saves us money because their employer has to pay first. And so with this program, we have to demonstrate to the federal government that it is cost effective, but it's really a win-win program. And so we are working on efforts to make sure that people are more aware, and employers are more aware of this program. All right, and so another thing that folks may not know is that main care administers a number of programs that are not technically considered Medicaid, because when we say Medicaid, we're really, again, talking about that federal and state partnership. And so we have services that are covered 100% with state dollars, and so they're not really Medicaid, although main care administers the programs, and we consider them to be main care programs. And so this includes main RX, as well as drugs for the elderly, or DEL. Those are both discount drug programs. Those are completely state funded. We have a program in partnership with Maine CDC that offers breast and cervical cancer screening to women who are otherwise over income for main care. As of a little over a year ago, we pay state funds to cover abortion services for women who are on main care, but we cannot cover the costs of those abortion services with federal funds, because the federal government will only pay for abortion services in the case of rape or incest, or if the life of the mother is at threat. And then under COVID, we are also offering a program that specifically covers the cost of testing and testing related services for uninsured individuals for COVID-19. And so that is a new non-Medicaid program that we are administering. So this is a little matrix that divides the populations and services into mandatory and optional, like I've been referencing so far, just to give you a sense of, again, this is from the federal perspective, what we have to cover versus what we don't have to cover. And it's interesting to see that the quadrant where we spend the most, if you will, is actually optional services for mandatory populations. So that is where over half of our spending is. And I've just put one bullet in each of these quadrants that shows you the biggest cost driver in each quadrant. So it's not a list of everything, but you'll see in that upper right quadrant that Section 21, that is one of our home and community-based waiver services for individuals with intellectual and developmental disabilities. And so that is an option. Home and community-based services are optional services. And so that is really what is driving a lot of our costs into that upper right square there. Following that, our second area of greatest spending at 31% of spending are the mandatory services for mandatory populations. And the biggest cost driver in that bucket are nursing facilities, which are rounded to the nearest million. We spend just about as much on nursing facilities as we do specifically on the Section 21 home and community-based service waiver. Okay, so I just mentioned waivers, and someone may say, what is a waiver and what is it waiving? So I mentioned our SPAs before, which are state plan amendments, and that is how we get authority to cover services with the federal government, generally speaking. If we want to do something different, or if we want to be able to waive one of the requirements I mentioned earlier, such as statewide-ness or choice of provider or certain eligibility requirements, those are instances where we need to get a waiver from the federal government. In Maine, you'll often hear people talk about waivers, and they're using that as shorthand for home and community-based service waivers, because we have a number of those in Maine, and so we talk about them a lot, and we call those the waivers. But just to be clear, there are other kinds of waivers, and we have additional waivers in the state of Maine. So it's good to know that distinction. I want to point out that it is not easy to get a waiver with the federal government. So state plan amendments, SPAs aren't easy either, but waivers are much more complicated. There's a special application. There are requirements, extra requirements around monitoring and evaluation. You have to go through renewal every 5 years. And it also takes longer to get approval. With state plan amendments, CMS gives themselves a mandatory deadline for review. They don't do that with waivers. So you really don't know how long it's going to take for CMS to review and approve a waiver for you. So starting with the waivers that we don't talk about as much in the state of Maine, a 1915B waiver. Back up for a second. So these are three different kinds of waivers. These are the big waiver buckets from the federal government perspective. There's the home and community-based waivers. There's the managed care waiver. And then there's the 1115 research and demonstration project. So the 1115 is where any kind of pilot approach would need to go. So we do have a 1915B waiver, and 1915B waivers are where you're waiving member choice. And what is the most well-known kind of waiver in this category is for managed care. And so Maine is one of only 8 states in the country that doesn't have a managed care organization that is at risk for essentially administering the program and paying providers for care. In a managed care situation, that managed care organization can direct members to where they receive their care. Again, kind of like when you think of our commercial health plans and have narrower networks, it's the same thing with a managed care organization. A different kind of managed care, though, is specific to non-emergency transportation. And we have what we call a brokerage system for non-emergency transportation in the state, where a broker actually gets a capitated amount and is at risk for making sure members get the transportation they need. And that is considered a managed care program by CMS. Under the 1115 waiver, so we have an HIV/AIDS waiver. It is the only waiver of its kind in the whole country. we've demonstrated, because we have to, that it is an effective program. And we just last year were able to get a 10-year renewal, which is very uncommon for this waiver. And then exciting news is that as of just last month, we got approval from CMS for what's called an IMD exclusion waiver. So that, without getting into lots of details, that basically means that our substance use disorder residential treatment facilities are now going to be able to expand capacity beyond 16 beds. Because Institutes for Mental Disease, or IMDs, CMS generally caps those at 16 beds and will not pay for adult care for institutions that are bigger than 16 beds. So this is a waiver that we've gotten that will enable us to expand capacity. We also have proposed some pilot programs within that 1115 waiver that we're excited about that are aimed to help reunite parents in substance use disorder treatment with their children and provide them with evidence-based services. Those pilots are still under review, so we do not have approval for those yet. And then we have our home and community-based waivers. And again, if you hear somebody say waiver in a state of Maine, this tends to be what they're talking about. We have 5 different waivers. These waivers are enabled or are intended across the country to be able to keep individuals who would otherwise need institutional care in their communities. And so the services they receive can be habilitation services, community supports. With our Section 21, that includes waiver homes, and these sorts of services, we provide them to individuals with brain injury, older adults, adults with physical disabilities, our members with intellectual disabilities and autism spectrum disorder. So this is a map from the CMS website. If you Google Medicaid and CHIP scorecard, there's a lot of interesting information on this website that compares different states and provides lots of metrics. So this is a metric that CMS looks at where they're basically looking at how much do you spend on home and community-based services as a percentage of your total expenditures on what they call LTSS, which stands for long-term services and supports. And so long-term services and supports includes all your nursing facility care, home care. So basically your whole bucket of anything that is supporting individuals who really need very long-term care. This map in particular looks at all home and community-based service expenditures. And so in addition to the populations I mentioned that Maine covers for HCBS, other states also have behavioral health home and community-based waivers. And so this includes those expenditures as well. So for the states where this data is available, which is all of the states that have a color here, this is basically split into 4 about equally sized quadrants. And Maine falls in the second highest quadrant, showing that we are at between 52.5 and 60.8% of our long-term services and supports expenditures go to home and community-based services. They didn't give specific percentages by state. You couldn't click on the states like you normally can, so I just know that we're in that range. And CMS shows a number of these different maps splitting out the HCBS services for specific populations. And in all cases, Maine ends up in the second quadrant of states, with the only exception is for behavioral health, which is not surprising because we don't have a home and community-based services waiver for behavioral health. All right, so now I'm going to switch to talking through some numbers from the program, starting out with a look at enrollment. So this is a simplified look at all those different benefit packages that I shared with you before, just looking at demographic populations. And so as you can tell from looking at this slide, the biggest single group that we serve is children. Following children is the expansion population. I will note, though, that you could combine some of these columns and get a different view on things. So, for example, if you combined our aged population with blind and disabled, that's almost an equivalently sized group as children. And then similarly, if you combined our Medicaid expansion population, which is childless adults and parent caregivers, if you compared that with our lower income parents, then that comes in at just about 110,000. And so those are sort of pretty roughly equal populations when you look at kids, age blind and disabled, and then non-disabled adults. So those three populations are pretty equal in the state of Maine. This enrollment chart looks at all of our programs, including the state-funded programs. And so if you look at the DHHS website, there is a chart that just shows the numbers, I think, for Medicaid and CHIP. It's always a challenge with Medicaid numbers is that you're never quite sure how somebody is counting them because there are a lot of different ways to count how many people are on Medicaid. So this chart, again, is looking at all of the programs that MaineCare administers, which does include those, for example, prescription assistance programs that are not technically Medicaid. If you looked at just the Medicaid and CHIP numbers, we are at about 330,000 as compared to this number here, which is a little over 380,000. So that's the difference of looking at those state-funded services and services that aren't Medicaid. So as you can see, we were on a downward trend through June of 2018. January 2019 is when we expanded Medicaid, but we did so retroactively to July of 2018. And so you can see quite a jump from June 2018 to June 2019, and that is due to Medicaid expansion, quite straightforward. You see another jump from June of 2019 to June of 2020. So as everyone is well aware, that is when the pandemic hit. Along with the pandemic, the federal government increased the match that they make available to states during the public health emergency. And so even though generally our match percentage is just under 64%, during COVID right now, it is at 70%, meaning that the federal government is, with exceptions for enhanced groups like expansion, the general rule is that the feds are paying 70% of services. As a requirement to states that wanted to take advantage of that enhanced match rate for the feds, and that basically means every state wanted to take advantage of that enhanced match rate, CMS put in place maintenance of effort, or MOE, requirements. And the requirement was that if someone was on Medicaid in March, they could not lose Medicaid during the public health emergency in order for states to continue to take advantage of the enhanced federal match. And so everybody who's been on Medicaid since March has stayed on Medicaid. That includes individuals who typically would have lost Medicaid because of a job change or any kind of reason. The only exceptions had been if you passed away or if you moved out of state. Those were the only instances in which individuals were coming off MaineCare in the past number of months, unless they chose to come off MaineCare because they wanted to. In December, the federal government did offer some additional guidance around maintenance of effort, and they said, okay, now it is okay for you to change somebody's eligibility group. Previously, we weren't allowed to do that. They said, now you can change somebody's eligibility group as long as they're like getting the same tier of coverage, and CMS defined what those tiers are. So that means that now there's a little bit more flexibility to sort of switch people around into what benefit group they're eligible for. But on the whole, we are still serving more people than we generally would. And you can see that is a big part of the reason why enrollment numbers have jumped again. In addition to maintenance of effort, there's also, we had projected ahead of time that we would see expansion numbers continue to rise. And then obviously with increasing unemployment, we would expect more people to come on main care for that reason as well. And unfortunately, it's hard for us to be able to split out like what is due to MOE versus expansion versus unemployment, because they all kind of meld together. But those are three factors that are driving our enrollment overall. It's good to keep in mind that when the public health emergency ends, when it's declared over, CMS has issued some guidance, and generally, I don't have all the details because a lot of it involves Office for Family Independence, but we're going to have about 6 months to unwind, CMS is calling it. And that means that people who are technically not eligible for Medicaid are going to have to come off the program. And that doesn't just happen with a snap of the fingers. That's a lot of people who will need to be processed. And so CMS at this point is saying, you're going to have about 6 months to get everybody off the program who is no longer technically eligible. So that's just a heads up that when the public health emergency ends, there are going to be declining roles, declining enrollment in the main care program. All right, so those were enrollment slides. This is looking at total spending. I will point out that, so this jump from state fiscal year 2019 to state fiscal year 20 is about an 8.5% jump. That is an increase in overall spending. However, the state expenditures, if you look at the blue portion down here at the bottom, state expenditures actually fell. So state expenditures fell by about 3.8%. So even though we had increased enrollment and a lot of increased enrollment, we had that expanded federal match. And we also know that there was a downward impact on utilization that also mitigated the increase in spending. This is another way to look at spending. So the previous chart looked at total dollars. When you look at things from a per member per month perspective, it basically takes enrollment out of the picture and says, okay, like how did the cost of Medicaid main care, how did it change on a person by person basis? From 18 to 19 state fiscal year, we went up about 2.9%, and then from 19 to 20, we went up about 2.78%. Why would the per member per month rates go up? A few reasons. One is when we increase rates, the payment rates for care, those costs go up. Also, when utilization increases, our costs go up. And some of the time, the reason why utilization increases is if the needs of your population changes and they may need more care. There's also utilization that happens that's not related to how much care somebody really requires, but those are factors that contribute to that increasing per member per month. Just for context, I think it's helpful to see that the Medicaid, the medical inflation, the medical care CPI for this period, they don't go by our state fiscal years, but it was 2.8%. And so we are right around 2.8%, which I at least find a little bit comforting that what we're seeing within the main care program isn't out of whack in terms of general inflation for medical care overall. The caveat here being, of course, that half of our fiscal year 20 was not a normal year, right? So we still need to see what the impact will be there. Okay, I feel like I'm on a marathon sprint here, but I've still got half an hour left. So I'll see if I can get through the rest of it. I see some raised eyebrows. All right, so accomplishments, moving on from the data. Our main care expansion has certainly been an accomplishment. The number you most often hear is our point in time measurement of who is enrolled in main care right now through expansion. And that number has exceeded 70,000. We're at 71,000 right now. However, if you count the people who have had expansion at some point over time since we expanded in January of 2019, we are getting really close to 95,000 total people who have benefited at a point in time, which is a big number and very exciting in terms of the access we've been able to provide to healthcare for low-income individuals in the state. I also just wanted to share that when you hear about Medicaid expansion in general, you hear of pent-up demand, which means that when people get healthcare who may not have had consistent healthcare or coverage for a while, there may be higher utilization at first, and then that utilization may go down over time. And that is what we've been seeing with our main care expansion population between fiscal year 19 and 20. Inpatient hospitalization utilization has decreased by 21%, and emergency department utilization has decreased by 26%. That was the case, that decreasing trend was the case prior to the pandemic, so that is not just pandemic related. We do see that the expansion population is becoming more like the comparison group as time continues to go on. I wanted to talk a little bit about our COVID response because in addition to all of our special initiatives and in addition to our day-to-day job of administering a health plan, we've responded to COVID, and we have done that a lot. And so our general assistance falls into two categories, what we've been able to do for members and what we've been able to do for providers. We cover COVID testing. Over 150,000 members that we know about have been tested so far under main care. I will note that it's actually not easy to count these folks because so we partner with Health InfoNet so that we're not just reliant on our claims data, which is helpful to get a more accurate count. But I just learned that with our swab and send sites that have been great, but with the swab and send sites, health systems have been less likely to enter the data into their electronic health records, which means that we then don't have a great record of it in the Health InfoNet data or in our claims data. So that's my way of saying that we think these numbers are artificially low. This is what we're able to count, but they're conservative. And when you look at our testing rates, Johns Hopkins has a good website where they show a number of people per 100,000 who have received tests. And for the state of Maine as a whole, that number is at about 92,000 per 100,000 have gotten a test. For the main care population, based on the data we have, it's looking at like about 75,000 per 100,000. But a couple caveats. One, I already made, is that we know the data is not complete. Two is that we know we have more children and that children get tested at lower rates. And so both of those factors might be impacting the reason why our main care numbers look lower. Let's see, what else? I'll also just mention around vaccines, because that's what we're all talking about these days, that we are, for one, we are doing analysis of our members so we can identify individuals who are eligible for 1B vaccinations, including those who are at higher risk. And we're having conversations within DHHS to figure out how to best outreach those members, and especially for those members who may not have access to regular care. And so they're not likely to have their own primary care provider reach out to them to say, hey, you should be getting a vaccine now, if they don't have that provider. We are paying for vaccine administration. We are paying 100% of the Medicare rate, which for Medicaid is considered generous. We are already able to reimburse hospitals and physicians and EMS for vaccine administration. Next week, we should be able to additionally pay home health and federally qualified health centers We are actively working to be able to pay pharmacies as well, but there are systems changes related to all of these efforts, but we are making progress. We have offered in total just under $60 million state and federal in payment supports to providers since the pandemic started. We provided temporary rate increases to congregate care facilities as well as our home and community-based services. We had a $10 million supplemental payment to hospitals. There were a number of rate increases that initially were slated to go into effect last July, but because of the pandemic, we turned them on earlier for April, just to be able to get that additional assistance out there. We offered per member per month payments for behavioral health services that saw the biggest hits in utilization. We also offered a children's health incentive payment that paid a per member per month amount for kids who both got a wellness visit as well as a vaccine, or kids who got dental services. And then we also have ongoing rate increases for congregate care facilities that are experiencing an outbreak. One thing that we've been really proud of with our pandemic response is our access to telehealth. So we had a strong policy to start with, which I can take no credit for because it's been in place since 2016. But we are very grateful for it. And so we were able to immediately pivot to how do we enhance this access. We did that through things like enabling telephone only evaluation management, including triage for dental care, enabling telehealth for well child visits, prescriptions, including medication-assisted treatment. And we also put a lot of work into getting guidance out to providers. And we also had a media campaign that was targeted towards getting people more comfortable with the idea of telehealth. And so this is our trend. So even though we had a strong telehealth policy prior to the pandemic, we were seeing about 1,000 claims a month. And then you can see that skyrocketed to a peak in May of about 90,000 claims per, I just forgot whether this is actually per week or per month. I think it's per week, yeah, because the line changes. So it's per week. And you can see that since about mid-September to October, we're seeing a slight upward trend with telehealth utilization again, which makes sense as the pandemic has surged. We are one of the 2 top states in the entire country in terms of the access that we've been able to provide to children via telehealth. So you can see that Maine and Connecticut are the darkest red on this map, and that indicates, and this is a slide from CMS, that we've had the best outreach to our children members during this time. Similarly, we are in the top 5 states for adult access to telehealth, adults under age 65. For adults over age 65, we are more middle of the road for the most part. All right, now I'm going to switch gears to talk about our comprehensive rate system evaluation. So how we pay for the services that we cover is really our most important lever in order to ensure that members have access to high value care. So I have presented to HHS as well as AFA in the past regarding the complexity, the inconsistency, and oftentimes the lack of a clear basis for our current rate system. And I use the term system pretty loosely in this case. And so because of this, we felt it was a priority to really get our house in order in terms of ensuring that we have rates that support member access. We contracted with a firm called Myers and Stauffer. They are a well-known national accounting firm. They specialize in Medicaid and Medicare. First, we asked them to do a benchmark report to give us a baseline snapshot of how our rates for main care compare to rates for comparable services covered by select other Medicaid states, Medicare, and commercial payers. We asked them for recommendations on how to rationalize and streamline our system as a whole. We asked them to give us their recommendations on which services should be a priority, both in terms of rate adjustments, as well as services where we would need further study to determine what appropriate reimbursement would be. And then we also asked them for an implementation plan. So this slide here, first it highlights that we have done a lot of stakeholder engagement through this process. We have received feedback by more than 525 individuals and 270 organizations. That was through 2 rounds of stakeholder sessions that were mostly focused on providers, as well as 3 member sessions and a member survey. And that input has been critical. I will also note that our Main Care Advisory Committee had a specific rate subcommittee that we would meet with, connect with on a monthly basis throughout this process. So the benchmark report was released around November. If you Google Main Care rate system evaluation, you'll find the page. There are 63 comparison workbooks. So they're Excel files by category of service where you can look in and you can see how main care rates compare to rates by other payers. So this was really unprecedented in terms of transparency and the scope of the data that was shared. I do want to call out that this was not, nor was it ever intended to be, a study of underlying rate assumptions and economic factors across different states. To be the best sort of comparison, we would have wanted that kind of analysis, but that also literally would probably have been at least a 3-year endeavor. And so this was really intended to be a snapshot. We know that especially for services where there's more variation in terms of how a service is set up, this often comes up with behavioral health as well as home and community-based services, where the models aren't as consistent state to state, and also with how the payment model differs from state to state. Those are harder services to compare. And so what this comparison does is it tells us, sometimes it's straightforward and you can say, oh, we're definitely paying more for this kind of service. Sometimes it tells us it looks like we're paying more, but we're not really sure why. We can't really say whether that's appropriate. And so this is something that you really need to look into more. So this is just a little bit of data from the benchmarking report. Again, there's 63 multi-tab Excel workbooks if you're a data geek and really want to get into it. This is just showing, looking at that main care benefits manual section of policy, those numbers align with the sections of policy in that manual. This shows in the red is the top 5 services, or I should say the 5 service categories that compare on the low end with other payers. And then in the green are the services that compare on the high end with other services. So the comparison rate, what we did is we looked at 5 comparison Medicaid states, New Hampshire, Vermont, Connecticut, North Carolina, and Montana. If there was a Medicare rate available for the service, we averaged that in, and that is what we call the comparison rate. And then we said, how do the main care rates in these services compare to that comparison rate? And then the column on the far right was intended to control for the fact that sometimes you may have a rate that compares really high or really low, but we might not barely ever use it, right? And so we also asked the question that how does our current spending compare to what we would spend if we actually paid out at the comparison rate level for all of these services? And so that is the difference between those 2 columns. And what this shows you is the 5 service categories that have the lowest relative rates are at the top. And in general, they show that main care is paying about half on average the comparison rates for these services, which include dental services, PT, OT, and CRNA stands for Certified Registered Nurse Anesthetist, I think. And then in the green, you can see behavioral health, home and community-based services, as well as ambulance. As I said on the last slide, we know that it is more complicated to compare rates for community-based behavioral health services as well as home and community-based services than it is, for example, to compare physical therapy rates. So those services look high in comparison to the other states. I can say that for some of those services, we've recently conducted rate studies. And so we are confident that we are paying an appropriate amount for some of those services. But for other services, there may be additional study needed to understand why those rates are looking high and whether or not that is appropriate, because we know that other factors go into rates, like what is the minimum wage, and does the state have other sources of funding for these services outside of Medicaid, and questions like that. So the exciting news today is that our second deliverable from Myers and Stauffer, which is our interim report, has been released. And so Molly is going to share with all of you the blog post that DHHS put out this morning with a link to that report and its recommendations. I will say up front for some context that our initial plan had been that we would get these recommendations and associated estimated fiscal impacts prior to the biennial budget, so we would be able to consider that in the biennial budget that the governor proposed. COVID delayed the start of this contract and therefore the work and the deliverables, and so we are releasing Myers and Stauffer's recommendations now. We are not proposing that we incorporate these recommendations into the biennial budget. We're going to be reviewing the recommendations and make sure that we adopt as we determine is appropriate into a plan that aligns with our priorities, that aligns with the biennial initiatives we've already put forward, and that is appropriate with budget constraints. So what are the recommendations? They fall into two categories. I would say system recommendations. So how do we improve our rate setting system? And then secondly, what are the specific services that we should prioritize looking at for rate adjustments? So to start with the system recommendations, and some of these are common sense, but they don't reflect what our system does currently. So using consistent and rational bases for developing and updating rates. Where there's a Medicare service, using a consistent Medicare benchmark across services. Moving away from cost settlement. Cost settlement is administratively burdensome for providers and for the state. It also is not a methodology that promotes high value care. Moving more towards alternative payment models that do recognize and reward for higher value care. And then lastly, reviewing and updating methodologies on a regular schedule. So Myers and Stauffer recommends that for services that need rate studies, that we should do those at least every 5 years, and that we should also adjust for inflation and for updated Medicare rates every 2 to 3 years. Looking at services that Myers and Stauffer is recommending that we take a closer look at. This is just for year one. In late February, Myers and Stauffer's final report is coming out, and they will have a more detailed implementation plan for us at that time. But for the first year, one of the first recommendations is that we look at a range of services, PT, OT, speech, vision, podiatry, and most physician services, and say, let us reimburse those services at a consistent percentage of 2020 Medicare rates across the board. A number of those services you saw on the previous slide, we were at about half of the comparison rate. So it's they are definitely paid on the low side, and they're also paid in an inconsistent manner. I'll also say that if we reference 70% of 2009 Medicare, when there are new codes added to Medicare, which happens all the time, and we turn those codes on for billing and Medicaid, that means that gets an updated year in our system, which means that those new services get paid relatively higher than the old services. So even within a service group that's supposed to have the same benchmark, you end up with like a crazy range of percentages of Medicare. And that has an impact. We heard from providers who said like, oh, I choose to to deliver these specific codes because these codes are paid higher than these other codes, and it just warps your delivery system. So this is a recommendation that would essentially fix that. Another big recommendation is to update our dental rates to more closely align with median commercial rates. They are, as an example, preventive dental services are paid at about 45% of what we see for commercial rates right now. A recommendation is to prioritize community-based behavioral health services for further rate study. So again, this is an area where we seem to be out of alignment, at least at first blush with other states, but we're really not sure why, and we're also not sure whether it's appropriate. And so those are services where we should do rate studies to be able to have confidence that we're paying an appropriate rate. And then lastly, there are a couple of service areas for the first year, durable medical equipment and hospice, where we exceed Medicare in our payment right now. For durable medical equipment, that means we actually have to pay Medicare back those dollars for where we go over their rates. And so those are areas where Myers and Stauffer is recommending that we adjust rates downwards. So please check out the report for estimated dollar amounts where they're available and additional detail for those recommendations. I'm almost there, I promise. I'm going to wrap it up really quick. I just wanted to say that as with the administration as a whole, addressing substance use disorder is a priority. We have a number of exciting initiatives going on. We have a Support for Me grant that is really assessing and looking at ways to improve capacity for SUD treatment. Our Maine Mom initiative, we are partnering with care delivery partners across the state, including national experts on opioid use disorder care for pregnant and postpartum moms. And they are working to develop a system of care and a way for Maine Care to reimburse for that care. So that's a great project. And then lastly, our opioid health homes program, we have seen a 280% increase in members served under that program since January of 2019. And we are evolving that model later at the end of this fiscal year so that we have more flexibility for a Medicaid assisted treatment model only, as well as greater expectations for primary care integration and tying a portion of payment to performance. I've referenced our goals for moving towards alternative payment models, which do a better job of looking at value. So fee for service, the more you deliver, the more you get paid. That is a reward for volume. It is not a reward for quality or for cost efficiency. Changing to alternative payment models that look at cost efficiency and quality is the direction we need to go in. The department has a goal that Maine Care will have 40% of its payments tied to alternative payment models or APMs by the end of 2022. We have a great initiative right now that is looking at all of our different programs for supporting primary care and turning them into one comprehensive program for primary care that is also aligned with an initiative out of the federal government that is a multi-payer initiative. So Medicare, as well as commercial payers, hoping to get them on board in the state of Maine as well, will be a part of that effort. And we're also looking at our Accountable Communities initiative to hold those accountable communities accountable for downside risk as well. Whew. And that is it. So I've got 15 minutes left for questions. Thank you.
Well, welcome to a deep dive, which is actually a shallow dive into what Maine Care is all about. So obviously a lot to begin to understand and plenty of opportunities down the road as we get into the budgeting process to better understand the impacts of some of these changes. So we'll do again now, Michelle, while you recuperate a little bit, we'll go around the virtual horseshoe and collect a couple of questions from everybody, fully understanding there's no way in the world we can collect them and you can answer them in 15 minutes. So, but Molly is going to take on getting us answers or getting us some more of your time or some of your people's time. So let's start with Representative Zager. Have you got any questions based on this quick look?
Thank you, Mr. Chairman. Ms. Probert, I really appreciate that work. That was that was a very in-depth presentation and tons of work that it represents. I guess my question that I want to highlight was sort of touched upon by the Myers and Stouffer's slide that you mentioned regarding behavioral health. I guess my question is, what do you think the next steps are in bringing more behavioral health to main care members?
Okay.
Sure. So I think a step in the process is,
Michelle?
oh, am I not supposed to be answering?
Michelle, what we're going to do is we're going to collect all of the questions so that everybody has a chance to ask their questions. And then you can pick a couple to answer, and Molly will get the rest of us pointed in the right direction for getting answers. Sorry.
Clearly, I don't follow directions well, so I apologize.
Well, I don't want to give Representative Zager any privileges that he hasn't earned yet. So what about you, Representative Lemelin? Have you got some questions for folks at Main Care?
I have one question, I guess. I'm very familiar with Main Care. I have about 25 years experience researching them. I'm very fond of Main Care in the system, and I wish there were no waivers like for a wait list for like Section 21, and I wish there were more services for adults with permanent disabilities. But my question would be on the durable medical equipment. You're talking about lowering some of the payments for the equipment. I know of a person who needs durable medical equipment, and that person was denied the equipment because Main Care pays, I think it was $54, and yet the cost to the distributor was significantly higher, and sometimes just a few dollars higher, like $58. So they refused to supply the patient with the equipment. So I'm wondering if you're aware of that, and is this legal for them to be a Main Care provider like that and to refuse to provide the person with the equipment? Thank you. And I appreciate your time today. You did a great job.
Okay, Representative Stover.
I had my question answered from this morning regarding dental and the rate study, so thank you.
Well, you're allowed two more if you'd like.
I'm going to pass for now in the interest of time. Thank you.
All right, Senator Baldacci.
Thank you. I wanted to thank Ms. Probert as well for excellent presentation. A lot of information, a lot more information we're going to definitely want to have. I just want to hit a couple of points in terms of issues. One is what information do you have in terms of, there's some states that are looking into having people allowed to buy into Medicaid as a public health insurance option type of thing. And what are your observations about the obstacles that we would face or should address in Maine in order to have a public health insurance option available to people at an affordable price? I know there are some discussions going on, I guess, regarding small business and the rest of it, but I'm very interested in looking at the possibility of trying to allow people to buy into the Medicaid program. The other thing is, and I think it's excellent, the fact that we've expanded the Medicaid program and the state's share of the budget. The state spending on that has been fairly stable, even though we're serving a lot more people. I think that is excellent news for everybody in the state. I also, in terms of the temporary rate increases, I know that the governor has talked about continuing those. I'd like to know what the direction is on that. And just trying to see if I have any other questions.
I think that's your too, Senator.
Okay, thank you. I will shut off my microphone. Thank you.
You may have missed the invitation to send any additional questions to Molly and the analysts so that they can round up some time with the department down the road and get some answers in the meantime.
Thank you, Mr. Chairman. I will take advantage of that opportunity. Thank you.
Representative Perry. Where'd you go?
Well, I had to unmute myself. I was having a great conversation with nowhere to go. This is all very interesting, and it's been wonderful to see how the progress has been, even with the expansion and what we're doing. I'm really interested in what you're looking at as alternative payment models and how those might fit into other areas like hospital reimbursement and no, I've lost track of what I'm doing, but those kind of areas more than just the patient area.
Thank you. Representative Javner, did you have questions?
Thank you, Senator Claxton. Thank you for this presentation. Wow, it was amazing. Great job. So much information to take in. I just had a question real quick about the telehealth for dental. I know that at the beginning of the COVID pandemic and the situation that I had so many dentists trying to contact me about how they were going to service their patients. And I see that now MaineCare actually covers the telehealth. I'm just really curious and interested in the process of how that came to be. Was that through a rule change, or how did that come about? I'm happy about it, but I'm just really curious how that came about. Thank you.
Representative Meyer, do you want to jump in here?
Thank you, Mr. Chair. Thank you, Ms. Probert. That was really an excellent overview. We're grateful. And Representative Perry actually touched on the alternative payment models, which was what my question was around, and just more information on that, a better understanding, and then also specific there, value-based purchasing and just some additional information and education for the committee as a whole.
Senator Moore.
The disadvantage to going later in the group is that everybody's asked the really, really good questions. Thank you, Michelle, for your presentation. It was very, very informative, and there's a lot to the department, way more than people realize it is. I think the only other question I had, I love the alternative payment, and I'm very pleased that we've gotten the reports back with the recommendations. Is just wondering how much of the CARES fund actually helped to supplement some of the payments that have been made related to COVID. I think that's it. And to just understand.
Okay. And Representative Madigan.
Thank you, Ms. Probert. Great presentation, very comprehensive. I have a few questions. You mentioned in the folks you had contracted with to look at rate studies, that prioritizing community behavioral health was something you had to do. Do you have any? It would be great to get information on when you expect to do that and just how you expect to do that. I'm concerned about just the availability of services, particularly in rural areas. And for those services that have no comparable Medicare rate, particularly those that serve children, can I have more detail about how you expect to come up with a fair rate, since we can't compare it to Medicare? In the past, that's been unclear to me. And I think that there were some assumptions that were erroneous. The per member per month as an alternative payment method that was put in for July and August for behavioral health services, that kind of payment structure is an alternative payment method for some evidence-based programs. And I'm wondering, is that something you expect to continue or something that you see changing? And then finally,
well, that's like 4.
I know, but like I like
gave Senator Baldacci a bad time about it. Please submit it.
Just one more, I promise. Just one more. We often hear about difficult to place patients, that it's difficult for some folks to get discharges from state hospitals like Riverview or Dorothea Dix. You know, I'm thinking in behavioral health kind of thing, or even people that have a criminal justice history, that often it's difficult to find a residential placement for them. I'm wondering whether there's ever been any discussion about a waiver for those kind of things, because actually providing the kind of wraparound services that are necessary to keep both the patient and the community safe might be
Thank
something.
you. Representative Craven, do you have anything to contribute?
Yes, thank you, Mr. Chair. Thank you, Michelle. I have two questions. One is why didn't the CARES Act pay for testing for people who are eligible for main care? And the other thing is around value-based reimbursement as well, whether you were looking at, for example, bundled rates, and or if you could describe what you were looking at for value-based reimbursement. Thank you.
Thank you, Mark. Representative Griffin.
Thank you. Thank you so much for your presentation. I did have a question about rate reimbursement, but you answered it well. Thank you so much.
And my question was, I'm guessing that you've done some preliminary work with value-based purchasing to look at what's been done and whether what you have done so far, you know, whether there's been an improvement or not. What's been the impact of initial efforts to try and nudge the world that way? So I'd be interested to see what you had from data for main care. And with that, you have 2 minutes to pick one or two things to answer if you want.
Sure. Well, first I'll say that it seems like we should have a separate presentation on value-based purchasing because it's something that I love to talk about, and you all have lots of questions about it. So we should do that. Just really quickly, because it's an easy answer, I did want to clarify on the question about dental and telehealth that the dental board issued clarification that they were okay with remote care for sort of triage and assessment. And so what we were able to turn payment on for our main care was telehealth triage and assessment services, but not at this point because it's currently in discussion whether the scope is allowed for in the state of Maine. We haven't been able to pay for telehealth more broadly for dental care. I'm trying to see if there's another really quick question I can answer.
Maybe around reimbursement for testing. Michelle, I think Representative Craven had a concern that.
Yep,
testing
that's a good quick one. So part of the reason why the federal government is giving an enhanced federal match rate is to enable states to better respond to the pandemic. And the rationale is really that if we can get the federal government to pay for 70% of the cost for something, then that just helps our dollars go further. And so where we could get federal match for a Medicaid service, we went in that direction because otherwise we'd have to pay a lot more of those CARES Act dollars instead of a smaller portion of the Medicaid dollars. So it's really just a way of extending the dollars for further use.
Thank you, Ms. Probert. This has been great. I'd give you more time to answer more questions, but then I'll get in trouble with Molly and don't want to go there. So we obviously very much appreciate the time and energy that went into preparation for that and your depth of knowledge. So thank you very much. And we look forward to a special section on value-based purchasing and whatever else comes out of the questions that get submitted in addition to what's been passed in so far. So thank you very much.
Thank you for the opportunity, and Director Landry, enjoy. I'll see you all soon.
So we have a new person joining us. Welcome, Mr. Landry. I'll turn it over to Molly Bogart to do her introduction.
Yes, all right, marathon day, one more presentation to go. I'll introduce briefly Dr. Landry, who's our Director of the Office of Child and Family Services. He held a similar position in the state of Nebraska and also worked for Lena Pope House, was Director of Lena Pope House in, you're gonna have to remind me which city in Texas, Todd, somewhere in Texas. And we are so glad to have had him at OCFS for the last, I think, just about 2 years. And he will walk you through the office and what they do and answer any questions.
Great. Thank you very much. It's a pleasure to be with you, Senator Claxton, Representative Meyer, members of the committee. As Molly indicated, I'm Todd Landry. I'm the director of the Office of Child and Family Services. Been here about 1.5 years. So I came to this role in May of 2019, and did come from Texas, specifically Fort Worth, Texas. And prior to that, as Molly indicated, I worked in the administration of Governor Dave Heineman in a similar role in the state of Nebraska. So I appreciate the chance to be with you today to introduce to you the Office of Child and Family Services, as well as share some specific information related to COVID, as well as some of our policy initiatives. And if it's okay, Senator Claxton, I'll just jump right in.
What we've been doing, Mr. Landry, is having you do your presentation. And then when you're done, we'll go around and collect questions, giving you an opportunity to answer a few of them if you're able or have time.
Great, thank you. Well, let me go ahead and see if I can get this screen sharing to work. Molly, can you see that? Excellent.
Yeah. If you could move it to full screen, that would be great. I think that's Control L on your keyboard might send us there.
This is a PDF version, so I don't know. I can make it a little bit bigger, but then it's going to lose some of the context.
Yeah, maybe if you go up to view, there should be an option for full screen.
Thank you.
Or not. That's fine. This works.
All right. Well, if anyone has trouble with it, please let me know. We can I can try to switch over to a PowerPoint version, but in the interest of time, I'll go ahead and get started. I do want to just start off by saying that, I believe Director Probert's presentation on main care, this presentation might get a little bit wonky as we get into the weeds a little bit. And so hopefully it won't get too much so. I'll try to keep it as relatively high level as possible. However, if I do slip into any acronyms or anything that you're not familiar with, please yell at me or let Molly know, and we'll make sure that we spell things out or sound things out in case there are any of those acronyms. So the Office of Child and Family Services is vital. It is one of the largest parts from a total number of staff positions within the Department of Health and Human Services. Specifically, we currently have just under 800 total positions. That does include limited period positions. And I believe behind Director Probert, budgetarily, we're the second largest department or office, excuse me, from a budget perspective. And our North Star for OCFS, the thing that all of our components of the office shoot for and always want to focus on, is to ensure or help ensure that all Maine children and families are safe, stable, happy, and healthy. And we do that through a variety of pieces that are shown here on the screen. The one that oftentimes people associate with the Office of Child and Family Services is the area of child welfare, seeking safety, permanency, and well-being for all children. And we do that through the investigations of suspected child abuse and neglect, working to ensure the well-being of children by guiding families as they create hopefully safe homes for their children, and in some cases providing temporary care for children when needed. It's also important to note that within child welfare, it does also include our Office of Violence Prevention. The violence prevention area provides support and funding for domestic violence and sexual assault organizations across the state. The second area is Children's Behavioral Health Services, supporting Maine families and children to access high-quality, evidence-based behavioral health services. This is an area where, as I've described for some of you who are on the committee, in the last session. This is an area where, in many ways, I believe that we came into a situation in the past couple of years of rebuilding the Children's Behavioral Health Services array and continuum of care. That work has continued despite the challenges of COVID, and I'll share with you some information on that later in the presentation. A third area that has become of even more importance, I think, during the COVID pandemic is in the area of early childhood education and childcare. Childcare, of course, is an essential component and an essential service for Maine's working families. Overseeing the Maine's Child Care Subsidy Program, which provides direct financial support to qualifying families, is part of this, the efforts of this part of OCFS. Included in this also, though, is support for quality improvement in child care programs, as well as our Maine Roads to Quality program that provides technical support and assistance to providers. I will say both in the area of childcare as well as in the area of children's behavioral health services. These are both areas where there's a significant amount of overlap with the Children's Cabinet and the work of the Children's Cabinet. It's also areas where we have opportunities and have taken advantage of opportunities for partnership and collaboration with the departments of education and the departments of correction, respectively, in their areas of education and juvenile justice. And last but certainly not least is our children's licensing and investigative services. I know you heard this morning from our colleague or our sister office in DLC. Children's licensing and investigation services resides within the Office of Child and Family Services. So anything related to agencies that provide care for children, including child care providers, children's residential facilities, and homeless shelters, those are licensed and overseen through the Office of Child and Family Services through our children's licensing area. From an organizational chart perspective, this is a high-level chart view that shows some of the people that you may come in contact with at our leadership level within OCFS. I do want to point out two additions to this chart that came about in March of last year. The first of those is Dr. Adrienne Carmack. She is our OCFS medical director. The first time, I believe, in several years that OCFS has had a full-time medical director on staff. Dr. Carmack is in the Bangor area and continues to practice in her clinical work 1 day a week, but the remaining 4 days of the week, she is our OCFS medical director. The other position that I would point out is the Family First Prevention Services Act Manager, FFPSA. Christine Therio is new to that role. She also began in that role in March. She came to us from CDC, Maine CDC, and has been working on the planning and soon-to-be implementation of Maine's response to the Federal Families First Prevention Services Act. And again, in this presentation, I'll be sharing information with you related to Family First. And from a visual perspective, you can see a graphic that was done in partnership with the John T. Gorman Foundation around what we call our North Star. And so again, everything that we do at the Office of Child and Family Services is focused on helping to ensure that all Maine children and families are safe, stable, happy, and healthy. So there's a lot of information that we could get into on the basics of OCFS, but I decided that for today's presentation, what I'd like to do is instead frame our discussion around some of the policy initiatives that are going on, as well as some of the policy initiatives that this committee will be undergoing review of during the coming session. And so those are really going to be around areas of Family First. Again, that's the Family First Prevention Services Act that we'll talk about in a moment. Related to Family First are changes that we've proposed in the budget and the budget initiatives around alternative response program. We also have some pieces that will be coming to this committee related to early childhood education. So I want to provide some information on that, as well as the CWIS. CWIS stands for the Comprehensive Child Welfare Information System. For those of you who were legislators in 2018, you may remember that you authorized and provided initial funding for the development of this information system that replaces or will replace our 20-plus-year-old current information system for child welfare. So I wanted to provide an information or an update to you on CWIS, and certainly not the least of which wanted to share with you some specific information related to OCFS as it relates to our COVID-19 and pandemic response. So let's jump right in, and I want to start with Family First and specifically the Family First Prevention Services Act. Family First was passed by the federal government in 2018 as part of the Budget Reconciliation Act and was signed into law. Family First it really represents a very significant change in the way the federal government approaches funding to the states and to public child welfare agencies across the country around the area of child welfare and specifically prevention of children having to enter child welfare systems in our country. It really has two components, and they tie these components into Title 4E. So Title 4E that you see there in the middle arrow is the funding mechanism from the federal government for child welfare services. So that Title 4E is a federal entitlement, and Family First in this act significantly changed some of the ways that the states can draw down and utilize Title 4E dollars. And it really focused on two different components. The first component was around prevention services for children and families. And for the first time, the federal government was allowing states through this act, when they meet certain requirements, to be able to pull down matching federal dollars, currently at a 50-50 match basis, to prevent the placement of children into formal child welfare systems through certain approved, federally approved, trauma-informed and evidence-based services. So for the first time with the Family First Act, states now have the opportunity to draw down federal dollars to provide these very specific services in order to help prevent the entry of children into care. The second piece, which is just as important but sometimes not always discussed as much, is the aspect related to residential care. And the act includes specific requirements that the states now must meet as it relates to increasing the quality and appropriateness of residential care for children who are in the custody of the state. And you'll hear us refer to this as QRTP, or the requirements related to QRTP. These, as you can see there, are qualified residential treatment programs. And I'll share with you a little bit about what makes a residential setting a QRTP. But it's an important component because with this new federal act, the carrot part of this act, if I can use a carrot and stick analogy, the carrot part of this act is the ability of states to draw down new federal funds related to these prevention services. The stick component, if you will, of the act is that unless states can ensure that those residential settings now meet this new level of quality, states will no longer be able to pull down federal funding through Title 4E to support children or to pay for children and the costs associated with the children in those placements. So the Title 4E is a really important leverage here that the federal government is using with Family First and really includes both this carrot and stick approach, if you will. I know some of you are clinicians by background, and so we wanted to share with you what the real theory of change for us from the perspective of the state is around Family First. It really is about increasing the amount and the quality of preventative services that can sometimes make it challenging for at-risk families to maintain their children safely in their homes. And the goal, of course, with Family First is to increase these prevention services so that we can help families deal with the challenges that they may be facing, and most importantly, continue to ensure that children are safe in their care and in their homes, so that they can receive those supportive treatment and services with enhanced safety and positive parenting, with the ultimate goal that we want children to be able to remain safely in their homes whenever possible. So that's a little bit from a theory of change perspective. I want to talk first now about the prevention services aspect in the Act, in the Federal Act for Family First. It is very clear in the Act of the who, what, and the how states have to respond to this new federal mandate. You can read there what the eligibility is. And I think the key piece of this is that first bullet point. It is children who are at imminent risk of entering the care and custody of the state. And the only thing that may be keeping them from entering the care and custody of the state is the fact that we are now providing these prevention services. So it's not primary or secondary prevention. It's really what's known in the field as tertiary prevention, that last level of prevention services to try to prevent children from having to enter the care and custody of the state. There are two other categories of eligibility. One is pregnant and parenting foster youth who are already in the care and custody of the state. It's one of the few exceptions in the act about children or youth who are already in the custody of the state. And it also can apply for children who have exited foster care, either through reunification, guardianship, or adoption, but who are at risk of reentry back into care. So those are the three categories of eligibility of children for the Family First Prevention Services Act program. You can see there a listing of the services. It is absolutely key to note that these must be evidence-based, they have to be time-limited, they have to be trauma-informed, and for federal matching purposes, they cannot already be covered by main care or Medicaid. So I know earlier, I believe Director Probert talked with you about main care being a payer of last resort. That is always true except in these cases. So this act did establish a new payer of last resort as Family First or Title 4E, but only for these services and components of these services. It's also important to know where do we find these services? It's important to note that the federal government through the ACF, Administration of Children and Families, publishes and continues to update what's known as the Clearinghouse of Services and Programs. Those are the federally approved programs that states can use in order to provide these services. So it's not just any service. It's not just any service that the state chooses. It's services that are on that clearinghouse that the federal government maintains. And last, prevention planning. How do we go about doing this? The key component of that is the second bullet point there. A prevention plan, a prevention services family plan has to be completed. It has to indicate which services are going to be offered, and then that plan has to be reviewed and followed up at least every 90 days as part of the prevention services component of the Family First Act. I mentioned a moment ago about the services that are currently listed on the clearinghouse. As we build our plan and as we have built and developed our plan here in the state of Maine, they really fall into these four kind of big buckets of services: substance use disorder services, mental health services, parent skill building, as well as kinship navigator services. Interestingly, as of right now, the federal government on the clearinghouse has not approved any kinship navigator programs to be used in the Family First planning process for the states. So that remains still to be worked on by the federal government. However, in the areas of substance use disorder, mental health services, and parent skill building, there are services. And as you can see here, these are the services that are currently on the clearinghouse that we can access or potentially include in these prevention services plan. Most of these are already main care funded, which means main care will be paying for those services as they currently do. But in the case of these last two programs here of in-home parent skill building services, those are not main care funded. So these services, specifically parents as teachers and home builders, are two services that we can now access federal dollars for on a 50-50 match basis in order to expand in the case of parents as teachers or bring up new to the state in the case of home builders. So our plan is going to significantly rely on, from a funding perspective, these two new programs. One, again, is an expansion. The other one, in the case of home builders, is a new program that we'll be bringing up in the state of Maine. The second half, if you go back to that chart, and I mentioned the carrot and the stick, I mentioned the stick piece about being the residential treatment programs. So the way the Act is designed is in order for states to continue to receive federal Title IV-E reimbursement for these residential programs, those residential programs must now meet the higher level of qualified residential treatment programs. Without that, the state, as you can see here, stands to potentially lose the ability to pull down approximately $800,000 per year that we currently are able to pull down in Title IV-E dollars. Clearly, we don't want to leave any of those dollars on the table, so to speak. And so we have worked over the past several months under the leadership of Christine Theriot with all of our residential providers. I'm happy to tell you that every single one of our state residential providers on the children's residential side have agreed to move up to and progress towards QRTP status. So my credit and my kudos and my thanks and credit to them for agreeing to move up the standard of their program to these QRTP levels. What makes a QRTP is shown in this bottom block. You can see the different components that are required to be in place for a residential provider to be a QRTP. As you can see there, some of them are things that maybe some of our agencies and programs are already doing. Other things may be new, but they must be licensed and nationally accredited. That accreditation piece, national accreditation piece, is new for several of our providers. And so we have been working with them over the past year, including providing financial support for them to go through that accreditation, national accreditation process. They have to use a trauma-informed treatment model. We have to do fingerprint-based criminal background checks on all of the staff that potentially are going to work with children in these facilities. But you can read there the various components, and these are the pieces that we're working with all of our children's residential providers in order to come up to that QRTP status so that we can in turn continue to pull down the federal Title IV-E dollars to support the placement of those children who need to be in those settings. A few pieces around how we've gone about planning, beginning in March of this past year, March of 2020. And I should say we actually started this in 2019 with work with a number of stakeholders around the state. We did convene 4 specific stakeholder groups, and my thanks to literally hundreds of professional stakeholders, youth, and family members who have participated in these stakeholder groups for the past several months. We also convened internal OCFS meetings in order to work with staff as we began to plan on the Family First implementation. Collaborations were absolutely key, and you can see just some of the ways that we collaborated with entities around the state as we developed the planning for Family First. Ultimately, that led to a significant amount of data collection and analysis. We did fiscal planning around this. We ultimately led to a draft of a Family First state plan, and feedback was collected on that Family First draft plan. We're currently in the final draft and review process of our state plan before we can then submit it to the federal government. The federal government has to have the opportunity to review and approve the state plan. We intend to submit our plan to the federal government by the end of this month. At the same time, we will then disseminate that widely and publicly. We then were moving towards we will have to work with the federal government on approving the plan, but our focus then will shift towards implementation, including implementation stakeholder work groups and changing our OCFS internal policies once the federal government has approved that state plan. Training of staff is going to coincide with training on our new comprehensive child welfare information system later this year. And then we will also have to submit separately to the federal government a QRTP plan. Once we are done with our submission of the Family First state plan, it's our intent then to finalize the QRTP plan and submit that to the federal government at that point. So that's a little bit about where we stand on that piece of it, and what our plans are on providing that these new services in the state. I will say that as it relates to Family First, one of the things that has a direct linkage to it is ARP. For those of you who have been on this committee for a while, you know the ARP program has been in place for a few years now, several years. It is the Alternative Response Program, and there's a significant amount of overlap between ARP and Family First. ARP has done an excellent job through our contracted providers in many ways, but in some ways there have been ongoing concerns about the ARP contracts and the ARP services. And one of the most significant concerns that we've had about the ARP contracts is it does create disparate experiences of families, depending upon whether a report is referred to an ARP provider or referred into the district for investigation. These are specifically considered to be lower risk cases, and this was an alternative response for those lower risk cases. But it does mean that some families that are in very similar situations, some may be referred to ARP, some may be referred to a district for investigation. As a result of that, it has created some potential legal concerns about that disparate treatment, and we want to eliminate those disparities and ensure equity for all families. The other component of ARP besides the assessment piece has been provision of services to families. Now we have a new vehicle with Family First to be able to provide and pull down federal dollars on a matching basis to provide some of those prevention services for families. So there's an opportunity for us to change the way we have utilized the dollars that have gone to ARP and instead to refocus those on ways that we can maximize state resources by pulling down matching federal dollars for some of those services. So our proposal that's included in our budget initiative, and I know you'll have a separate session to talk about these specific budget initiatives, is to add 15 new casework positions. That would then allow us to take back the investigations and assessments that currently are outsourced to the ARP providers. At the same time, we would end those ARP contracts and we would redirect those funds to Family First programming. So specifically, this flow chart shows a little bit about how those dollars would be handled. When we look at our overall total Family First budget, we estimate on an annualized basis, it will be about $4.8 million. The good news is half of that comes from the federal government through matching dollars. The other half would be state general funds. We intend to pay for those $2.4 million in state general funds by using $500,000 of Children's Behavioral Health Service funds that link and tie into these services, and then a $1.9 million of redirect from ARP. If you look at the bottom half of the chart, the current placeholder in the budget is $4 million for the ARP services and CIP services. So we start with that $4 million annual budget. $1.5 million of it would go towards the hiring of the 15 caseworker staff on an annual basis. The other $1.9 million is redirected from the current ARP contracts into these services instead. And because of the federal match, this means that we can also reap a $600,000 savings in state general funds from that $4 million placeholder in the budget. So if we're successful in doing this, and if it's approved through the budgetary process, it means that we'll be able to now provide evidence-based, federally approved prevention services to families who need it. We'll be able to ensure that all families have equitable treatment around their assessments and investigations of child abuse and neglect. And at the same time, we're able to reap a $600,000 annualized savings in state general funds. In the comment box in the middle of the page there, I do want to point out cost savings are less in the first fiscal year, state fiscal year that we would do this for two reasons. One, we're implementing Family First beginning on October 1, and so that's beginning in the second quarter of the state fiscal year. The second reason is we plan to continue the ARP services through the end of the contracts in December in order to allow for adequate time for transition of services. So I wanted to make sure I shared this with you today because obviously it's an important piece of the funding question and an important part of our budget initiatives, but it all links and ties back into together around that overall plan that we have for the implementation of Family First and those Family First prevention services activities. I mentioned before the CWIS program. CWIS stands again for the Comprehensive Child Welfare Information System. As you can see in the first box to the left, this was approved by the legislature in 2018 and the legislature provided some initial funding for the CWIS system. In 2019, we went through the full RFP process for the development of the system. It eventually was awarded to Deloitte in the spring of 2020. And in April of 2020 through the fourth quarter of this year, we're in our system development component. I want to give a lot of credit to the team, both at Deloitte and within OCFS that have been working on this system development. That April timeframe, of course, occurred exactly when the COVID pandemic was really beginning to spread quite rapidly throughout the country. And so they had to shift, and really all of the system development has been done now in a virtual format with the team from Deloitte and OCFS working. They've done a great job in doing that under the leadership of Bob Blanchard within OCFS. As a result of that, we're on time, we're on budget, and scheduled for, as you can see there, training and implementation in the fall of this year and early 22, with ongoing then system updates, improvement, and maintenance. Wanted to give you that update, number one, from a general perspective of CWIS, because I know this committee has heard prior presentations on the CWIS system. The other reason is I indicated in that first bullet that in 2018, the legislature approved the project and provided initial funding for the CWIS system. One of the budget initiatives that we have this year that's in the governor's budget is to fully fund the remainder of the development cost of the CWIS system. Again, this is not because the project is over budget. It's not. It's on budget, actually a little bit under budget right now. It's on time and on schedule, but the way the budgeting process worked in 2018 means we now need to come back in order to fund the remainder of the development of the system. So I'll move on now from child welfare and instead talk a little bit about children's behavioral health. It's my belief that if we get children's behavioral health right and we can increase our capacity for an effective early childhood education system, hopefully many of the challenges that we sometimes see in the child welfare system can ultimately be avoided. But that's going to take some significant work as we continue to try to rebuild the children's behavioral health system. Last year, I shared with this committee our improvement strategies. Those strategies all continue and have continued during the COVID pandemic, although very honestly, some of these challenges have been made that much harder during the COVID pandemic because of the challenges related to it. You can see there our short-term as well as our long-term strategies. Those are the same strategies that we shared with you last year, and those are the same strategies that we continue to focus on as a department and as an office. Many of these have a significant amount of overlap with our colleagues in the Office of Main Care Services, because many of these services, as all of you I believe know, are funded primarily through Main Care, and so there's close coordination between the two to work together. I want to point out just a few specific pieces related to our behavioral health initiatives. The first one is some good news that hopefully all of you heard about last year. We did compete for and receive a federally funded 4-year, $8.5 million federal grant. It's called a System of Care grant using the federal DHHS language. This grant is really designed and aligns perfectly with our initiatives that I shared with you a moment ago to improve the behavioral health services for children and families in our state. In our first year, which we began in the fall of last year, so we're in our first year of the grant, it is focusing initially on 3 of our historically underserved counties from a behavioral health perspective of Aroostook, Penobscot, and Piscataquis counties. And you can read there some of these specific components related to the system of care grant that we are implementing. But we are looking forward to the full implementation of this grant over the full 4-year period. It will expand to all counties in the state, and will continue to be reported on through these opportunities as well as through other public opportunities as well. A second piece I wanted to give you a quick update on from a behavioral health perspective is LD 997, which is our Early Childhood Consultation Partnership Program. LD 997, passed by the legislature in 2019, provided legislative authorization and funding to implement an early childhood mental health consultation program in 5 pilot sites. In 2020, we researched and selected an evidence-informed model. We also conducted the RFP procurement process for vendors for those 5 sites. Those were awarded in the 4th quarter of last year, and the implementation of these 5 pilot sites begins this month. We have provided regular updates through the Children's Cabinet to the Early Childhood Advisory Council. I know some of your colleagues sit on that advisory council. We'll continue to do that, but we're looking forward to implementing this program, evaluating the program, and then sharing with you those evaluation results, as it could be something that we want to possibly replicate across the state. And last is, but certainly not least, focuses around children's residential. I mentioned our work in partnership with Director Probert and Main Care Services. One of the ways that we have done that is through a rate study. First time, I believe, in at least 10 years of a rate study around children's residential services. That rate study is in progress right now, and the budget does include a placeholder for a potential rate increase. I will say that with this rate study, we're also increasing the components related for these residential providers to move to a QRTP status. And so the rate study will be prospective from that perspective, as well as looking at what their current costs are right now. But it's a good example, I think, of the way that our 2 offices have collaborated and worked together towards ultimately the implementation of not just the new rate, but also the new quality standards associated with QRTP. That also links, of course, back to Family First. I'd like to move into, a little bit regarding childcare and a few specific things that are going to be coming before this committee as it relates to childcare and childcare licensing. We have implemented a new comprehensive background check rule for licensed childcare providers. As many of you may know, and as we reported last year to you, beginning in 2014, the federal government passed an update to the Federal Child Care Development Block Grant that included new requirements for the states to meet. Since 2014, the state of Maine had been out of compliance with those new guidelines, and we were potentially subject to an $800,000 annual penalty for being out of compliance with those guidelines. We worked diligently over the past year and a half, and I'm happy to say last fall, with the implementation, including these new comprehensive background checks, we have now come back into compliance with the federal law and have received formal confirmation from the Federal Office of Child Care that we are in compliance and we are no longer currently subject to the penalties that were initially assessed on the state. This rule does add some significant requirements around pre-employment and pre-licensure. The most significant of those are background checks. Background checks now have to be done with fingerprints, and we have to do those through the Federal Bureau of Investigation as well as the State Bureau of Identification records. It includes, background checks now include the National Crime Information Center Sex Offender Registry, as well as some other components. This has been a challenge for some of our providers. We have worked and provided financial as well as technical support to the providers to assist in that implementation. We are paying 100% of the cost for these background checks, including the increased costs related to the federal fingerprint checks. That is just one example of the ways that we tried to work with providers to implement this new process. Associated with this is a couple of provider licensing pieces. We do have proposed rulemaking. The major substantive components will be coming before this committee to replace our family child care license rule with a new rule that is necessary to fully comply with the federal requirements that I mentioned a moment ago. It includes some new provisions necessary to meet federal requirements related to health and safety needs of children. It includes the background check component that we talked about before. It also adds a requirement to register with our professional development network and Maine's quality rating improvement system. Similarly, a second proposed rule, we currently have two other rules. One is for child care facilities, what sometimes we call centers or larger centers, as well as we have a licensing rule currently on the books for what's called nursery schools. We are proposing to repeal both of those and replace them with one unified child care facility licensing rule. Again, at the same time, putting in place changes to come back into compliance with the Child Care Development Block Grant, as well as those health and safety components that I mentioned a moment ago. We also have proposed some changes to add some clarity and transparency around some language and to ensure some consistency in licensing requirements. Again, the major substantive components of those will be coming forward to this committee, and I'm happy to share more information at that point in time, but did want to let you know the background and context for these rule changes. It is in large part due to coming back into compliance with that the federal requirements, so that we are not in a situation where we're subject to a significant, as I said before, $800,000 annual penalty. And finally, I want to share with you a little bit around COVID responses. As you have heard from all of my colleague office directors, and as you heard from Commissioner Lambrou this morning, much of our work over the past 10 months has been focused around COVID and pandemic response. One of the most significant ways that the Office of Child and Family Services has partnered with that effort is in the area of childcare. Maine did receive approximately $11 million in the spring through the Federal CARES Act, and this was processed through the Federal Child Care Development Block Grant that came to the state. Of that $11 million, about $10 million of the funding went directly to child care providers through stipends and grants. We did that in 3 waves of grants to the providers. Happy to say that 98% of our providers, 1,645 of our programs, received at least one. Most of them received all 3 of these grants. In addition, 47 licensed exempt providers also received funds through the first of those 3 grant initiatives. But it is one of the ways that we were quickly able to provide direct financial support to child care providers, as well as to qualifying essential workers with child care subsidy, regardless of income, that was in place from April to June of this year. Now, in addition to the Child Care Development Block Grant CARES Act money, the governor also made available an additional $8.4 million of coronavirus relief funds, CRF funds. These had more specific requirements as required by the federal government. As a result of that, not as many of our providers were able to qualify for these CRF funds. However, 579 of them did qualify, and they received over $2.2 million in reimbursements under the CRF initiative. So from a financial perspective, we have provided over $13.2 million of financial support. The vast majority of that went directly to child care providers, although some did go to essential workers during the early weeks of the pandemic. In addition to the financial support, OCFS has provided ongoing monthly guidance to child care providers regarding policies and procedures. We have done those in conjunction with our partners at Maine CDC in order to ensure the latest and most accurate health and safety information is provided to our child care providers. My credit and all the credit and kudos to our child care providers on doing a fantastic job across the state in adhering to these proactive safety and health measures in order to keep the children in their facility safe, the families of those children, as well as the staff who work in those centers. The good news is, through the most recently enacted federal relief bill and Consolidated Appropriations Act, we are anticipating receiving over $30 million in additional CCDBG funding through that relief bill that was passed at the end of December. We're currently working with our partners on developing goals for the use of these funds, and we are working with our other 5 New England states to learn from each other and to potentially develop some common frameworks around the distribution of these funds. No final plans have been developed, primarily because we have not received any formal notice from the federal government of exactly how much of the funds we are going to receive, nor have we received any notification of any of the conditions that are going to be placed on these funds or requirements for the distribution of these funds by the federal government. We hope that we're going to be receiving that information soon with the new administration, but at this point, we are having to wait for those guidance and details to be issued to us from the federal government. I do want to share with you a little bit of data related to childcare and the COVID pandemic. We have been reporting on this on a routine basis through our COVID dashboards in the Department of Health and Human Services. This chart shows the number of providers who were closed at any given point in time from mid-March until the first week of 2021. And as you can see here, during the early weeks of the pandemic, and I think it's important to note that the state of Maine did not require our providers to close, but they had the option to potentially close based on their unique needs and situations. During the early weeks of the pandemic, about 50% of our providers did close. Beginning in May, we began to see a gradual reopening, and then in the summertime, a significant reopening. And for most of the summer, we reached a point where 80% of our providers were back open or had remained open. Once school started in the fall, you can see we saw a significant increase in the number of openings, and we were down to approximately 5% of our providers that were closed for most of the fall. We have seen a bit of an increase over the past few weeks, although that did dip back down again in the first week of 21, as some of the providers have had to close whenever they've had a situation of a positive COVID test among their staff or children in their care. And that has sometimes resulted in them having temporary closures. As of the first week of the year, we were currently at 94% of our providers that were open. This does not mean that they're open at full capacity. Some of them have had to reduce capacity for a number of reasons, including reducing some of the numbers in classrooms, as well as some of the challenges that they occasionally have regarding workforce. But I will say, versus other parts of the country, we were able to maintain a higher percentage of our providers open during even the early weeks of the pandemic, and we were able to more quickly see more providers reopen during the spring and the summertime and into the fall. And as of most recent data, we're still tracking at a higher percentage of our providers open versus national averages. And again, in large part, that goes to great credit not only to our staff who have worked with the providers, but also the providers themselves who have done an outstanding job of adhering to good safety practices during the pandemic. From a child welfare perspective and the pandemic, I wanted to share with you a little bit of information of our response. And we've divided it up on this chart in various components. Our intake staff, beginning from the very first weeks of the pandemic, 100% of our intake staff are now working remotely and have been working remotely for the past several months. This does not mean that we've had any decrease in the ability to answer calls and inquiries related to suspicions of abuse and neglect. That call line remains open 24/7, and our staff are monitoring it and answering those calls on a 24/7 basis. That hotline number is 1-800-452-1999. It is, of course, manned 24 hours a day, 7 days a week. In addition to that, from an investigation perspective, we are conducting pre-screening prior to any in-person meetings. At the beginning of the pandemic, for the first few weeks of the pandemic, we did have a two-tier process for investigation. So areas of the state where there was higher levels of community transmission, those investigations were primarily being done on a virtual basis. But since June, all of our investigations are now being conducted and have been conducted in person, unless the pre-screening questions indicate that there's an issue with potential COVID infection, including individuals in the household testing positive. But since June, all of our investigations returned to an in-person basis. Similarly, our monthly contacts with parents, children, and with our resource parents, in the early weeks of the pandemic, we did shift those to a virtual format. However, again, beginning in June, we resumed those on an in-person basis. And those are being conducted, again, with the use of that pre-screening safety questions. So again, if there's an issue related to COVID infection in the household, we obviously are not going in those cases on an in-person basis, but instead reverting back to virtual format. And a very important component is family visitation. That's a critical component from an ongoing basis of child welfare practice. Those in-person visits were suspended during the early weeks of the pandemic. We did continue to support those visits through phone and video conferencing. And then again in June, in-person visits did resume with safety precautions in place. So the same pre-screening questionnaire that we're using in the other areas, we're using in these situations. But for the most part, many of those in-person or virtually, most of those in-person visits have all resumed and have continued to be on an in-person basis since June. I do want to point out that we did work closely with our colleagues in the Department of Education in order to develop and share guidance with teachers and staff and professionals who were working with children on a virtual format. We developed specific guidance for them to help them identify signs of abuse or neglect while they're interacting on a remote basis. And we've closely monitored our data to watch our trends as it relates to some of the key child welfare measures. And I'd like to share some of those with you. This first chart shows all OCFS hotline calls. So these are all of the calls that come into our hotline. And as you can see, the dark blue bar represents 2018, light blue 2019, red 2020, and then we have the one dot for the first week of 2021. And as you can see, when the state of civil emergency was put in place in mid-March, we did see this decrease in the number of calls with a bit of an increase after we issued guidance to teachers and other school personnel through the Department of Education. But since then, it has tended to trend lower than the prior 2 years, or in the case of the first week of 2021, the prior 3 years. It's important to note that hotline calls encompass a variety of different kinds of calls. Certainly, allegations or suspicions of abuse and neglect is one component of the calls that we receive on the hotline. But a significant number of calls that come in are resource and referral calls, consent to treatment calls, or adult protective services calls. So when we disaggregate this total hotline call volume to just look at the number of calls coming in for allegations of abuse or suspicions of abuse or neglect, you again can see a decrease during the first few weeks of the pandemic after the state of civil emergency, a pretty significant increase after we issued guidance to teachers and school personnel and other professionals working with children in a remote environment. And since the summertime, you can see this red line, or in the case of the orange dot there, it has trended about the same as we have seen in prior years. So since the beginning of summer, essentially, we have generally been in the same rough ballpark numbers. So I know there have been a number of concerns, both nationally and locally, about reductions or a concern of a reduction of number of reports of abuse and neglect. Certainly we saw that in the early weeks, but since the summertime, we have seen in our data about the same number of calls of suspicions of abuse and neglect relative to the other 2 or 3 years. I do want to share with you also some child welfare data on the number of children in care, and you'll be happy to know I think this is my last slide to share with you. in the early weeks of the pandemic, and certainly through really the summertime, we did see an increase in the number of children in the care and custody of DHHS. During that time period, as many of you know, there were challenges in the court system related to how they were going to proceed with court hearings, whether those be reunification cases, adoption, permanency guardianship cases, or other type of hearings. We worked closely with Acting Chief Justice Meade as well as Chief Judge French on an ongoing basis to work on some of those challenges. And we also continued a significant focus around permanency and exits to safe permanency as well. And we really began to see the benefits of much of that work in the fourth quarter of this past year, when we began to see a decrease in the number of children in the care and custody of the state. This was not really due to a decrease in the number of entries or the number of investigations. It was really an increase in the number of safe exits to permanency. We are now currently, as of mid-January, at 2253 children in care of in DHHS custody. That is above where we were a year ago when we were at 2213, but it is worth pointing out it is lower than where we were in mid-March. In mid-March, at the beginning of the civil emergency order, we were at 2,280 kids. As you can see here, we're below that now at 2253. And a tremendous amount of credit to our OCFS staff for continuing a focus around permanency, but also credit to our partners in the main judicial branch, as well as other partners, in order to ensure that we're continuing to focus on permanency for children in care, even during the challenges of this pandemic. So with that, I will stop sharing my screen, and I thank you for your attention for the past hour. I know you have many questions, and I know we went into quite a bit of detail in this that you may have follow-up questions on, and I'm happy to follow your process, Senator, as far as the question and answer section here.
Thank you, Director Landry. Appreciate that. I'm sure the committee wants to ask some questions, so we'll just handle this the way we have been and start with Representative Griffin. Have you got a question or two for Director Landry?
I do not, but thank you very much for your presentation. It was very good.
Representative Connor isn't with us. He's doing one of his other committees. Representative Craven's back.
Thank you, Mr. Chair. Thank you, Dr. Landry. That was a good report. I don't have any questions at the moment. Thanks.
Okay. Representative Madigan, do you have two questions you'd like to ask?
Thank you. I have a couple questions. As far as the initiatives that are based on the Families First Prevention Services Act, it looks like you're getting rid of, phasing out the alternative response programs and adding staff, anticipating that they will pick up those cases. Is there, I guess I would want to see more information, because it seems like 15 staff that you anticipate that you would have to hire to cover what ARP has been doing doesn't seem to me to be enough. So I mean, so I have a question about that. And then the other piece is the MST. We've talked about kind of MST and FFT, and I'm really glad to see that the federal government has authorized then parents as teachers and home builders and some other things, in a list of their approved services. And I would love to hear more about your initiatives to start bringing those into the state. So.
Thank you. Representative Zager.
Thank you, Senator Claxton. Dr. Landry, thank you very much for the presentation. I do not have any questions, but I thank you for the tremendous work that you and your folks are doing to keep our children safe, engaged, and having bright futures.
Representative Lemelin.
Thank you, Senator, and thank you for the presentation, Mr. Director. I have two quick questions. One, do we have programs in place to keep potential children off the custody list? In other words, preventing some children from ever being under DHHS care, protection care. And the second one is, you mentioned with the $4 million annual budget, there was a $600,000 savings to the general fund. What would be that amount if it was a $3 million annual budget? Would there be any savings still? Would we take a loss, break even? Thank you very much. Again, great presentation.
Thank you. Representative Stover?
I just want to thank you, Dr. Landry. The content today and the new information, it feels almost transformative from where we were a year ago. Unfortunately, COVID brought a lot of those resources, but the good news is the resources came and more are coming, the 30 million. So thank you very much.
Senator Baldacci.
Thank you. Thank you, Dr. Landry. That was quite a presentation. There's a lot to digest there, a lot to unpack. I don't think one afternoon can do it. I've been doing custody cases for almost my entire career, including dealing with the Department of Human Services in these child protective cases since probably the early 90s. So I have a lot of familiarity with the entire process. One of my major issues that I'd like to get into a deeper dive on is the kinship placement issue. I'd like to look at historical numbers on child custody going back at least until the last 10 or 15 years. I think that one of my major concerns in these cases has always been to either avoid or minimize the child's need for foster care and to find a family placement as quickly as possible. And my experience in those cases is that there's kind of it's uneven depending on the caseworker, depending on the court, depending on who, where we are with a number of different things. So that is one area I'd like to have follow-up discussions with you on, or get some additional information. Kinship placement issue, and because there's a specific statute that gives, for instance, grandparents and other relatives priority, and how that is actually implemented. So I just wanted to share, it's not so much a question as to let you know where one of my areas of concerns are that I'd like to discuss with you, and also get as much information from you as we go over the process over the next few months. That would be helpful to me. Thank you.
Representative Perry.
I would say that, first of all, thank you for the presentation, and you answered a lot of questions I started out listening to. So I really appreciate that, and I have no further questions right now. Thank you.
Representative Javner.
Thank you, Senator Claxton. Thank you, Dr. Landry. We appreciate the presentation today. I had questions about the kinship numbers as well. Just curious how those have been throughout the last year. And thank you to your department very, very much for getting the face-to-face visitations up and running again very quickly. As you can imagine, we received many calls and emails concerning that during this process. So thank you.
Senator Moore.
Yes, thank you very much, Dr. Landry. It was a very, very good presentation. I wrote down a couple of questions, and I hope I didn't miss them that you have already answered. That was asking how many residential across the state, and how many beds actually work.
Could you repeat that question? Your audio tends to break up.
I don't understand. Okay. What I was curious about is how many, and you may have answered this question already, Dr. Landry. I just was curious how many residential facilities we have across the state, and how many beds, how many children can be accommodated in those across the state. Thank you.
Thank you. Representative Meyer.
Thank you, Mr. Chair, and thank you, Dr. Landry. Excellent presentation. I'm wondering, since your CPS workers are back doing in-person visits, are they in the queue for vaccines? And another question I have is what's being done to work with both DHHS and the Department of Education to support children with behavioral and IDD who are receiving services from both of those departments? I'm told that sometimes providers and kids kind of get caught in the middle of that.
And my question was about the transition from the private non-medical to the qualified residential treatment plan, and a better sense of how many dollars there are to support that transition for the entities that are trying to do that. I'm delighted to hear that everybody has signed on to that, but I know they're going to need some help. And then the other question is that a lot to bite off at the same time that you're launching the CCWIS in the late this calendar year? So those are the range of questions that the committee offers. Would you like to take a run at a few of those without feeling obliged to answer all of them?
Sure. I appreciate it, and I will try to answer a few of those, and I'll try to group them into a couple of different components. I know there were a couple of questions as it relates to kinship care, and so let me just give you a little bit of context on that, and then Senator Baldacci, as you indicated, we can certainly do more information and share more information as we go forward. It is the practice, the policy that we have within OCFS, that if a child cannot be safely maintained in their home and they have to be removed and taken into custody, the first preference is to find a safe member of the family or extended family for the child to be with. And so that is the preference. But to Senator Baldacci's point, sometimes there are a number of factors that sometimes make that appear to be potentially inconsistent across the state. You mentioned the court process. That's certainly part of that process. I will also say that sometimes I think we do have some inconsistent practice among our different districts in the state. That is an area of focus of ours to work on. I believe many of you know that last year in February, I think it was February, maybe early March, in an agreement that we made with the Judiciary Committee, but it also impacted the HHS Committee, we agreed to do a number of town halls, open public forum town halls around the issue of child welfare. We had intended to do those in person, of course, back in February. That, of course, wasn't possible. So we did switch over to a virtual format, and all of those forums were, in fact, conducted this fall. I believe all of you should have received, or for those of you who were on the committee last year, should have received invitations to those forums. And then last month, we did issue a report with the help of Professor Shinna Burnell at USM Farmington. She helped us facilitate those meetings and put together a report on the outcomes of what we heard from those town hall calls and public forums. I mention that because one of the consistent themes that we heard on those calls was a concern about consistency of practice around the state. A consistency of practice certainly with our caseworkers, but also consistency of practice with courts and with judges, consistency of practice with guardians ad litem, consistency of practice with providers. And so that consistency of practice that I heard you at least mention, Senator, is certainly something that we have to focus on and continue to focus and work on. Through our cooperative agreement that we initiated in 2019 with the Muskie School, one of the things that they're helping us to do is look at all of our policies in order to make sure that they are up to date, that we're training appropriately to those policies, and that we're looking at those policies from an equity lens to ensure that we don't have any inherent issues in our policies that would lead to disparities and disproportionality in treatment of children and families. So I hear what you're saying about some inconsistency of practices. Sometimes that does not lie, of course, within OCFS, as you indicated, whether that be the court system, guardian ad litems, et cetera. But sometimes it is within OCFS, and it's something that we are focusing on. I will simply say on the last topic on relative care, we currently sit versus the beginning of actually it goes back into 2019. In reports that we have provided by agreement with the Government Oversight Committee, we have been tracking the number of resource families as well as the number of kinship families. We actually have now more kinship families and more resource families than we did before the pandemic. And that is something that we're quite proud of, and is great credit to everyone who had to switch to remote training and virtual training in many ways for those families. But we do have more of both of those categories than we did even before the pandemic. And our number of placements with relative caregivers, kinship providers, if you will, has remained basically flat during the entirety of 2020, pre and post-pandemic. About 45% of our children that are in the custody of the state are placed with family members, kinship family members. That's something that I think is a good thing, because and that's slightly above national averages. National averages are in the low 40 percentile, so we're just a little bit above that national average, but some would argue that we're statistically in the same range. But we have about 45% of our kids in care that are placed with kinship families. So we can go into a lot more details about the kinship families, but that's a little bit of information that I wanted to share with you on that.
I appreciate that very much. It's been very helpful. Thank you.
One other thing that I will mention real quickly is that you, I believe, also asked, that I want to talk about as it relates to some questions on Family First. Certainly, the big focus, and I see as one of our greatest opportunities, is utilizing Family First with these new resources of federal matching dollars and a more comprehensive way of documenting and following up on prevention plans with families, is to increase the number of kids that we can safely keep out of the care and custody of the state. If we can keep kids safe with their families, with the addition of some of these services, that is certainly what I think, I'm hoping we all will agree upon, is good for kids and it's good for families. Ultimately, that's what we're shooting for, as well as the back end, if I can use that term, of kids who exit care. We want to make sure that they don't come back into care. And that is one of our key measures that we look at. We post those results on a monthly basis on our key measures site on the OCFS website. But ensuring that success and permanency also happens, that's the other place that I didn't spend much time talking about, that I think these prevention plans will really help us to increase the number of those successful placements out of permanency and prevent those kids from having to come back into the care and custody of the state. Couple of things that I think I heard questions on that I'll try to address is related to Family First. So Representative Madigan, I think you had a couple of questions. As it relates to the 15 caseworkers, I can tell you for the past 7 to 8 months, not including the time period of March and April right around the pandemic when there were other challenges, but outside of that time period and from before the pandemic, on average, we have about 150 referrals a month to, if my memory serves correct, and we'll confirm that number for you, of referrals to ARP providers for assessment purposes. So 15 caseworkers is, in our opinion, the right number for those number of assessments that we would be taking on. So that's how we came up with that number. We're happy to provide you with more details about the calculations on that. And then as it relates to the either increasing or new services that we're going to bring in through the Family First planning process and the Family First implementation. The good news, as I showed on that one bubble chart, is most of those services are already in place to certain degrees within the state of Maine, with the exception of home builders. Home builders will be brand new, and so we will be working with providers around the state over the course of the next several months once we have indications from the federal government that they're approving our plan, to bring in training and to train providers on the use of home builders and implementing home builders, so that we'll have that in our arsenal of services beginning in the fourth quarter of this year. From a parents as teachers perspective, that is a program that's already in place in the state of Maine. It's actually managed through CDC on a contract with Maine Families, I believe, and we have worked with them, and this will enable us to use federal dollars in order to expand that program to add more families that they can serve. So the intention on parents as teachers is a little bit less of an uphill climb because it's already there. We're just going to be expanding it and adding more to their staff capability to be able to serve more kids and families. Home builders will be brand new. So that'll be a ground up operation that we'll be looking at there. And then real quickly, two other points that I'd like to make as I look through some of the questions. First of all, Representative Moore, we will get you the specific number of children's residential facilities and the specific number of bed spaces or capacity that they have. What I will tell you is we have seen since COVID and since mid-March, we have seen a slight reduction in the capacity of beds that children's residential providers have. And that is very logical when you take into account that they've had to take into, make plans for in case a child, for example, tests positive. So they need to have a quarantine spot or an isolation spot. So in some cases, for some of our providers, that means that they've had to rearrange their physical configuration so that they can have an isolation area for those kids who have tested positive without impacting potentially, hopefully, the other kids. So we have seen a reduction during the pandemic of the amount of capacity that our children's residential providers have. We'll get you that specific number, but we continue to work with them on an ongoing basis. We certainly support their need to create those changes for whenever that situation happens. We've been very fortunate. I think we've only had 3 instances since March of any of our children's residential providers having a classified outbreak of COVID in their facility. And so we've been very happy about that. We've seen very few, fortunately, children and youth in their facilities test positive. That's been positive. And great credit to them. They took very seriously the safety and health precautions that we gave them guidance on with the support of Maine CDC. We provided technical assistance to them. They implemented that, and we have seen the benefits of them doing that. Now, certainly it helps that the data generally shows that children are less likely to be infected or to have a positive case of COVID. But nonetheless, we know in some of our other states, including right here in New England, they've had a much more difficult time in keeping the infection rates low. I will share with you on that topic that as it relates to COVID positive cases, since the beginning of the pandemic, since mid-March, we've had, roughly around, call it 2,300 or so kids in care. I don't have the exact unduplicated number for you right now, but what I can tell you for sure, a total since mid-March, 53 children in care and custody of the state have tested positive. Total. So that's total from the beginning of March. And I believe when you do that calculation, that's actually lower than the percentage in general of children and youth in the state of Maine who have tested positive. Again, great credit to our providers, great credit to our resource parents, great credit to everyone involved to keep those kids as safe as possible during the pandemic. I can also share with you from middle of March, from the beginning of the pandemic, since we've been tracking this, a total number of OCFS staff that have tested positive is 25 total. So again, versus our total 780, nearly 800 staff, that's a relatively very small percentage. And again, great credit to them for adhering to our safety and health precautions in order to keep themselves safe and to keep our colleagues and others safe. I will say, to no surprise to all of you, about 85% of our staff are working remotely or dispatching remotely. That was in place in the very early weeks of the pandemic. that has certainly continued over the entire 10 months that we have been dealing with pandemic response. And then if I may, I will just simply say, one of the questions I believe from Representative Meyer around CPS caseworkers and our frontline staff from a vaccine perspective. As you heard, I know today from Director Shaw from NERV of where we stand. I know we all wish we had more doses of the vaccine that we could be giving out and making available to people who want that vaccine. I can tell you there's a large amount of interest among our CPS caseworkers, caseworker supervisors, and others who are dealing in the field and working in the field on a daily basis. I've heard that loud and clear from them. There is a category in Phase 1B for frontline essential workers. It's certainly my belief that our frontline staff, our caseworkers and caseworker supervisors will be in that category. But as you know, there's more work to be done on fleshing fully out that category and how the processes are going to work with that category. But certainly that is what I have advocated for and what I continue to support. Again, there's a lot of other categories that we got to get through before we get to that part of Phase 1B. We're still in Phase 1A, as you all know, and then there's priority categories of Phase 1B, including those over 70, those over 65, and then those that have an underlying medical condition. And so it's going to be based on our current thinking and projection on amount of vaccine available, it's going to be, unfortunately, at this point, a bit of time measured in weeks versus days before I think we're going to be able to get to the phase in 1B for frontline essential workers. So with that, hopefully I've answered some of the questions. I know Molly has helped to capture those questions that we didn't get to or that I missed. Be happy to make sure that we provide that information after today's call.
Thank you for all that content. Thank you for the presentation. That's much appreciated. By now, the committee has a reinforced sense of how capable the directors are in DHHS that we've had a chance to hear from today, and thank you very much for that. I'm going to thank Molly for putting this together, and I think I'm going to release the committee to go about their lives. It's only been how many hours of Zooming? We're not in practice yet. We need to ramp up our skills. And then several of us are meeting on a separate Zoom to work on the schedule. So thank you all for your attention.
Senator, can we mention next week before you let everybody go?
Sure.
We just want to make sure that everybody knows what's happening on Tuesday, because you don't have the weekly yet and you won't have it until tomorrow. But we just want to make sure that you should have gotten your invitation today for appropriations, which starts at 10 o'clock. But in addition to that, you'll get one from Kerry. Luke will do the hour-long to walk through the budget with you. So you will have a 9 o'clock with HHS first. And that will be a different Zoom call. And also just a reminder that we've been instructed to remind you all not to share the link that you get for AFA, that's link is for you alone. And other than that, just to tell you that we do know that we'll be meeting Tuesday, Wednesday, Thursday of next week, but you will get the weekly later on. That's all I wanted to say. Thank you, Senator.
So thank you, Anna, for pointing that out. So unless there's something else that needs to be done right now, I think we'll close down this meeting. I see a couple of things in chat that I hadn't seen before. Okay, so I think we got those.